प्रस्तुति करेंगे। Mother
Yeah, live.
So good morning, all our friends from AIOS and MOS. Welcome to the second day of the show, and to run the first amazing session of cataract, we have our moderators, Dr. Anaga Herur, who is the Honorary Secretary of MOS and the Director of Anil Eye Hospital. And along with her, we have Dr. Rajesh Joshi, who is the current Chief Editor of JCOR and a Professor of Ophthalmology in Nagpur. Over to you, Dr. Anaga and Dr. Rajesh.
Yeah, thank you so much, Dr. Vardhaman. And welcome everyone to the second day of the MOS Midterm Conference. It was an excellent and fantastic session yesterday evening, and I hope everybody would have enjoyed the 2-minute videos also. Today we will be starting the day with the cataract session, and I hope we were looking forward to a great session as yesterday. So we'd like to welcome our chairman, Professor Dr. T.P. Lane sir, who would be joining us very shortly, and Dr. Santosh Bide sir from US. Dr. Lane sir, as we all know, is the guiding light for all of us for so many years. He's been the force behind the Maharashtra Ophthalmic Society as well as the BOA, and he's been a mentor to thousands of ophthalmologists all over the country also. And Dr. Santosh Bide sir, our glorious president of the MOS, has been very, very energetic and enthusiastic, and he has been the force behind this conference as well as all our activities. We would also be having all our expert panelists, the young experts as well as the senior experts. Among the young experts, we have Dr. Nikita Tripathi, Dr. Akanksha Thakkar, Dr. Niket Gandhi, Dr. Ameya Kulkarni, and Dr. Prashant Birla, who will be giving their pearls of wisdom and their inputs for all the topics and the presentations. And among the senior experts, we have Dr. Praveen Vyavhare, Dr. Shubhangi Pimprikar, Dr. Sohail Khan, Dr. Sanjay Rasal, and Dr. Jagannath Boramani. So we are looking forward to a great session. Over to you, Dr. Rajesh Joshi. And before that, we would like to ask Dr. Santosh Bide sir to say a few words.
Just a minute. Just a minute. Give us a minute.
He wants a link again. Okay.
Yeah. Can you send it?
Yeah, I'll send it.
So till that time, maybe we can have Dr. Rajesh ji to talk about.
Yeah.
So in Maharashtra Ophthalmological Society, we have a new team for JCOR. Professor Rajesh Joshi is editor JCOR. And this year he has planned to release 4 issues of JCOR in a year. And we are going to have release of second issue of JCOR now. And I request Professor Rajesh Joshi to say a few words regarding JCOR. Over to you, Dr. Rajesh. Dr. Rajesh, you can share your screen.
Good morning, everyone. At that side,
Sir has joined actually. Yeah? Welcome, Professor Lamu, sir. Yeah.
Yes.
Yeah, JCOR release केलंय.
Welcome, sir. Welcome, sir.
Welcome, sir.
Welcome. चला सुरू
good morning,
करतोय.
sir. Good morning, sir.
मी जॉईन झालोय अनघा आणि संतोष मी जॉईन झालो.
Yes, sir. I just sent you the link. Okay.
Good morning, sir. Respected Lahane sir, Santosh Bide sir, President MOS, Chairman Scientific Committee, Dr. Vardhaman, all the advisory members of MOS, editorial members of JCOR, advisory members of JCOR. In fact, it's great pleasure for me to bring out the second issue of JCOR. In fact, it is before time that we are releasing this issue. This is the fresh look of the cover page of JCOR. You must have gone through the first issue of JCOR, and it was very well appreciated, everyone. I take this opportunity to mention one of the articles from Pune, which was written by Dr. Arti Pasule, which has become very popular in very short duration. And here I feel proud to tell you that it has crossed almost 8,000 issues worldwide. And I'm trying to increase the indexing of the JCOR as well as number of the articles. We need to have almost 25 to 30 articles, original articles, which are citable one in a year to go into PubMed indexing. So that is the one which is remaining. So, and my aim is to bring JCOR to PubMed. Now, I will not take much time and request Lahane sir to release second issue of JCOR.
Thank you very much. I think you are doing a very good work, and this issue has came very early than the time decided. So I really congratulate you and all the editorial board members. And this issue is now, I think, inaugurated and open for the now distribution. And I congratulate once again to everyone. And as we are going for the indexing, our articles are getting published, and even the original articles are coming to the JCOR. That is very good, but credit of this is goes to first to the BK Naik sir, and then now Joshi, who is really doing very good work for this. And MOS itself as now having done excellent journal, and it should be of the equal to the like an Indian Journal of Ophthalmology, and one day we will be equal to that. My best wishes to you. Thank you.
Thank you, sir. Thank you so much for your inputs. We will take it further so that our journal becomes a worldwide. So these are the few articles which will be published in the journal. We have articles all over the India as well as from the world also. So these are a few glimpses. These are all original articles, as well as we have brief communications also. So important and rare case reports will be published in this issue. So I think I will circulate to everyone once this gets released.
Yes. Excellent.
Thank you, sir. Thank you. So I think we will go to our session.
Yeah.
Dr. Santosh Bede sir, a few words from you, and Dr. Lahane sir.
Lahane sir has already said.
Yeah.
And Dr. Rajesh Joshi has taken enormous efforts, and I'm sure that with his efforts, we will definitely get it become an index journal, and there will be a lot of students also sending their PG thesis as a free paper. And during our annual conference at Kolhapur, we have kept a special session for PG thesis. So the best paper can be released in our JCOR. And in fact, yesterday's one of the case by Dr. Snehal Thakre, in fact, I have requested her to send to JCOR as it was a rare case. There was some cutaneous association along with myasthenia, ocular myasthenia. So it's quite rare. So I have requested her to give preference to JCOR over IJO.
Yes.
So I'm sure with all this, this thing will be. So let's begin our cataract session. Over to you, Dr. Anaga and Dr. Rajesh.
The first video is by Dr. Ashish. He's MBBS from GMC Nagpur, MS from Minto, Bangalore. He did his retina fellowship from Irvine, USA, and current practice is at Uttam Hospital, Nagpur. His talk will be on IOL power calculation in radial keratotomy patients. I request Ashish to share his screen.
Thank you, sir. A warm good morning to everybody. Thank you for this opportunity. I'll be talking on IOL calculation in RK patients. So I had this patient, a 65-year-old female with no history of prior surgery, but I realized that she had undergone 8-incision RK surgery in the left eye, and the right eye, she had undergone an ICCE, that is like a refractive exchange without IOL implantation. It was a very old surgery. And on IOL Master 700 as well, we can see that her K values are lower, her axial length is higher, and it means some kind of refractive surgery she has undergone, but her corneal thickness is high, this is 600-fold. This means the radial keratotomy surgery was done. Now the scan is done in RK mode, and in this mode, the fixation is absent, and hence the axial length is unreliable, and K readings are also unreliable. The astigmatism reported is very low. Now, I need two things to calculate the power of cornea. I need the radius of curvature and the refractive index. And as we know that if we have the refractive index and radius, we can use the lens maker's equation to calculate the power. Now, the radius of the refractive index of the cornea, it changes according to the tissue at which the refractive index is measured. We take an average of 0.376, and we ignore the posterior corneal curvature, the contribution of this to the refractive index, and hence we assume the refractive index as 1.375 in our routine calculations. Nowadays, it is possible to measure the posterior corneal curvatures, but previously it was not possible, hence this correction was done. Now, if you look at the distribution of K values, RK patients, we realize that the range of RK values in the range of K values in post-RK patients can be as huge as 30 parameters compared to a normal population data. Problems in RK is that the optical zone, the central part, can be very small. This results in sudden steepening of the peripheral zone. So we have a small optical zone, a flat central, a steep peripheral area. We have altered anterior and posterior corneal curvature. Refractive index is changed, and so it is difficult to know the corneal power. Also, the effective lens position causes shallowing of anterior chamber that underestimates the IOL power. Now, this is how K value is measured in IOL Master. It uses telecentric 3-zone keratometry at the smallest zone of 2.5, and OCT-based technology estimates the posterior curvature using the points that are projected using the LED diodes. But let's say that this is the keratometry measurement points, and what if our RK incidents are positioned like this? Now you can see that all these points are not aligned to the RK incisions. Using image analysis, I have designed these incisions so that they cross the exact center dot that you see on this image. So in order to understand what is the real astigmatism, we need a circle instead of the dot that the IOL Master is projecting. And this circle is available to us with our auto-FK, the auto-refractometer that we have in our clinic. But the problem is we'll miss out the central blue area, which is the area at which the patient has great vision. It is not affected by corneal scars, but it is not imaged by the key powers using the IOL Master as well as the auto-FK that look at the IOL. If you look at the auto-FK pictures, you would realize that there is a lot of variation in the Myers, and this reveals us that the astigmatism level is high. It is not 0.38 as it revealed by the IOL Master. So the central cornea can be flattened in RK in a variable manner because the number of incision, the optical axis, the depth of the incision, everything varies according to the surgeon. So in summary, we did not get anything from the IOL Master. To know the radius of curvature, we have to use tomography because it is the only instrument that will measure both anterior and posterior corneal curvatures, and it has no central scotoma. If you look at the data of accuracy, it sounds impressive that the OCT-based technology or the Schlein-Plug technology gives us a very accurate 0.5 diopter variation in about 60% of the patients. But the other way to put this data is that 1 out of 3 or 4 patients is going to land up with some kind of hyperopia of about 1 diopter. So the best formula to use in RK is a Barrett's true K or a Haggis suite. But Haggis suite has the advantage that it accounts for the effective lens position. Barrett's true K total keratotomy formula is pretty accurate if it has the pre-RK and the post-RK refraction value. This patient also has fixation. So the eccentric visual axis will generate an angle kappa, which will be huge, and it will be disobeyed by the IOL, which is going to sit centrally on the back. In general, RK patients, they are not very good candidates for other type of IOLs, the trifocal, EDOFs, or even toric. This patient, obviously, because of the eccentric axis, the RK itself, we have no option but to use a monofocal. Cornea, we will have to understand that all the keratometry measured points would be generated from an eccentric axis. The axial length will be also eccentric. So this is the fixation variation of the patient in octave K. By asking the patient to look at the light, you can observe that the Mayas are having huge variation. This kind of error would get replicated even in tomographers. So how do you proceed? Because the Barrett's formula is giving us an IOL power of 18 diopter. Using the ASCRS website, which measures the posterior corneal curvature, I also found that the results are similar. The Barrett's true TK formula was not working in IOL Master because it had obtained an error in the calculation of axial length. This is, I feel, a unique advantage because the IOL Master will not allow you to use the TK formula unless it has fixation. And that tells us that the K values are inaccurate. And hence, even if you try on this machine to get the TK value of the formula and try to calculate the IOL power, this is not going to reveal you the IOL power. So this is the surgery. I'll speed it up. I think it has been covered by another talk. So
I think you will need to conclude now.
We decided to implant an IOL after aphakic refraction, and a 22 diopter IOL was implanted because the refraction was 11, and I landed up with a 2 diopter of astigmatism. So I would also like to say that the N value for my patient, the refraction index, I can go back on the ASCRS website and know the N value, which is 1.368, provided my axial length is.
Can you please conclude, sir?
Yes, thank you.
Yeah.
Yeah. Thank you so
what
much.
is the take-home message?
Yeah, very nice talk, Dr.
Please talk,
Archie.
Thank you, sir. Thank you very much.
Yeah, very nice talk. Actually, just I want to narrate that amongst the all corneal refractive procedure, I think the RK is the most notorious one because here you cannot predict the IL power exactly. So for these patients, we have to do a pre-op consult. And whenever you go for a premium lenses, then the expectations of the patients are high. So you have to do the counseling properly. So if I give you a choice amongst all the formulas, you have IL Master 700, right, Dr. Ashish?
Yes.
So have you tried the total keratometry TK with routine universal direct formula?
In routine, I did not get your question, sir. Do you mean?
Actually, a Barrett IL calculation formula with total keratometry also works fairly well in these cases. So you can have you look at that also.
The Barrett's total keratometry formula did not work in this patient because fixation was not obtained. So the instrument disallows us to use the TK formula for this scenario. So I had to go online on the ASCRS website and enter the data.
Can I request everybody, because we are short of time and we have to stick to the time. So please conclude with one line take home message from this presentation quickly.
Yeah.
Sorry
So,
to interrupt you. Sorry to excellent presentation.
no
All
problem.
excellent pearls of wisdom you have given. But because of paucity of time, we have to stick to time. So just conclude by giving one-liner echo message. So in RK patient, we have to do dash. That's it.
I would go for clear lens extraction, and then I would plan secondary IOL based on the manual refraction after 2 weeks. Thank you, sir.
Dr. Nikita, Dr. Nikita Tripathi.
Yes, ma'am. Sir, just want to ask if you don't have IOL master for normal A scan people, what formula you'll prefer? How you'll go ahead? Those who don't have IOL masters, and which formula? Anything
Dr.
to
Praveen,
calculate?
Dr. Praveen, you can just answer that.
Yeah, actually, whenever you
I think his net is a little poor.
Yeah, it is a problem. Anyone else can take that.
Dr.
question?
Ashish, yeah.
Yeah, I
want
what my
do a
presentation is
you
about.
want
This is about like not finding
to do a
the answer
calculation,
in
or is it
IOL master and then going for manual refraction. That's what I'm suggesting. In RK, just do manual refraction for plain excision, and then you can implant the IOL. And a barometer, it has 90% accuracy. And it is an intraoperative instrument which tells you what the aberrations are. It tells you intraoperative what IOL power you can implant. You can also do that manually. So there's no need to buy that barometer, which has the best accuracy. If you do a refraction, that is going to cover for all the errors. So my suggestion is just do a manual refraction. Either do it intraoperative. I choose to do it 2 weeks because the refraction intraoperatively is going to change. In RK patients in general as well, if you look at the refraction, they are going to have hyperopic variations throughout the day. So it is better to have them at a stable refractive position of the cornea about 1 or 2 weeks after surgery, and try to do multiple manual refractions and try to find the worst hyperopic refraction and then implant the IOL power 2 times of the manual refraction. That is my suggestion.
Okay,
I think we need to look at a case-to-case basis, and then more the number of cuts, it becomes more unpredictable. So I think we will move on to the next speaker. Thank you very much, Dr. Ashish. So our next talk will be by Dr. Gajanan Bhagat. He's an excellent surgeon and a great academician. He'll be speaking to us on topical phaco in uncooperative patients, tips and tricks. Can you please start sharing?
Yeah. Hi, good morning all. I would like to thank the... Hello? Am I audible?
Yes, I can hear you. Yes, please start sharing.
Please share the screen. Gajanan, please share.
All the, especially Dr. Joshi sir for giving me the chance. I'm going to talk on my favorite topic, which is a topical anesthesia phaco in uncooperative patients. There are some tips and tricks. Is my screen
No, we can't see your screen.
Gajanan, you need to share the screen.
Yeah. Just a minute.
Yeah. Yeah, we can see your screen. And presentation.
Sorry.
Yeah, make it full screen.
Yeah. My topic is topical phaco in non-cooperative patients. Which of the factors which gives rise to this type of condition in our operation theater is anxiety of the patient, then hard of hearing, one-eyed patient, excessive moment, intraoperative complication like meiosis and iris touching, like hard cataract and semi-dilated pupil. As all of you know, the available drugs which are now in the market are no financial interest in this. Lignocaine 1% weight by volume in the name of injection Oculan and injection Zylox. But in my OT also, I use Lignocaine 2% weight by volume, which is a vial, injection Loxigard. So with all aseptic precautions, we remove just 2 ml from this vial and use in some of the cases. Above all, preparations are preservative free, and we can take 2 ml of injection Loxigard in syringe with all aseptic precautions. I just want to share my video of few patients. Can you see my video?
Yes. Go ahead.
Yes.
Yeah, this is one patient which I started in my operation theater, and suddenly he was uncooperative. I started in topical, so I injected little bit of xylocaine 2% at 12 o'clock subconjunctival, and then still there was a moment. Then I started to fixate the eyeball. I have plugged this conjunctiva at 12 o'clock with the help of tooth forceps, and I started my surgery. That was one type of fixating the eyeball and making the patient stable and still. There is one second video. If the patient is still, is not again uncooperative. Second. This was one video where the patient was still very uncooperative. This is a patient of second patient. So I have put some 2% xylocaine at 12 o'clock in subconjunctival region at 12 o'clock, and then I have taken a superictus in this case under topical, which is possible, and I'm doing so many cases under topical with superictus. So just keep a watch on the pulse of the patient. There should not be any bradycardia, as it may lead to the vasovagal. So as it is under cover of anesthetics in my OT, it is quite possible. And once you take a superictus, the eye becomes very stable, and it is very easy to go for the phaco. And I'm showing the next video of the same patient where I'm doing a phaco. Yeah, this is this one. Sorry. So this was the phaco which I am doing. Here is the superictus, and I'm catching the eye with the help of tooth forceps. This is a single entry phaco I am doing routinely in my OT. So there is no need of second instrument, and we can easily go ahead with topical phaco with phaco probe. So this was again a very good surgery, and after completing the surgery, we can easily after completing the surgery, keeping a watch on the pulse, we can easily cut the superictus thread and complete the surgery as of it. So these are some few videos. So the take-home message of my presentation is the proper selection of patient for topical surgery is very important. You are selecting the patient, because nowadays every patient we are operating in the topical. Always be calm and cool as much as possible during surgery. Try to minimize the duration of the surgery, as it is better for surgeon and patient also. Always be ready to convert from phaco to SICS in a very tricky situation. So keeping aside your low ego of all these things, once you decide with full dedication, you can operate any case under topical anesthesia.
Yeah.
So, thank you.
Thank you so much. An excellent presentation. Dr. Sanjay, your thoughts, please.
That was a nice presentation, actually, doctor. I want to ask one question regarding the ocular akinesia. In the case of uncooperative patients like this, whether the only subconjunctival preservative-free injection will be sufficient to get a good akinesia in uncooperative patient?
Yeah, I have done a quite patient.
I thought.
Sir, only subconjunctival xylocaine can work, and also if we are in a very short of time or patient is panic directly, we can take superictus with the help of local superficial anesthesia like paracaine.
Taking the superior.
What I would advise you to take a subconjunctival or posterior subtenon bout of a xylocaine, preservative free or with preservative doesn't make difference, to get a akinesia, good akinesia. The moment you see the patient, uncooperative patient, while evaluation of the cataract surgery, like doing keratometry or immersion biometry, you see that the patient is not very helpful or cooperative, then you have to plan the surgery accordingly. If you feel that patient is not very cooperative, better to avoid topical surgery. That is a take-home message one I would like to highlight. Another thing, taking superrectus under subconjunctival injection is a little risky. superior rectus middle suture. So better to have a posterior subtenon injection to get a good akinesia and then take a middle suture.
Okay. Thank you, sir.
Dr.
Another
Shubhangi, your
point
thoughts?
I would like to add here, Anaga, give me 1 minute. Another point, he said a single port phaco. That was a wonderful case he showed. But without chopper, how you can manage a nucleus of a grade 3 and 4 with the single port phaco?
Yeah,
In uncooperative patient.
I have got the presentation of single entry. We have broken the cataract in bag in 4 pieces, and then we have taken every piece from the bag, and with the help of single entry.
That is beyond this particular topic, you know.
I think
Single-handed phaco for hard cataract is beyond this particular topic. So let's not discuss that here.
So
Because
actually,
what he has shown is that you have to you have to stabilize the globe. If you are doing topical, take-home messages, by some method you have to stabilize the globe. Point well mentioned that instead of giving subconjunctival block, you can give a posterior tenons block and then take a superior rectus suture. Only point, there are some patients who are great squeezers. They try to squeeze eyeball, and because of Bell's phenomenon, the eye rolls up, and then it is a really tricky situation. And in such situations, taking a superior rectus suture and stabilizing the globe can help you. So it can bail you out of the situation. That is the point for this.
Good counseling of the patient is helpful. Must.
Yes.
Dr. Shubhangi,
as Dr. Bhide sir pointed out Bell's phenomena, I always make it a point to put local anesthetic eye drops in both the eyes of the patient so that both the patient becomes more cooperative. And I would not agree to the point that convert the patient from phaco to SICS. Instead, you can always give subtenons and make the patient comfortable.
Yes.
So converting a non-cooperative patient from phaco to SICS would land up in a more troublesome situation than giving block. So keep your ego aside, tell the patient that end result is more important than doing it under topical. Give subtenons, a wonderful tool in the armamentarium of any surgeon. And I think those who have done a retrobulbar block would not be scared of giving a subtenons at all. So bilateral Paracane eye drops is a wonderful tool. My anesthetist always puts a speculum to the patient. We reduce the light intensity as the patient, and then only we start. And counseling throughout the surgery.
Yes.
Definitely.
Throughout the surgery.
And we can always assess the patient whether he's cooperative on slit lamp, whether he's cooperative on biometry. So there are so many stages before surgery that you can assess the patient, and always tell the patient that end result is more important. Topical many times turns out to be a market strategy than the surgeons or the patients.
Even the second instrument in the side port also actually helps to stabilize.
Absolutely.
So bridal suture may not be actually required. With the second instrument only you can stabilize the globe. And if you hold that the limbus too tightly, you can cause subconjunctival hemorrhage or even tearing of the conjunctiva. So you need to be careful. I think we are falling short of time. I know Dr. Jagannath sir has raised his hand. Quickly, sir, in 10 seconds, if you can make your point.
Yeah, no, I want to come in because I have been doing topical SICS, which is supposed to be more difficult. And I am the first surgeon to start topical SICS. Generally, under topical anesthesia surgery, the pain is only when you stretch the zonules. Otherwise, most of the parts are insensitive. As far as the superior rectus is an unnecessary trauma to the eye. Thirdly, for the counseling of the patients, especially for uncooperative patient, to make the patient comfortable, do some procedure in OPD, which is a contact procedure, like contact biometry or the contact tonometry, and ask the patient whether he had any pain. He will definitely say no. So then you explain him that the surgery will be exactly similar procedure. We'll be putting same drops and doing the work. We will not have any pain. So patient become very comfortable. And thirdly, which is very important, which has happened to in one of my pterygium patient, under topical anesthesia, there is no block, patient keeps seeing the light. And if the patient stops seeing the light, sometimes topic can reach up to the optic nerve, patient stops seeing the light. Suddenly, because patient doesn't know what is happening, patient may feel that the surgeon has cut some important nerve, that's why my vision is gone, something like that. One of my patient under pterygium surgery, under topical, he went into vasovagal attack on table because he stopped seeing light. So every patient you tell that though you are seeing the light may go for some time. You just explain the patient. This is very important. Thank you.
Good
Yeah, thank
inputs
you.
from everyone. I think
Very
we'll
good.
move on to the
Good
next.
points.
Dr. Rajesh.
Sorry to
Nothing-
disturb you. I want to take only 1 minute. I am doing 99% cases under topical in my institute. So the take-home message is you should always have anesthetic cover along with the patient, because in under topical anesthesia patient, there are high chances that patient can go into vasovagal at any stage from the start to end. So this is my
Yeah,
suggestion.
anesthetic standby is good for even for
It's a legal
patients.
requirement. It's a legal requirement.
Legal requirement,
Even
but
for
your
a peribulbar
anes-
also you can get a vasovagal.
anesthetic should be 100% aware during the whole
Right.
cycle.
Yes.
Yes, sir.
Yeah,
Dr.
very
Rajesh.
well. Yeah, that was really a wonderful presentation, Gajanan. If nothing works, then verbal anesthesia top up may work at the
Thank
end.
you. Thank you.
So, our next presenter is Dr. Sarika, who is a wonderful surgeon and owner of Indovision Eye Center, Pune. She has received numerous awards, including Health Influencer of the Year, then WS Inspiration Award, and has received Top Doctors of the Month. With this, I present to you Dr. Sarika.
A very good morning to everyone, and thank you so much for the MOS office bearers for the opportunity. It was a very well managed and program. So it's virtual, so we all can actually attend it and present our work. I will be talking about the challenges in cataract surgery with prior radial keratotomy. Yes, so we know that RK was very popular 2-3 decades ago, and now we are seeing these patients coming with cataract. So these patients underwent RK 30 years back because they did not want to wear glasses. So today they are coming back to us because they have cataract and they are wearing glasses. So they want to get rid of glasses as well as get rid of cataract. But are we able to do the justice to their demands is the question here. So the major complications that I went across in this patient was the difficulty to achieve the perfect IOL power, and also the challenges in terms of the corneal integrity because of the likelihood of the incisions to gape and dehiscence. So preoperatively, we know that our photography is not very accurate for post-RK patients, and IOL power calculation has been covered very well by Dr. Ashish. So here, in this case, patient was willing to undergo multifocal, trifocal, but what will be your selection? We wanted to aim for a good outcome post-operatively. So I decided to put in a monofocal lens. So I'll just quickly show my video. So yes, this patient had 16 cut radial keratotomy, and
Doctor, video is not shown. You need to stop and reshare.
You have to stop this presentation and then share the video.
Open video and then start sharing. No, you have to open video and then start sharing. First open the video, then start sharing.
Yeah.
No, we can't see it.
Shared, we can't see it.
Dr. Sarika, you need to share.
Yeah.
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 You can see it, yeah.
You can switch off the volume.
So then we
the video.
Yeah, we can see it. Please go ahead.
Yes. Yes. So the main
Play it.
So it is played.
It's not playing.
But it is just
Sarika madam, your video is paused.
Click on the play.
Okay, I'll just do it again.
the screen had come, but it was not playing. So just
you have to play the video. You do again, you open the video, then share.
Okay, now is it playing?
Yes, yes.
Okay, sorry.
It is playing, don't worry. Yeah.
So while taking the incisions, we need to be sure that we are not making the corneal incision at the RK cuts. So the main incision was planned in such a way that it was not coinciding with the RK cuts. Same with the side ports. We ensured that the main incisions were away from the RK cuts. You can already start seeing that the side port incisions, the previous RK cuts have already started gaping. Then even during the phaco procedure, a low pressure of the fluidics was maintained so that there are no sudden intraoperative pressure changes which would lead to a more wound gaping. If there was a more wound gaping, we would have actually had to take a suture to stabilize these wounds, and then we would have to continue the surgery. But this surgery went very uneventful, and these RK cuts did gape after the procedure was over and took good 4 to 6 weeks for all the epithelialization and reconstruction. Now, during the IOL power calculation, we did estimate a hyperopia, which does occur with these patients post-operatively. So a number which was closest to 1 and minus 1.5 was chosen. Also, and there was no suture needed during the surgery.
Dr. Sarika, will you please sum up?
Yes.
The time is over almost. Yeah, that was a great video.
Yeah, now open your presentation and reshare and then sum up.
Okay. Now the presentation is visible, right?
Yes, yes, it is visible.
Okay, thank you, sir. So, yes. So intraoperatively, these were the things that we took care of. And yes, post-operatively, hyperopic shift and the refractive surprise was what we did not want in this patient. So a meticulous preoperative topography and keratometry was done. IOL power calculation with Barrett's 2K and the ASCRS IOL calculator was done. And the powers which were most accurate, which was more repeatable, those were taken so that a good post-operative refraction with no refractive surprise, and patient is having a good vision post-operatively instead of putting a multifocal and having a bad post-operative outcome. We went ahead with a monofocal lens and gave the patient a very good vision. Patient was 6/6 unaided, but this vision is after 1 month of surgery. Post-operatively, yes, there were some fluctuations that we know it happened because of the cornea reacts very differently in these patients.
Yes.
So yes, thank you so much.
Wonderful presentation, Dr. Sarika. Amay, quick your take on this.
Yeah. Thank you for this opportunity.
You do something different.
Very good presentation, Dr. Sarika. There are certain things that I would like to talk about. First and foremost, we all know that most biometers will measure at 3.5 mm, and you have a central zone of 3 mm in these patients, or sometimes less than 3 mm. So there is always an overestimation of the keratometry in RK patients. There's something called as an adjustment method that not the first speaker and not even you have mentioned, that if there are 4 cuts, you should add the 0.5 diopters to the IOL power that you calculated. 8 cuts, 1 diopter. If there are more than 8 cuts, you have to add about 2 diopters to your final IOL power. And thank you for not choosing a multifocal. Please do not even talk of multifocals when it's a patient of RK. Sometimes there is no role of even, I think, toric IOL in RK, because this is an irregular astigmatism. All you will end up is flipping the axis and creating problems for the patient. And otherwise, a wonderful presentation.
But I think the ASCRS IOL calculator is already doing the adjustment. So the power which is best in that, the 2-1, if you choose that, there is no surprise after that. So I think this adjustment will not be needed.
Okay. And another thing is, you should always take measurements at least on 2 instruments, no matter what, and take the lowest keratometry possible of those 2 instruments.
But I think the most
avoid
important
spherical lens. You have to put spherical lens.
Spherical lens, yeah.
The most important part of the procedure is the giving up of the incision. So I recommend to to take scleral incision because that works very well. Boramani sir, your inputs?
Yeah, as you rightly said, scleral incision is preferable for such patients because it is difficult to do phaco, especially if the cuts are more. I don't want to go into the details of the biometry. Biometry is very challenging in RK patients. You have to keep a target of -1.5 that she has explained, but sometimes there is postoperative hypermetropic surprise. This is mainly because there can be swelling at the ends of the radial cuts, and which over a period of say 6 weeks to 12 weeks, it slowly settles. Now, as far as the counseling of the patient is concerned, perhaps the surgeon is luckier in doing a post-RK cataract surgery than a post-LASIK cataract surgery, because post-LASIK cataract surgery, the expectations are very high. But for RK patient already knows that he has undergone a technique which has been abandoned now. So it is something like neurosurgeons and cardiac surgeons, though the death rate is very high, they have less consumer cases than us ophthalmologists. And one important point I want to add is that even after the surgery, if you feel that the pressure is well settled, do a saddle test at the end of the procedure. Pull the eye with the fluorescein and see whether there is any leak from the radial keratomy RK wound. That's all.
Yeah.
Thank you, everyone, for your very good inputs. And yes, for the post-RK, if the cuts are say 8 to 16 cuts, and if the topography is not very aberrated, we have used toric lenses also with good results. You have to see it on a case-to-case basis. Yes. So let's move on to the next topic. Our next speaker is our young, energetic, and very enthusiastic Dr. Aarti Heda. She is the consultant at NIO Hospital, Pune, and she'll be speaking to us on charting stormy waters, rhexis in tricky situations. Yeah, over to you, Dr. Aarti. Please start sharing. Yeah.
Thank you so much, ma'am. Thank you, Team MOS, for this wonderful opportunity. So, good morning, everyone. This is the dream of every cataract surgeon. A well-dilated pupil, good visibility, a cooperative patient, and a well-centered circular rhexis. But life cannot be that simple always. So let's see some situations where the rhexis can be challenging. So this is a fibrotic capsule. It comes with its own challenges. To stain the capsule, be prepared to use the multiple techniques and modify your plan. You may have to use one scissor to cut the fibrotic part. As in this case, I really had to take efforts to remove that fibrotic part of the capsule. So, rhexis in mature cataract and hypermature cataract can be challenging due to poor visibility, shallow anterior chamber, increased intralenticulaar pressure, and lack of support due to liquefied cortex. So, various techniques have been described in literature. I'll just read you. So, various techniques have been described. So, I'll just show a couple of the videos. Here, a nick is made in the anterior capsule and the liquefied cortex is aspirated. Here, I am attempting to make a spiral rhexis, wherein I started with a small rhexis and now I am enlarging it. So, over a period of time, I have stopped using the cystitome, and rhexis forceps is my instrument of choice for almost all cases. So then you can slowly enlarge the rhexis. So here is the another technique called as double rhexis. A small nick is made in the anterior capsule and the liquefied cortex is aspirated. A small rhexis is made and the nucleus is debulked so that you reduce the intralenticular pressure. And once that is done, then you can make a bigger rhexis. So this was one of the video which was selected for ESCRS Young Ophthalmologist session. So I'll show one more very interesting case. At times, the anterior capsule can be torn as a subject to trauma. So this 26-year-old male presented with history of trauma and blurred vision of 2 weeks duration. So you can see very well there is a big anterior capsular tear, which is very obvious after the staining. So the main port was fashioned and the intralenticular foreign body was removed. So since the patient was young and the cataract was of recent origin, it was very soft and phacoemulsification was commenced at the low parameters. The viscoelastic was injected before removing the phaco probe, and an attempt was made to make the rhexis circular. So I'll not call it rhexis, I'll call it capsulotomy here. So the pediatric rhexis forceps was used to make it circular. So once that is done, it's easy to implant the lens. So the lens was implanted in the back and the patient had good post-op outcomes. So to summarize, anterior capsulotomy can pave to a successful cataract surgery. All the attempts should be made to identify the risk factors and look for intraoperative signs in high-risk cases. Utilize whatever options you have like trypan blue dye, rhexis forceps, Vanna scissors, endo-illuminator at times when needed. Thank you so much.
Excellent presentation, Dr. Aarti. We have our young expert here, Dr. Akanksha Thakkar. Can you give your thoughts on this? Yes.
Yes, thank you so much. Ma'am, just one thing in hypermature cataract that there has to be a way for the posterior fluid also to come out. So a little bit nudging of the nucleus at the rhexis margin so that even that trap, whatever fluid is trapped posteriorly can come out by doing the debulking of the nucleus. And another thing is, as you have mentioned in many of your presentations, that there are two types of hypermature cataract. One which is very liquidy, and one which is in which the cortical fibers are swollen. So we have to be more careful in the ones in which the cortical fibers are swollen. So that is what we have to take care.
Yeah, and in the intumescent cataracts, because the intralenticular pressure is high, you need to use a very heavy molecular weight viscoelastic to flatten the anterior capsule. And if you go in through the side port, it is less likely that the viscoelastic will get leaked from the main port. And if you maintain the anterior chamber, then it is less likely to have an Argentinian flag sign. So that is important to maintain the anterior chamber. Dr. Jagannath sir, can you give your quick inputs?
Yeah, I want to give one important tip which is not described anywhere. Many times the capsular rhexis starts going to peri-peri, and multiple methods have been described, like to continue as CCC for some time, again do capsular rhexis, or so many things are there. But why the capsular rhexis go to the peri-peri? Because the more you go to the peri-peri, the centrifugal forces are more, because the lens becomes more curved there. So to reduce the stress on the zonules, if the capsule starts going to the peri-peri, generally what you do is you indent the ciliary body region on the sclera with any blunt instrument. So if you indent the ciliary body region, the zonules become very slack there, and that centrifugal force is nullified. Then it becomes easy to bring that peripheral capsular rhexis again into the center. That's all.
Yeah, and in pediatric cataracts, because the elasticity is very high, use the forceps and actually towards the center you pull it.
Yeah.
Yes, so that you have a good capsular rect. Anybody else wants to?
Sometimes when the rhexis is not coming inside even after pulling, because I've seen one or two videos in which it was mentioned that you have to forcefully take it inside in a sudden moment. So I don't know how good that is for the zonules.
Yeah.
Can't we make just a nick on the capsule that moment and then continue doing the rhexis as we were doing before?
No, the thing is, it's not a sudden movement. It is you just lift up the rhexis and then bring it. If you're going it, see, routinely when you're making a capsulotomy, you're making the flap very flat. That gives the best way to give a round capsular rhexis. But when it is going out, you have to pull it towards the center, and you need to change from the cystitome to the forceps. The forceps gives you the extra advantage because you can lift it. Whereas with the cystitome, you cannot lift the flap. That is the only disadvantage.
There are two forces, shearing and tearing technique. So shearing is when you are doing, but when it starts going towards periphery, you have to pull it centripetally, and then it comes in the center. That's the technique which is described in the literature.
Yeah, I think.
And today we also have the flax opportunity, so to give you a perfect central capsular atomy. That also is. We can move on to, I think, to the next talk.
Yeah.
To Rajesh, yeah.
Yeah. Next presenter is Dr. Ajay Khandewale from Amravati. He is a high volume cataract and refractive surgeon. and he will be telling us on ticks and trips in black cataract.
Hello, I am audible?
Yeah, visible also. You can share your screen.
Is it visible?
Yes, visible.
Good morning to all of you, and thanks for MOS all of his bearer for giving me this opportunity. Today I am going to discuss few tips and tricks regarding how to manage the black cataract. Before beginning, I would prefer to do this kind of cataracts under local anesthesia for two reasons. The surgery may take a long time, and if you at all want to convert to SICS or ECC, it will be easy. Under the cohesive viscoelastic, at least 5.5 millimeter of rhexis is prepared. Because smaller rhexis, it will be difficult to maneuver such a large nucleus, and there are very high chances of BC tear, zonular dehiscence, and tearing of rhexis to peric. The optimum amount of hydrodissection is indicated because too vigorous hydrodissection may give up the posterior capsule, may give up the heavy nucleus. So optimal amount of hydrodissection is done. So a central deep trench is created. This nucleus hard cataracts can be managed by direct chop or age-old method of direct stop and chop in 4 quadrants. Stop and chop in 4 quadrants I am doing right now is in this case it is direct chop is shown. Stop and chop is having the advantage of all the debulking and nuclear cracking of the nucleus is done in posterior capsule quite away from the endothelium. So chances of getting corneal endothelial damage and post-op corneal endothelial edema are quite less. See here, all the nuclear fragments are separated totally because in type of cases grade 4 or plus, the leathery fibers, even if they appears to be separated, but they remain attached deeply. So clear fundal glow should be visible after cracking of the nucleus. Multiple multiple nuclear fragments or nucleus is broken into multiple pieces. Here one point should be noted, copious or plenty of amount of viscoelastic should be used so that the corneal endothelial damage is prevented. One more important point is always tell your assistant to pour saline on the wound to prevent the wound burn. As wound burn may cause the fish mouthing of the wound, or there may be wound gap and leading to gapping of the wound. Always come multiple times out and push viscoelastic. Copious use of viscoelastic is indicated, and whenever the nuclear fragments are coming and closer to endothelium, they are always pushed into the bag, and because there are very high chances they may cause the turbulence and damage to corneal endothelium, as well as this sharp hard nucleus may damage the posterior capsule. So these nuclear fragments should float into the anterior chamber very easy. In the back very easily. So coming to the getting of message of this today's my video is it is always preferable to under topical anesthesia, local anesthesia. Obvious use of viscoelastic and at least 5.5 millimeter of the rhexis is must. Optimal amount of hydrodissection is done. Minimal turbulence and lens chatter should be there, and this can be modified by the foot pedal tips and changing the parameters accordingly. And in corneal endothelium is prevented by doing the phaco in the posterior chamber. So clear corneas with good amount of vision is not impossible nowadays. Thank you very much.
Thank you, Ajay. That was wonderful presentation. Quick comments from Dr. Prashant, who is a high volume surgeon from Nashik.
So, congratulations, Dr. Ajay Khandelwar. I really appreciate his presentation, and I thanks office bearer to give me this opportunity to be with you today. So Rexis rightly said, I prefer oval Rexis. Means the meridian of Rexis in the incision plane is slightly more than the right angle to it, which will help for the longer trenching, and division is also easy. Trenching, I normally target for the 90% depth. You should give the adequate time for the trenching. I should not hurry to go on the FECO 2 mode if it's taking long time. Wound burn, as rightly said, you have to pour the saline on the wound. And I normally take one or 2 mm bigger incision for this FECO for the black cat. So there will be the adequate fluid coming out of the chamber during the FECO surgery, and it will cool down the tip and avoid the wound burn. If required, the bottle height can be raised in such situation in order to compensate the fluid coming out of the chamber. During the chop, the second instrument plays very important role, acting as a guard, preventing it from the fragment going to the endothelium. All the maneuvers should be done at the pupillary plane and not near the endothelium. Higher amount of FECO energy used during the surgery need not be proportionate to the amount of endothelial loss. More important is at what plane and how far away from the cornea going to decide the amount of endothelium damage.
Yeah, I think
We lost his connection.
Lost his
Yeah.
connection.
Yeah.
Dr. Sohail, who manages
Sohail.
this type of cataract.
There are higher chances of piscerent at the last piece. So during the last piece, the parameters should be decreased, like vacuum flow rate should be decreased. And again, use of visco is important to avoid the piscerent.
Yeah.
So thank you for
Thank you,
listening.
Dr. Prashant. That were the wonderful tips. Dr. Sohail, who operates this type of cases with his technique.
Yes, sir. Am I audible, sir?
Yeah.
Yes, yes. Very well.
Yeah, so most of the points have been covered, I think, nicely by the presenter as well as the just now doctor who has summarized that. The only thing is the shorter tunnel length is going to be very important because we don't want a larger tunnel which will produce a overlocking, and a adequate size Rexis to err on a little larger one to prevent capsular block and the subsequent nucleus drop is the most important thing, and not a very zealous hydrodissection, and using the right quality of OVD and using the optimal FECO strategy, using the nice power modulations and vacuum and posterior plane of emulsification. And patience is the most important thing, I suppose. Thank you very much.
At one point, Ajay, just a point. So if you are delivering the energy directly in the direction of endothelium, it can trouble. So tilting the FECO tip a bit obliquely or horizontal way helps many times to deliver the energy sideways instead of directly on the endothelium. So I do it many times in hard cataract because I never knew how to do SICS. So I was supposed to do hard cataracts also with FECO. That was just one point, Ajay, I would add. Yeah, otherwise it was an amazing.
Yeah, very nice presentation. I think we need a combination of all these techniques, and today we have higher end machines where you have FECO modulating techniques, technologies, and other modules so that you can reduce the FECO energy that is released. Use of flax also in such cases. A larger Rexis, see that the posterior plate is nicely separated. Otherwise, if it is attached, then it can cause problems later on. And no ego issues, you can convert to a SICS in case there is a problem. That also should be a take-home message, that there is no, it's not necessary that you have to do FECO in case you feel that the cataract is extremely hard and the corneal endothelium is not very healthy, then you can move on to SICS also. What is important is giving good visual outcomes to the patient.
Soft shell technique is important, actually. Soft shell
Yes,
technique.
soft shell technique, yes. So I think we have had excellent discussions over the last 5 presenters. Very big thank you to all the presenters, to all the young experts, as well as the senior expert panel. Thank you for sparing your valuable time. I think Dr. Santosh Bide sir, you can give your concluding remarks.
One thing I want to say is that Dr. Sohail Khan has developed a chopper, pre-chopper, And I have seen that those videos also. Excellent chopper, and for any grade of cataract,
Thank you.
He's chopper.
Thank you very much, sir, for the encouragement.
Extremely hard cataracts. One point to avoid wound burns. Before starting phaco, you have to go on aspiration mode. You have to aspirate some of the viscoelastic, because if you start immediately, if you go to pedal foot position number 3, then the tip will get clogged, and that is the cause for wound burns. Whatever amount of fluid you put from outside is not going to cool the tip. So you have to first of all create a free space above the hard nucleus, and then start doing phaco. And proper chopping techniques will definitely reduce the energy consumption. And soft shell technique helps you in protecting the endothelium. But all in all, excellent presentations by everybody. Great show.
Thank you, sir.
Thank you.
So,
Dr. Vardhaman, you're muted. Just unmute.
Thank you so much for amazing moderation and conducting the cataract session to both Dr. Anaga and Dr. Rajesh ji. And thank you, Dr. Bide sir and Dr. Lahane sir, for chairing the session, and all amazing panelists. So we will probably now move on to the next session.
Is Dr. Lahane sir here to give concluding remarks?
Lahane sir was traveling, I think.
Yeah.
Okay.
Thank you. Okay, thank you again. So friends, we all know that this Moscon midterm is very special because we are talking about young India. India is probably the only nation right now in the world which has the highest amount of young population. And this was the main motto of the Moscon midterm, to give platform to our young stars. And to move from the cataract to the session now, we will be having, again, amazing array of our presenters, young experts and senior experts. In this refractive surgery session, I would like to invite Dr. Prakash Kankaria sir to chair the session, along with Dr. Jeevan Ladi sir. We all know that Dr. Prakash Kankaria is one of the pioneers of refractive surgery in India, and he is also known by the peers as one of the fathers of refractive surgery in Maharashtra. Right from the era of RK to the current generation of Smile, he has seen the entire journey. We welcome him to this session. We welcome Dr. Jeevan Ladi sir, who has been a past president of Maharashtra Ophthalmological Society, one of the pioneers of both cataract as well as the refractive surgeries in Maharashtra. He is at forefront of cutting edge technology, and we are very lucky to have him as a chairperson for today's session as well. So friends, we are going to start this session with our first young presenter, who is Dr. Karishma Wadia from Mumbai. She is going to discuss a curious case of unhappy cataract refractive patient. And to discuss this, we have Dr. Kunal Shinde from Pune and Dr. Sharad Patil sir from Nasik as the expert discussants. Over to you, Karishma.
Good morning, everybody. Thank you so much for having me here. Thank you, MOS. Thank you, Dr. Vardhaman. Thank you, Dr. Anaga, for the invitation. I'll start with my presentation. I have two cases which are unhappy cataract patients. One is a monofocal and one is a multifocal. So we'll start with my first patient. He's a 62-year-old male, retired, likes to play chess, has hazy vision in both eyes since 6 months, and was diagnosed with immature senile cataracts. He underwent a right eye cataract surgery with multifocal IOL after the necessity pre-surgery workups. But he was extremely unhappy with his vision and complained of a lot of glare and halos. On examination, if you see his pre-operative workup, he was a hyperope. Usually these patients do well after surgery. They are even more happy because of their independence from glasses. Anterior segment was a regular clear cornea with immature cataract. So there was nothing remarkable that could have caused this. If you see his pre and post-op pictures also, it was just a regular uneventful surgery with a well-centered multifocal IOL. So what exactly happened? Why is he so unhappy with his vision and complaining of glare and halos? He sees 6/9 and 8, but the visual quality is quite bad. So when you go back retrospectively to find out what happened, you look at the corneal topography. The topography is also fairly normal. It's with the rule astigmatism. There's nothing that's dangerous. But if you look closely, there is a high angle kappa. Now, usually for multifocal patients, we would want to use 5 degrees as the cutoff, beyond which you may have a certain amount of dissatisfaction in the patient. So you need to keep this in mind and you need to explain this to the patients. Don't just look at your topography, whether it's regular or not, because your angle kappa is the angle between the pupillary axis and the visual axis. So if you have a small angle kappa, which is mostly present in everybody, the fovea-centric ray passes through the central ring of the multifocal IOL, which gives him his good distance vision. But if you have a large angle kappa, that fovea-centric ray is going to hit on the edge of the ring, which may cause what this very patient is experiencing, which is edge glare and decreased quality of vision. So when you are planning your IOL placement as well, the IOL normally tends to center around the bag, right? It's not going to center on your visual axis. So no matter what you do, if you have a high angle kappa and it's combined with a multifocal IOL, you might have compromised vision. Again, this is not a hard and fast rule, but it's very common to see these patients as unhappy. So you'd rather give them a heads up than suffer later on. So axis of the eye, is this important to me? Yes, very much, particularly if you're going in for a multifocal cataract surgery. Now let's go on to our second case. This is a 59-year-old lady. I would like to emphasize on the point she's a relative, and you'll come to know why during the course of the presentation. So she's always complained of dry and itchy eyes. She was a case of CA breast operated in 2010 and was on oral tamoxifen for 2 years, but was having a lot of GI issues with the medication. So it was changed to oral aromidazole since the past 6 years. All right. Now, in the period post her surgery and her medications from 2010 to 2012, her vision was always good, best corrected 6/6 and 6, but varied based on symptoms like dry eyes, itchy eyes. She had recurrent acute internal hordeola with continuous rubbing of the eyes, and cornea would show on and off a few SPKs, and MGD was significant. She was managed conservatively. Chronic MGD symptoms were treated. Subsequently, in 2013 and 14, she underwent cataract surgery, left eye and then right eye, because she was complaining of blurred vision. Particularly, a monofocal IOL was chosen for her because she had so much of dry eye and discomfort with on and off glare bothering her. Post-op, as expected, there was increased dryness, so she was managed again conservatively, lubricant, cyclosporine and paraffin-based ointments. The point is that she has always complained of some dryness, some itching, and some fluctuation in vision. But her best corrected vision was always 6/6. So the symptoms were always attributed to her dry eye. Now, in 2015 and 16, which is again 2 to 3 years post-op. So the post-op dryness related to cataract has now gone off. She still complains that she cannot see clearly, but when you check her, vision is 6/6. And I would like to emphasize on this point in my last sentence. We have been deferring dilated checkups because she was non-diabetic and she was always 6/6. And so she is a relative. So whenever she would come, she would be like, oh, I don't have the time. So are you sure I should get dilated this time? And it would get skipped. Over a telephonic conversation in 2017, she said, I can't see. So we thought again, maybe it's PCO. So we explained Chari to her, and again, she procrastinated her checkup until finally she came to our clinic. Now her best corrected vision is still 6/6 in the right eye, left eye is 6/6 part. But she says, I can't see. Cornea is clear, PC is clear, there's no PCO. So what's happening? I finally looked at her corneas, absolutely fine. If you can see, there's hardly any SPKs, or rather there's no SPKs. It's just a terribly bad T-butt time. But finally, I put her through a dilated evaluation, and I have found a left eye lamellar macular hole. So this is what was distorting her vision. She's an actively working individual. She's a speech therapist. And so this was bothering her vision because she finds some distortion or some irritation that is continuously obstructing her, which has been dismissed by us as her chronic dry eye symptoms. So what are the mistakes and the lessons that we got from this? Do not give or do not assume a presumptive diagnosis on a telephonic conversation. This is particularly important post-COVID. We have all started doing video consultations. So maybe we need to add a disclaimer that it is not, it is not going to hold true forever. You need to visit us if your symptoms are not relieved. Do not get carried away with the chronicity of symptoms. Just because she had dry eye doesn't mean forever the dry eye is the only culprit. Do not let patients delay a dilated evaluation. Most patients say, oh, my vision is good, pressure is good, everything seems to be okay. Do I really need to get dilated right now? let them get dilated even if their vision is good after a particular set amount of time. And very important take-home message, please evaluate all cancer patients in detail after every 6 months. If you do a review of literature, it is seen that with tamoxifen as well as with arimidazoles, which are the very commonly prescribed post breast cancer treatment drugs, most women are complaining of chronic dry eye, and a lot of them also do develop some sort of retinal issue. Earlier, we used to think that there is retinal toxicity, but they may also suffer from retinal holes. So keep a watch out for such patients, because anyways, CA breast is on the rise, and this is something that we need to watch out for. So with that, I'd like to conclude, and thank you all very much for your patience.
Yeah, thank you so much, Karishma. May we have our young expert, Dr. Kunal? Is he online? Yeah. Dr. Kunal, can you give your expert comments on these cases?
Please unmute yourself, Dr. Kunal.
Good morning, all. Thanks, Moscon, for this opportunity. So I would like to ask the question, do you evaluate dry eye disease for each case of your cataract surgery?
Yes, with particular emphasis to the multifocal IOLs. Yes, we evaluate for dry eye. If there is pre-existing dry eye, if it's of the mild variety, then I like to just first manage the dry eye. So I tell them to defer the surgery, take dry eye treatment and come back. And if it is moderate to severe, then we can even offer them dry eye treatments like IPL is available to address their symptoms, and with a proper warning that your dry eye is expected to increase temporarily after the cataract surgery. So give them a heads up, because a lot of them come to us with one eye operated elsewhere. The vision is excellent, 6x6 vision, but there is something poking. So something has gone wrong in my surgery. Is it, doctor? So they try to blame the doctor or the surgery. So we kind of need to explain to them that this is a possibility. These are the symptoms of dry eye. Otherwise, they're only going to badmouth us. So I have started doing it with special emphasis for multifocal patients, because they expect more out of us overall.
Yes. Actually, nowadays, this cataract surgery is like presbyopia correction surgery. So they want good results also. So this cataract surgery, especially after surgery, the effect of dry eye increases. Reasons might be the goblet cell and corneal epithelial cell loss, plus phototoxicity, plus hydration, frequent drying and hydration during cataract surgery. So and altered nerve sensation. So this altered nerve sensation, I also think, one of the itching factors for these patients. And regarding your first case, angle kappa, yes, it is very important to know angle kappa before surgery. And 5 degree, I think it's sufficient. More than that, I will prefer EDOF lenses or the other.
Absolutely, absolutely right. We would rather choose an EDOF and get rid of the symptoms of glare with that.
Thank you, Dr. Kunal. May we have Dr. Sharad Patil, sir, our senior expert, to give his comments, please?
I think he's not there.
He's there, sir is there.
Yeah, okay.
Sir has joined, actually. Dr. Patil, sir? I just spoke to him.
Okay.
Okay, so maybe we will try to get sir's inputs for the other case. Can we have Dr. Shirish Thorat, sir, our co-moderator, to introduce the next speaker, please?
Before going to next case, one thing I would like to add in this case, Vardhaman.
Yes, please.
Apart from angle kappa, angle alpha is also important in case of multifocal IOL. And it is very difficult to get angle alpha and kappa in routine OPD instruments and OPD setups. So quad view length, which is available in every IOL Master 500, will be helpful.
Absolutely.
You just need to go with the quad view length, which is not more than 0.5. It will act as a, angle alpha.
I think in the current concept right now, quad mu length is actually more important.
Right. Apparently, really, yes.
Absolutely. And just to make a small comment about the OCT, because if anybody is actually doing premium IOLs, now it has become almost a norm that you should get, if you have the access to OCT, a macular OCT should actually be done. If you want to charge patient or not is up to you. But large case, there is a large paper that we had published from Bascom Palmer about 8 years ago, when we had seen that before cataract surgery, even a medical retina expert missed 22% of lesions clinically, which were actually found out on the macular OCT. So I think that is a valid point what Karishma has brought out.
Yes, yes.
Absolutely. Yes.
Now,
Vardhaman.
Yeah.
Vardhaman, good morning. This is Dr. Sangeeta Wagh speaking.
Yes, ma'am. Yes, ma'am. Please.
I didn't want to interrupt, but I think there's something very, very basic and simple I want to share, especially with all my young friends. Couple of things that help us in avoiding both the problems that Karishma spoke of. One, when you look at the autorefractor, most of us have optometrists who are looking at it. But if we look at our premium patients, the AR can give you a lot of information on, one is the dryness, where you'll see distortion of the Myers. And two, if the centration is, you look at the centration of the central dot with the rings, that will give you an idea of the angle kappa. And also, if you just look at the Amsler chart where a patient is complaining of vision, uniocular with reading glasses, that can give you a lot of information on the macular status. So these are just three simple screening tests that can be done by anybody and everybody, which can help you a long way in your outcome.
Yes, very true. Absolutely. Thank you. Thank you.
Absolutely very. I think they're available with each and every ophthalmologist.
Yes, yes, yes.
Thank you so much, ma'am, for your kind inputs.
Yes. Now moving to next speaker. Our next speaker is Dr. Anand Basari, who has completed his long-term fellowship from Edu Prasad ISU. He has many awards and awards to his names, and he'll be speaking on optimizing visual outcome in cases of keratoconus. To his case, the panelists are Dr. Rashmi Shukla and Dr. Anand Pimper. Anand?
Yes. So, is my title slide visible? And
No.
am I audible?
You're audible, but not visible.
The title slide is visible, sir? I've shared the screen.
Doctor, it's not visible. Can you share again?
Yes, just. So, is the title slide visible now?
Is okay now. Yes.
Yes. So, thank you, Moss and Dr. Vardhaman Kankaria for having me over here. So my topic is reshaping the cone, topography guided PRK and cross-linking in keratoconus. So let me begin with this case. So this 23-year-old gentleman presented with chief complaints of ghosting, which were there even with glasses. And on examination, his best corrected, his right uncorrected visual acuity in both eyes was around 6/18, which improved to 6/12. Not improving further even with glasses. So the topography here we can see showed inferior steepening in both the eyes, with keratometry reaching up to 48.36 diopters, and obviously the diagnosis was pretty clear. This was both eye keratoconus, and his older records when we looked upon, it showed that there was progression in both the eyes. Interestingly, this was relatively the patient had a good corneal thickness in both eyes, 511 microns in the right eye and 509 microns. And as we look from the corneal topography and the K readings, this was relatively early to mild to moderate keratoconus, probably an early stage with keratometry of 42 and 44 in the right eye and 43 and 44 in the left eye. So this was left eye more than right keratoconus. So to just begin with, keratoconus is a progressive corneal ectatic disorder characterized by two problems. The first problem is progression, and the second problem is irregular astigmatism. So for progression, we have a cross-linking procedure, and for irregular astigmatism, often these patients require contact lenses, which are a bit cumbersome to use, but they give excellent quality of vision. But these hard contact lenses often cause problems related to watering, irritation, and long-term use becomes cumbersome. So this patient was offered cross-linking, but he was not very keen for using contact lenses. So do we have something better for this who can address both of the problems of progression and irregular astigmatism? For that, we have an established procedure of corneal collagen cross-linking, which is the only modality available to stop the progression of the cornea, and it acts by stiffening the cornea, but doesn't address the irregular astigmatism, and hard contact lenses needs to be used. So for managing the component of irregular astigmatism, now we have the CXL plus protocols, in which there is an option of topography guided partial PRK combined with cross-linking in a single stage, which has been described as the Athens protocol and the Cretan protocol. So this is a very interesting article which came from AJ Kanellopoulos and his group, which was described as Athens protocol, and in which a topography guided treatment has been done, which has been combined with cross-linking. So let me tell you what is the principle of topography guided treatment. So in keratoconus, we have an irregular corneal surface, and this can be reshaped by a topography guided treatment to a target toric surface, which in which the target surface starts at the lower point of the irregularities. Here, by using the topography guided mode, excimer laser corrects the most steepest part of the cornea to regularize it somewhat to get a better surface, which leads to reducing the problem of irregular astigmatism. So in Athens protocol, a partial PTK mode, 50 microns of the epithelium is removed, followed by topography guided PRK, followed by cross-linking. So in Athens protocol, here we see the apex of the cone, the most steepest portion, receives the myopic ablation, which leads to the flattening of the cornea at the apex of the cone. And in the mid-periphery, in the areas which are relatively flatter, there is an arcuate hyperopic treatment.
Can I ask you to sum up shortly, next 1 minute, please?
Yeah.
Because we are...
So steepens the cornea anterior to it. So here is the pre-op topography, and here we see the post-op topography. So there is a significant flattening of the cornea here in the inferior cone, and here we see that the superior cornea is relatively steepened. So there is the regularization of the cornea. So so this is the last slide, in which there are the minimum parameters, where the minimum pre-op thickness has to be 450 microns to begin with, and the minimum post-operative thickness is has to be around 400 microns or more, and we cannot ablate more than 50 microns at a time, because we need to have residual stromal bed, and we need to know the primary purpose of the process is to stabilize the keratoconus, but it's not a refractive procedure, and emmetropy is never a target. And we can reduce some amount of cylinder and under correction. So there is a significant change in the optical quality, where we can see there is difference in the ghosting.
Okay, Dr. Anand, I think we will...
So this is my last slide, and this 10 years of outcomes of progressive keratoconus management has been shown in this article, in which this summed up that the long-term outcomes have been stable. Yeah, so this is my last slide.
Thank you. Thank you so much, Dr. Anand. Yeah, Dr. Thorat, sir, please. Yeah.
Can I request our panelists, Dr. Anand Pimparkar or Rasushikla ma'am, to comment?
Dr. Rashmi, would you like to go first?
Dr. Anand?
Dr. Rashmi, would you like to go with your comments?
Yeah. Thank you, Dr. Anand. That was a wonderful and interesting case. So I just want to make a mention is, like you obviously said, that we are only reshaping the cornea. So counseling the patient, because the moment they hear that there is a refractive procedure, they may have these expectations whereby they may be free of glasses, or they may not need to wear contact lenses. So that needs to be explained, that only the quality of vision might improve, but they may still need aids which may be suitable to them. The second thing I just want to ask you, because we know that trans PRK versus epithelial off mode of doing these, there are definite advantages and disadvantages of one over the other. So any particular reasons why you chose trans PRK in this patient? And secondly, the parameters where you would decide that we could do a combined procedure versus only CXL in a progressive, parameters on the topography or thickness parameters.
So there's some of the things. So the location of cone really matters. So deciding on whether we are going with which patients would you choose for doing this procedure. So the centrally placed cone are a very good relatively patients for this, because they tend to benefit more versus the very inferiorly placed cones. Okay. So, and second is the most important parameter is the preoperative corneal thickness. So if the preoperative corneal thickness is good, so those patients who have thickness more than 450 microns, I actually prefer even more thickness, 400, 480, 90 microns, which is relatively uncommon to see. But those are my ideal cases where we have a good idea, where good scope to correct some amount of cylinder as well as reshape the cone as well. And in patients who have corneal thickness less than 450, 440 microns, my preferred approach would be to do only cross-linking because the residual stromal bed and there are chances of progression later on as well.
Thanks, Dr. Anand. Dr. Shiri sir, Dr. Anand sir has some family health emergency. So we'll take Dr. Patil sir's comments on this.
Yes.
Yeah, thank you, Vardhaman and Prakash for this session. Dr. Karishma presented very well cases of multifocal and dry eye with lamellar hole. In these patients, before you offer multifocal lenses, one should thoroughly check entire system of that patient's eye. That is right from dryness, surface, whether surface has got the irregularities, HOAs, even pupil size, his fundus with OCT or with clinically, along with the optic nerve and if possible perimetry. So all these things will give a fair idea about possibility of any risk factors. And once you rule out risk factors, then you may advise patient for multifocal lenses and angle kappa, angle alpha. These are definitely important things, which as Sangeeta had already mentioned, that can be very easily clinically diagnosed on AR or even on newer instruments like OPD scan and all this thing. So multiple patient needs thorough workup. That is one thing. Second case, what Karishma showed was of dry eye patient landing into some kind of a retinal problem like lamellar macular hole. So all these patients relate to one and the same thing, that you need to rule out any risk factors to these patients for cataract surgery and its outcome, because patients nowadays they are very sensitive and one should be able to give them a fair idea about expectations or outcomes before you plan for the surgery. And second case, what Dr. showed, Parashar, that is about topo-guided PRK. Nowadays, if surface is stable and amount of treatment is not going to be more than 50 microns, one can definitely plan for these kinds of topo-guided PRKs for keratoconus patients to reduce HOAs. The aim is not to reduce refractive error, but to make cornea somewhat better so that patient can wear glasses.
Thank you so much, sir. I think great inputs. Only thing is, probably half a minute I'll add is about the Cretan and the Athens protocol, because most of this work has come from our group, from Professor Kimionis. He is the pioneer of this technology, and we have published more than 50 papers now only on these aspects. I'm going to put a small review article that I had written for Indian Journal of Ophthalmology, which compiles all the CXL Plus protocols, when to use which techniques. For people who have interest in that, they can go through it. But thank you so much, Dr. Anand, as well as Dr. Karishma, for wonderful presentations. So I think next we will go to Dr. Mukesh Paryani from Pune. Dr. Mukesh is a refractive surgeon based out of Pune. He is trained in Narayan Nethralaya. He's going to present his tips about preventing the flip and phakic IOL surgery. And to discuss his case, we have Dr. Shadab Khan as the junior expert, and Dr. Ambarish Darak sir, who is a very high volume pioneering refractive surgeon and the chief of Vision Next Eye Foundation at Pune. He's going to be the senior expert for the case. Over to you, Mukesh.
Hi, good morning. Am I audible?
Yes.
Yeah, so I will be just showing a 4-minute video of preventing the flip and phakic IOL surgeries. Most of us are doing phakic IOL surgeries, but sometimes we land up with an inverted phakic IOL in the chamber. Although it is easy to manage this kind of complication, but it's kind of cumbersome to take out the IOL, load it again and put it inside, and sometimes may damage the iris structure or the endothelium. So I'm going to show a small 4-minute video of the evolution in the technique that I used to do in 2013, then in 2016, and then now what I do in preventing the flip in the phakic IOL surgery. So as I said, flip will happen. Most of us who have done a phakic IOL surgery would have experienced a flipped phakic IOL at some point of time. And obviously, preventing is the best technique. This is what I used to do in 2013 video. This was in 2013, the star ICL you can see. But many a times we kind of land up in the way the ICL or the phakic IOL opens. As you can see in this particular video, which was a piggyback phakic IOL, the second instrument is a globe stabilizer. And we see that the ICL has opened not in a way we would want to. And it's inverted. Simple, we have to take it out, reload it, and put it inside. But it's cumbersome. It's cumbersome for the patient as well. It's cumbersome for us as well. That's where I introduce the first instrument here. Since 2016, what I've been doing is the first instrument that goes is the Vukix manipulator here. Following that is the implantation of the phakic IOL. So in case the phakic IOL doesn't open the way I want to, my second instrument is there to guide it and open it up. Sometimes what happens is, despite this thing, a lot of things that go in my mind while the phakic IOL is opening. I'll show a very brilliant example of what goes through in my mind when this kind of situation happens. And everyone will correlate to it. We have seen a movie, this particular movie, and this thing happens in my mind, whether it's going to open on the left side or it's going to open on the right side. And this kind of thing happens, it's going to open straight or it's going to happen inverted. Most of the times we are lucky enough that the phakic IOL opens the way we want to because we have loaded under microscope. That's the most important tip. Now, this is where the second instrument comes into play. Now, what I do nowadays is the first instrument is my guard. So the first instrument, I always call it as a guard. It will help us to make sure that it opens the way I want it. Now, if it doesn't, what I do is I just hold it there. Observe the bubble at 7 o'clock, as it will be very important that it's kept away from the endothelium. And the phakic IOL has to be kept away from the endothelium. Now there's a bubble between the instrument as well as the endothelium. I use a second instrument here to open it the way I want to, and that's it. That's pretty much done. So always keep a second instrument handy. The assistant should know if I ask for a second instrument. Again, check the orientation of the phakic IOL and you will be done for most of the times. Let us see in one more example of how we do it. As I say, my guard is there standing on the left. In case it doesn't open the way I want to and I'm able to manage with first instrument, it's well and good. But in case it doesn't, I just hold it there, take a deep breath, give the injector to my assistant. I ask for a second instrument. I know the orientation by now, which phakic IOL, what the notch should be up or the hole should be on the right or on the left. I simply go arrange it, making sure that the first instrument is way away from endothelium. The rest all things are easily manageable. You don't want endothelium in a young patient to be damaged. Always loading has to be under the microscope. The first and the second instrument helps a lot. Well, that's all. That was my 4-minute video. Thank you so much.
Thank you very much, Mukesh. Very good tips for anyone who would like to start with phakic lenses, and people who are already doing it also. I'm sure they have learned a lot. So can we have our senior expert, Dr. Turks sir, to give his expert inputs? He does very high volume of this phakic lens implants.
Thank you, Vardhaman. First of all, congratulations for such a innovative concept. of conducting a midterm conference. So I congratulate all the MOS team for this. Second thing, most of the time, what I see now, I am doing phakic implant for more than 15 years almost. So the thing is, I have seen these things happening with ICL in particular. With recent bunch of phakic implants, the same injector are used, which are used for cataract surgery, and rarely you come across these kind of shape. In case of particularly ICL, what I see is that because I have also done these complications, in inverted ICL. So most of the time, what I see is when you load actually the proximal end, once the 50% of the lens is in the AC, that time only you realize what way it is going to open. And you can actually twist or change the injector itself to change the direction of your implant. So that is the primitive or the preliminary step where you can actually manipulate the change position of the ICL in there. And if at all it is inverted, then yes, it is a good technique developed by Mukesh to flip it inside only, because yes, I also agree, taking out that lens and reinserting is a tedious task.
Absolutely. Thank you, sir, for your kind comments. I think with your high volume work, this pearls will come very handy for our young experts who are trying to learn. Can we?
I would like to quickly add just one comment.
Yes,
Keeping AC towards shallower side does also help, because it if AC is very deep, then ICL gets a lot of space to flip through, and if it is kept towards shallower side, then 90% of the times ICL won't even flip. And the other tip, as shared by the other expert, sir, very well, that once you inject slowly in probably 50% of injection, you get the hint as well. Thank you.
Thank you, Navrata, for your tips. Can we also have Dr. Shatab Khan, our junior expert, to give it?
Thank you, sir. Am I audible?
Yes, yes.
Yeah. So thank you, Moscon, and very nice presentation by Mukesh sir. He was my first teacher of refractive surgery in HV Desai. And I just want to share one or two things which I have faced. In the loading of the lens, if there is small amount of pinch between the one of the haptics and the injector, there might be a little flipping. So we need to check when we inject the IL before the injection of the phakic IL.
Yes.
And also the wound size. I have seen that trying to inject the ICL through wound assisted technique does lead to a lot of problems. I usually create a larger wound for my ICLs rather than for my IOLs. And also viscoelastics, I have had some problems with using sodium hyaluronate. In ICLs, I usually now prefer methyl cellulose for all the ICL, for all the phakic IL cases. I have had very few experiences of ICL. I usually use some of the Indian manufactured phakic ILs, but I have had very good results with methyl cellulose. I feel that under sodium hyaluronate, the phakic IL does not behave very well as it does under methyl cellulose. And also, if the injection is very slow, it gives us time to think and to react to the flip or to the flipping process. That's what my points are. Thank you.
Thank you so much. Thank you. Thank you.
Thank you so much, Dr. Shadav. I think great inputs by everybody. Dr. Shirish sir, can we go to the next case, please?
Yes, sir. Our next presenter is a dynamic refractive surgeon, Shraddha Surekha. She's a good clinician. The topic is the flip-flop of flap, and the panelists for her case, Dr. Ankit and Dr. Sairas Mehta. Over to you.
Okay. Thank you, Moss, for the opportunity. And I'd like to ask if my slides are visible.
Yes, yes, visible. Yes, yes.
Okay. Numerator, can you just help with presenting this? Okay, I'll just present it from here then. Okay. So Thank you, Moss, for the opportunity. I'll present a case of the flip-flop of the flap. So a 30-year-old lady came to me with right eye -3 refractive error, left eye -3.5 refractive error. And I went ahead with both eye microkeratome LASIK with a 100 micron flap. Now she came on post-op day 1 with 6/6 vision in each eye. But on post-op day 3, she came with redness, pain, decreased vision, and blurring of vision in that eye. She had history of rubbing her eyes at night while sleeping. And on examination, I could see that the flap, it was centered infero-nasally decentered. So while rubbing her eyes, she must have done something to the flap. And there were folds which were visible. Now, with this kind of picture, I immediately took her to the OR. And the first thing that I did was made sure that the pupil was dilated so that on retroillumination, I could make out the flap edges and the folds. The next step was making sure that the epithelium was out in the area where there was no flap. So there was new epithelium which had grown on this area wherein on the stromal bed, and I made sure that that epithelium was completely out. I tried to remove the epithelium from the flap, but it did not come out very easily at that point. Now, once the epithelium was out from the stromal bed, then I tried to manipulate the flap. So the flap was just 1 or 2 days old, and just by putting water under the flap, I was able to kind of slowly get it back to its original position. Yes, there were points wherein the epithelial sheet did not allow me, and I had to kind of break off those links between the epithelium and the flap, and then I was slowly able to get it back to its original position. Now, at this point, I'd like to mention that we as cornea surgeons are very particular that we clear the edges. So the host stromal bed has epithelium which needs to be cleared off, because otherwise that will be the place from which epithelial ingrowth occurs. Well, refractive surgeons may not be that comfortable doing that, but I'd like to emphasize that. The next is those folds I can see on the flap. And I tried to remove the epithelium over that flap area with a 15 number blade, then with a bud, and even with the IA cannula. But it was very difficult to remove that because the flap was moving all around. But with patience, I was able to remove the epithelium. Now, if you can see closely, as soon as I remove the epithelium of the flap, the fold in that area flattens out and becomes invisible. So that's because the Bowman's membrane, it has these troughs which epithelium fills in. And as soon as you remove the epithelium, it kind of clears off the folds. At this point, I wished I had some alcohol with me so I could remove the epithelium more easily. So that would be something I would keep in mind to keep that ready. So at every point, I tried to remove the epithelium, especially from the visual axis. It did take a lot of time, but patience was required in this situation. Then I inspected at every point using water repeatedly to see for flaps and removed the epithelium. After I felt that the flaps were out, I hydrated the flap and tried to float it back into position. Because of the hinge, it came back in its position. I was comfortable with the orientation of the flap. And after that, I let it sit for some time, let it adhere for at least 2 minutes. There was no hurry from my side to kind of finish off the case. While I was waiting for it to adhere, I used a bud and tried to remove the fluid from the gutter area, simultaneously checking if I could get a symmetrical gutter, which is a little difficult to see because the epithelium was removed from the host bed, but it looked quite symmetrical to me. At the end, BCL was put on the eye, which stayed for about 7 days. And on post-op day 1, the patient did have inflammation, but on post-op day 7, she was absolutely fine with 6/6 vision and very happy with the correction with no striae, which was seen in the pupillary area. So I would like to conclude by saying that if you see a flap dislodgement, it's an emergency. It's okay. You can manage it. Remove the epithelium. The epithelium will not will prevent your folds from going away, and it can be easily tackled by most refractive surgeons in their own settings without resorting to a corneal surgeon. Thank you.
Thank you. Thank you, madam. We have with us our senior panelist, Dr. C.R.S. Mehta. Sir, would you like to make comment, please?
Yeah, can you hear me?
Yes.
Yeah, 2-3 things. You know, when I started doing LASIK, I also used to do all these 100, 110 micron flaps. And then I had all these flaps moving here and there. That's why I stopped doing it. So if I did LASIK today, it would be like 130 or 125 or 130 microns. And I've kind of stopped doing microkeratome LASIK. I just dissuade the patient, or I make some excuse, acha nahi hai, something, and just push them out so that I don't have to deal with stuff like this anymore. But this was very nicely managed case. What I would do was, first of all, start with a thicker flap. I agree that you have to move the epithelium away, otherwise you'll get a nasty epithelial ingrowth, and I've had those as well. And Vardhaman will agree that now with Smile, we don't see all this stuff anymore, and we don't have to hold our breath when we see the patient the next day, is the flap sitting in place or no. And I always use a PCL with LASIK case. However nice it looks, however good the flap, however good the femto edge apposition, I would always use a PCL. And since I started using a PCL, usually I don't see this anymore last few years. But yeah, all this has happened to me as well. And especially with the ultra thin flaps, you are going to get some striae, however nicely it's done. So don't be worried about that. As long as the patient sees well, and you can see the striae, but patient can't see striae. So what difference does it make? And so I think they're very well managed and very nice and well done.
Thank you, Dr. Cyrus.
Dr. Ankit, would you like to comment?
Yes, nicely managed case, ma'am. Just want to ask and have an opinion about what is the take of suturing such flaps, because sometimes patients whose flap have dislodged, they have a tendency to dislodged again and again. So is there a role of suturing such cases, suturing the flap for some time and then removing the sutures later?
So I would keep sutures for, say, a patient with a late onset displacement, wherein the flap folds haven't released that well because of the fibrosis. And of course, if there's repeated dislodgement, then I would suture. But in the first setting, I would not suture. But yes, it has been described very nicely and it works pretty well. Any other panelists have any comments regarding this case or?
Yeah, I have one final comment. You know that now I think in the future, Vardhaman, the era of the microkeratome is basically over now. Dead and gone like the dinosaur, like ICC. And so eventually we have to tell patients that, see, you have to do a femto LASIK. There is no other LASIK. And remember that somebody who can afford 40,000 for LASIK can afford 70,000 for femto LASIK. They will not go broke, etc. They will go to Thailand and spend 5 lakhs on their holiday instead. So eventually now, I think most of the problems we see with LASIK are microkeratome driven with irregular flaps or buttonholing or thin flaps, etc. Eventually, everyone all the patients have to understand that it's time for femto LASIK, and the microkeratome, I think people will stop making it also in future.
Yeah, definitely. I think the era overall is going towards bladeless procedures. And as I think Cyrus has correctly said, now it is going towards also flapless procedures. So I think probably we will not be able to see such flap complications in the future, because not only with Zeiss when they came with Smile about a decade back, but now we have many other manufacturers also which are coming up with their own versions of Smile procedure, which is the flapless and bladeless procedure, which is procedure of choice for both me and Cyrus for a long time. And I think wonderful inputs. Thank you so much, Cyrus, for being there on a busy Sunday. Thank you so much for your comments. Thank you. So I think with the paucity of time, we will go to the last case. We have only 8 minutes to go for our session. The next case is by Dr. Neeraj Israni. He is our young star who practices in Mumbai, does a lot of innovative work. He's going to present his interesting refractive case. And to discuss this, we have our junior expert, Dr. Amruta Ajani, and senior expert, Dr. Namrata Kabra from Jalna. Over to you, Neeraj.
Thank you, sir. Am I audible?
Yes, yes.
Okay. So quickly, since we have shortage of time, I have 2 cases to present. So the first case I've named it new software, old problem. This is a game changer in refractive surgery. Now, we all know that refractive surgery is nothing but hunt for at-the-risk corneas. topographer normally gives us a diagnosis of a frank keratoconus, but subclinical KC and KC suspect is what we have to usually look for to prevent ectasia, obviously, if we perform a LASIK or a PRK. Now, what happened was that this friend of mine came down from the US. He was a 32-year-old male. And as you can see, in his case, the refraction was absolutely normal. I did a cyclopentolate refraction, which I do for all my cases. And I saw a normal topography. This is a normal bow tie appearance with a good K1, K2. He has a pachymetry, is a little on the lower side, 482, but that is not my cutoff. If you see the bad D is on the borderline. Same thing with the other eye. It's a good bow tie with a good K1, K2 values. 481 is the thinnest pachy. Again, bad D looks okay to me, not too much on the borderline. Now we have three options. Obviously, I chose for the PRK because I thought he had enough time. So I chose trans PRK. However, this patient then went to another senior surgeon for a second opinion. And the senior surgeon called me and told me that he's performed an epithelial map for the patient, which looked normal. He had access to the corvus. So he told me that Neeraj, the patient's corvus is on the higher side. So as you can see, the CBI, TBI over here is more than borderline. It is on the higher side. And then same thing with the other eye. We came to know about this new software which Narayan Netralaya is working extensively. It's called Accusimics. Now, Accusimics is the world's first finite element simulation along with artificial intelligence. It actually gives you ectasia risk estimation. So let me explain to you what it does. It takes into consideration the data from your tomographer, corvus, epithelial maps, and the other demographic data. And it gives you a prediction of how much is the risk of ectasia for the patient post-operatively. So it takes the entire 1 day to perform this because it's an entire software which takes place. And this is the report that it gave us. So this report, as you can see, a normal corneal stiffness starts from 102 onwards. So 130, 140, that is what the stiffness should be. If you see on the right-hand side, this is what it stimulated and gave us, that the preoperative stiffness of this patient was 67.97 in the right eye and 66.51 in the left eye. And post-operatively, the stiffness would be 64.97 and 63.51. So after this software, obviously the patient, I was not confident to perform LASIK because the software told us that this is a low or a moderate risk for ectasia in the patient. So my question over here would be, is this a boon or a bane? Are we going to keep neglecting cases like this? Now let me quickly go to the second case. So the second case is again a friend of mine who again came from the US, 22-year-old female. And the surgery, this was during the lockdown, when there was a lockdown before she had come down. And she had more than 14 hours of screen time. She had only myopia in one eye, that is minus 2.25 with minus 1.5. So I thought of just doing the right eye, and I thought left eye we can leave alone because the 0.5 will not make a difference, and obviously we wouldn't do anything for that. So everything was absolutely normal. I did a dry eye workup for her. Only thing that I had a hiccup was that she had acne and she was on treatment for acne. So I did some research and I saw that there is no correlation between, it's not a contraindication. She was on a drug like isotretinoin, a US substitute. Her topography came out to be absolutely normal. As you can see, 545 was her thickness. I gave her 3 options. The reason she chose trans PRK because I told her pros and cons of all the options, and she said, okay, I have enough time, so I did trans PRK. So I did the trans PRK. Surgery went uneventful. MMC 0.02%. 35 seconds is what I used MMC for. And I started the patient like I do on antibiotic lotipred combination immediately. So I saw that the epithelium was not healing for 5 days. I realized.
लेकिन ये बात कर रही हूँ अपन मिक्स नहीं कर सकते उनके अंदर तो खाली ये सुनो.
Hello. Yeah. Please try to sum up in next half a minute, please.
Yeah. So the epithelium actually was healing slowly. And this is when I started the patient. I removed the BCL after 7 days and started the patient on cyclosporin. So the patient had 6/9 vision and the patient wasn't happy. You can see a haze over here. And 6/9 was the vision. Now this was the anterior segment OCT. You can see a little bit of haze. Now my question is when everything was normal, why was there a haze? Can it be related to acne? Can it be related to delayed epithelium healing because of the lotipred that I started? Can it be because of high screen time? And lastly, I read about mask, which is mask associated dry eye. This is my last slide. So it is said that when you wear a mask, especially during the COVID time, the CO2 is getting exhaled and it actually goes and causes the hypercapnic air causes ocular discomfort to the eye. Was that a reason for the haze and the less vision in this patient? So these are my few questions which I would like to get answered if the seniors can help me out.
Thanks, Neeraj. Very interesting cases, both of them. First, can we have Dr. Namrata Kabra, our senior expert, to comment on both the cases?
Yes, doctor. Both the cases were really interesting. I would like to comment on second case. Patient was on isotretinoin, which is known to cause dryness, dry eye disease. So probably that can be related to your delayed healing, and delayed healing is a known cause for development of haze. So all this can be related and can be explained based on use of isotretinoin. Because as per books, what they say is isotretinoin treatment should be disconnected or discontinued at least for 3 to 6 months beforehand. And even after performance of LASIK, for 6 more months, isotretinoin is contraindicated.
Yeah, isotretinoin as...
I do have a couple of cases where delayed start after post-op LASIK of isotretinoin caused dryness. And after 3 years of performance of LASIK, patient came to me with a complaint of some difficulty in vision. And when we inquired, it was actually isotretinoin, which was causing dryness and difficulty.
Such an impact, 10 mg of isotretinoin a single day would leave such an impact. Only high doses is documented. The lower doses are not documented.
It can be one of the cause. I am not saying, because no one knows in your case what can be exactly the cause, but yes, that seems to be relatable.
Yeah.
And by book, we should stop isotretinoin pretty beforehand, before planning any refractive surgery.
Thank you, ma'am. Thank you.
Thank you.
And are there any studies available for that new software?
So there are no studies available. It is still an ongoing process. And so basically finite element done for a lot of heavy-made bridges, which what they do is they simulate on the software how much strain and stress can a bridge take or can an airplane take. So they're using this on the eye now and taking into consideration of the eye, the values from the forways. So it's software which is being developed. A lot of studies, a lot of long-term results need to be done on that.
Would be really interesting to see the further results.
Thank you.
Thank you.
Dr. Amrita, would you like to comment? Dr. Amrita?
Hi. Thank you, Amos. Am I audible?
Yeah.
And yes, Neeraj, congrats on having so many patients from the US. So I have one question each for the case. As we discussed that dry eye could have been a possibility, right? Because of either the isotretinoin or the mask. But here you mentioned you did the complete dry eye workup. So, and your dosage was also less, as you correctly pointed in literature, that dosage is not actually supposed to cause anything. And your dry eye workup was normal. So I wonder if other reasons could have been MMC, which you have used, power, which was minus 2.5. Again, that is not a cause for the haze. What I want to ask you is, when did you start the steroid and what steroid did you use?
Post-operative, I usually start on Lotipred antibiotic moxifloxacin combination with the BCL on.
So do you start on day one?
Yes, I start with the BCL on. Initially, I used to start on only moxifloxacin. But then I have seen good results with time because it actually helps in. Lotipred is a very low dose steroid. It does cause a delayed wound healing according to the literature again. But if in your opinion, what would it be better to just start on antibiotic?
So actually haze, what is haze? It's just the activated keratocytes which are transforming to myofibroblasts, which are showing up as haze, right? So this is basically an inflammatory response which needs to be tackled at a particular time, which is about say 48 to 72 hours. So a lot of people who delay the steroids because many people feel that the epithelial healing would get delayed. We should also at the same time realize that this anti-inflammatory response at the right time is very important. So yes, you actually did that also. So I don't think we have the answer for your haze.
Instead of lotipred, would a dexamethasone actually help better?
Probably, yeah. Or yes, a stronger steroid probably could have done better. But again, your refraction was minus 2.5. You did use MMC. So there is not lots that you could have predicted, could have gone wrong, and you would have landed up with the haze. And yeah, looking forward to the software also. And how much of follow-up do you have right now with this software?
So this is actually, we cannot have the software. We need to send the data to NN or the
Oh,
senior
okay.
software. And it takes one entire day to calculate. So
Okay.
it is not available in the market.
Available, okay. Fine. So looking forward, and thank you so much.
Thank you. I think all the panelists and all the experts, thank you, Neeraj, for the last cases. They were very, very interesting. To first conclude, I would like to now ask Dr. Prakash Kangriya, sir, our chairperson of refractive session, to say a few words, and Dr. Jivan Ladi, sir, and then we have to give it to the next session, please.
Yes.
I think you have to unmute. Unmute. Mr. Sunil, can you please help Dr. Kangriya? Yes.
Yeah. Dear friends, all panelists, thank you very much for sharing valuable tips in this 1 hour. Of course, the refractive surgery, which was 10 years earlier, has really changed its face now. And now you will find every 1 year adds so many faces. And now it gives more completeness to the real dream of a person, to give a complete vision to the man, or say a human being who is coming to him. You have got a lot of combination, you have got a lot of choices, and of course, like you have now more understanding of refractive surgery. Of course, all panelists have really opened up all faces and has given overview of refractive surgery, and probably refractive surgery is one of the most rapidly changing science in this world, and more getting perfected. So thank you very much, all panelists, and I'm sure the viewers have got really much more opening of the different phases of this wonderful science. Thank you.
Thank you. Thank you, sir.
Yes, sir. Thank you.
We have Dr. Ladi, sir, to say a few words, and then we have to conclude.
Hi, Dr. Vardhaman, Dr. Shirish, Dr. Prakash. Thanks a lot for the opportunity. It was excellent presentation by everybody. Very good discussion, and it's really taking the CME forward and really successful, I would say. Thanks a lot. Thank you.
Thank you so much, sir. So thank you so much, Dr. Shirish, sir, for co-moderating this session. He is our future president of Maharashtra Ophthalmic Society. And now we will hand over to the next session of cornea. We would like to ask Dr. Sumit Lahane and Dr. Nikhil, sir, to please take it forward. Thank you.
Good morning, friends. I think we are already about 5-6 minutes late. So without much delay, I'd request Sumit, if your network is good, maybe you can invite the chairperson, co-chairperson. So we have Dr. Quresh Maskati, who is the chairman today for our session. Dr. Prakash Marathe is the co-chairman, and me and Sumit are the moderators. And we have nice cases with presenters, and panel discussion will be there. So I'll ask Sumit to invite the first speaker and go ahead. Thank you, Sumit.
Thank you, sir. And thank you, MOS, Dr. Vardhaman, sir, Santosh, sir, Aditi, ma'am, and Anaga, ma'am, for this beautiful platform. We'll start the cornea session. Our first speaker will be Dr. Rashmi Shukla, ma'am. Ma'am is a senior cornea consultant at Hinduja Hospital, and she will be presenting case on the allogenic slit in a child. Over to you, ma'am. Yeah, the slides are visible. You can start.
Is the slideshow visible?
Yeah, everything is visible, ma'am.
Not in slideshow, just put it on slideshow, Doctor.
Yeah.
Dr. Rashmi, put it in slideshow and you can start.
Yeah, that's what I'm doing.
Oh. Ma'am, you stopped sharing.
Yes.
Just reshare and
Yeah.
during reshare you can do it.
Ma'am, if there is any problem, should we go ahead with the second presentation?
Yeah, you all can start with the second.
Yeah. Dr. Swapnil Bhalekar, sir. Swapnil, sir, you are ready?
Yes, I'm here.
Yeah.
Yes, I'm here.
Yeah. So, Swapnil, I would request. Yeah. Please share the screen. Swapnil sir is a cornea refractive surgeon. He has done his fellowship from LV Prasad Hospital and he runs a tertiary care eye institute in the Shirur. He has a keen interest in ocular surface reconstruction and the keratoprosthesis procedure. So you'll be talking on Tennant's patch graft. You can start, sir.
So my slides are visible?
Very much, sir. Very much.
My slides are. Yeah, thank you. So thanks, Sumit, for kind introduction. And let's go ahead with the case of Tennant's patch graft. So this was a gentleman who presented with this kind of picture where he had an inferior corneal melt, and he came to me in the emergency after getting the tuna in his eye. When I removed the tuna, this was the picture. His inferior cornea was almost melt. And now, in this particular scenario, when you don't have the tissue in hand or anything,
your slides are not moving, Swapnil. We are
you
still on first slide.
Yeah. So I'm on first slide. I'm describing on the first slide only.
Oh.
So I have only
Title
3 slides.
slide.
So first option was, first option was Sanaclate glue plus BCL. Second is multi-layered AMG. Third is patch graft, and fourth was Tennant's patch graft. So we'll discuss one by one. So if I do Sanaclate glue on such a huge area, all of you will agree that it will induce
We can't see the picture, Swapnil. We can't see the picture.
Can you
Patient
see
eye.
now?
No, only your title slide.
Can you see now?
Only the title slide is visible, Swapnil. Yeah, now we can see.
Can you see the video?
Yeah.
Okay, so I'll directly go to the video. So this particular gentleman had an inferior corneal melt. So only option left was doing a Tennant patch graft, because if I do a corneal patch graft, that will induce a lot of astigmatism because sutures will come in the center. That's where I decided to do a Tennant's patch graft in this particular case. So when I took the patient on table and cleared all the necrotic area, you can see that all the inferior cornea is almost melt. So I started with doing the inferior conjunctival periotomy to create the area for suturing, and then measure the area where from where I'm going to take the Tennant's graft. And this is where I took the thick Tennant's, almost around 8 millimeter by 5 millimeter graft was needed. So I selected right away from the area of melt. And that's where, this is how we can harvest the Tennant's. So this is a very simple procedure how to harvest the Tennant's, all of us know. And then the fibrin glue was applied on the area of melt. And when you take the Tennant's graft, press it firmly onto the area of melt so that it will sit nicely. It's slightly bulky, but yes, if you nicely iron it out and press it properly, it will sit nicely with the fibrin glue. And this is very important part, suturing. So you have to pass the overlay sutures.
We are not seeing your video.
And the important.
We are not seeing your video. We are only seeing the second slide.
Oh God. I think there is problem in the connectivity. Can you see the video now?
Yeah, it's not moving, but it's there.
It's moving for me actually, in the connectivity issue.
You can play once, like try.
Is it moving now?
No, sir. You can, yeah. Now it's slowly moving, sir. It's a net lag which is there.
Now it's moving?
No.
I'm facing some connectivity issues here. Maybe because of that problem is there.
So you can directly show the final post-op also. Sir.
Okay.
We can have a
So can you see this slide? Can you see this slide now?
We are still on video, sir. We are still on video.
Video is moving in spurts.
I'm not sure what is happening. So this is the final slide. Is it visible now?
No, sir. You need to move again. We are still stuck on the video.
I'll stop share and reshare again so that I'll.
Okay. Meanwhile, I would request our esteemed panelists to have a discussion on the TNN patch graft and what could be the other options in such cases. Sangeeta Wagman.
So I think, am I audible?
Very much, ma'am.
Okay, so I think the tenants patch graft is a big boon to all of us for sealing leaks or to prevent further thinning. And you can use it in single layer or multi-layer. You can use it with glue or sutures. And of course, it does result in a little scarring. The biggest advantage over glue is that it attracts less vascularization. It doesn't prevent it completely, but it is definitely less. And you get increased tectonic strength at that point. So I think it's a very simple procedure. And if it's done well, it could be done, you don't need too much of expertise for this. And especially in peripheral areas of thinning and leaks, it could be like a permanent curative procedure. In central leaks and thinning, it can buy time till it heals up and you can do an optical graft at a later date.
I think we have lost Swapnil, probably is not here anymore. Swapnil, are you there?
Yeah, I just know I'm facing some connectivity issues. So can I show just one slide, last
Yes.
slide?
Yeah, last slide shows. Yeah.
Yeah. So is it visible now?
No,
Is
doctor.
it visible now?
No, doctor.
I'm so sorry. Probably but there is some connectivity issue on my side.
Screen share.
Already shared the screen.
Should we go to Rashmi or Reddy?
Yeah, I can start.
Yeah, I think you can start then probably. If Swapnil comes back, we'll put his last slide later.
Yes.
Go ahead, Rashmi. Put on your full screen and start.
So you all can see my slides?
Yeah, put it on full screen, please.
Yeah, are they moving?
No, nothing is moving. Only title slide is there.
Doctor, you need to change the view to PowerPoint show. Just go. Doctor, don't stop sharing. Just reshare, please.
Yeah.
अभी stop मत करना. उस पे view में जाके PowerPoint show कर देना बस.
Is it showing now?
No, doctor, you need to share again. You stopped sharing.
Okay.
In the meanwhile, Dr. Nikhil, can I ask you a question about the previous presentation? Yeah. Would it have been possible to do a AMG in Swapnil's case or?
So basically, the thing is that decision making. I think the AMG does not have much tectonic strength. So if you are facing a situation where the perforation is large or area of melt is large, then the tenons does have some tectonic strength, and you can put overlay sutures and you can put glue and try to sort of seal it. just the AMG alone possibly may not, always be able to seal the thing. It might just bulge out, or it may not. It may give way, sort of thing.
Yeah.
So is the internet wrong at everyone's place, or it's just that there is some other issue?
Nikhil sir, meanwhile, may I ask one question to Maskati sir?
Go ahead, Namrata.
Yeah.
Sir, I would like to hear you regarding your experience of Gunderson flap in such cases. We hardly have any experience with Gunderson flap. So have you used such type of flap for these type of conditions?
Namrata, no. Though I am a great fan, as you know, of Gunderson's, I use it for total conjunctivoplasty as a permanent solution for PBK in blind eyes, or as a waiting game for in corneal abscesses. I use it as a total. I don't use a partial because it tends to recede. So in these cases, I would prefer either a multi-layered AMG. See, when you get AMG from the eye bank is huge. Even the smallest piece from, at least from our Parel eye bank, is quite big. You can cut it into small pieces and stuff it into that opening, and then put another larger layer on top. So if you are not well versed with tin and patch, you can use a multi-layered AMG, but otherwise I would prefer a tin and patch.
Okay, sir. Thank you.
Thank you.
The other problem with the conjunctival flap would be that you'll create limbal deficiency, total deficiency if you want
partial.
Yeah.
If you're doing a partial flap, yeah.
Yeah.
But biggest issue is that it recedes. A partial flap doesn't stay. Go ahead, Rashmi.
Yeah, are my slides visible now?
All good so far.
Thank you, sir. And thank you, Team MOS, for this opportunity. So I'll be presenting a patient with bilateral limbal stem cell deficiency, in which I performed allogenic simple limbal epithelial transplantation. So this was an 8-year-old boy. He came with bilateral LSCD due to balloon cylinder blast injury at 6 years of age. So the left eye, although had total limbal stem cell deficiency with only 1 clock hour of healthy limbus, he still had a stable ocular surface and a clear central visual axis. But the right eye, as we can see, progressed over 6 months with this presentation. Initially, the central axis was clear. He had a vision of 6/18, but over 6 months, it progressed with complete pannus and conjunctivalization, and the visual axis was also obscured. So for the left eye, we only observed, and the right eye, he underwent living-related allogenic slet from his mother. We could not consider sibling-related allogenic slet is better. He has a sister, but who was 1.5-year-old at the time, so that was not an option. We went ahead with the mother, who had the same blood group. So the patient achieved post-op stable ocular surface with a best-corrected visual acuity of 6/12, and he was maintained on a tapering course of oral and topical steroids, tacrolimus eye ointment, and mycophenolate mofetil 750 mg per day. At 12-month post-op, the MMF dose was reduced to 500 mg per day. At 13 months post-op, he presented with features of acute slet rejection with decreased vision, redness, photophobia. We can see this raised epithelial line like a ridge in the center of the cornea, which stained with fluorescein. Above this line, the cornea was hazy, and there's a leash of blood vessels which are coming from the nasal limbus. So this acute rejection episode was treated with intravenous methylprednisolone 500 mg, which was given for 2 days, hourly prednisolone acetate eye drops, and the dose of MMF increased again to 750 mg per day. He responded well, and with time, the rejection resolved with some scarring and a stable ocular surface. Visual acuity improved to 6/18. He did also improve with contact lenses to 6/6, but this patient would not wear contact lenses. So in conclusion, in this patient, alloslet was considered only after documented progression and decrease in vision after multiple counseling sessions and discussion with his parents. The typical sign of acute rejection should be picked up early to prevent complete epithelial defect or failure of the transplants, limbal transplants, and to prevent the recurrence of LSE. Because this rejection line stains with fluorescein, it might be considered to be herpetic, as it may appear like a pseudodendrite, so that should not be the case. Thank you so much.
So I'll request Harsh and Rohit, if they're there, to have a few questions and discussion.
Nice case, Dr. Rashmi. It's quite rare to do a alloslet in pediatric age group, actually. And the main reason is the medications that have to be continued for a long time, and they can have side effects on a pediatric population. The other nuances I would like to add is that you should also treat the adjuvant anomalies. Generally, children come with multiple things. Usually, symblepharon is quite common. So, treating the symblepharon with conjunctival grafts is one important point. And tarsorrhaphy is a good option in pediatric age group because BCL tends to fall in them. Also, Dr. Alok Sati described a mini slat technique where the stem cells are placed directly on the cornea and an amniotic membrane is placed over the stem cells, like a sandwich type, not exactly a sandwich, but a covering. So that also helps in this. And finally, if you want to try and avoid alloslat, then maybe you can think about sequential conjunctivoplasty or a cleft procedure where they can be grown in a lab in a better way, and try and avoid an alloslat probably. So these are my points. I would just like to ask you, do you find any difference in the causes of stem cell deficiency between the pediatric and the adult population? And how long do you continue your immunomodulation regimen in such cases?
Yeah, thank you, Dr. Harshvardhan. So definitely points well taken. Tarsorrhaphy is actually a must in this patient. I did do a tarsorrhaphy because in a pediatric patient, tarsorrhaphy is required. And your question about differences in, so this age group will generally be injuries, especially chemical injuries. And in adults, you would have other autoimmune conditions generally, which will cause bilateral, such as SJS or ocular cicatricial pemphigoid. Of course, you would have chemical injuries also in adults, but in the pediatric population, you would generally see chemical injuries.
You can also have GVHD and VKC as causes in children.
And this particular child did not have a symblepharon. I just also want to add one thing about the immunomodulation that you said is, so this patient will not be off immunosuppression ever. They will definitely need even oral steroids and topical steroids in some dosage. They cannot be completely off. After about 1 year, 2 years, 3 years, we can consider bringing down the oral immunosuppressive, that is mycophenolate in this case. But then there is a protocol which is described by Swapna Shahanbag et al., a group where they can you can give pulse IV methylprednisolone. So after the initial, it is given pre-op, and then 1 week, 1 month, and then every 6 monthly or early IVMP can be given to the patients, and we can bring them off the systemic immunosuppressives. But some form of oral steroid or topical steroid is still needed in these patients. They will not be completely off treatment.
Yes, I was just going to say that you could read the review of SLED by Swapna Shahanbag and Sayan Basu in IGO. It's a good,
yes,
very nice article.
Mentioning the same.
Swapnil?
So this is my last slide. So this was the inferior corneal melt where the overlay sutures were put over the tenons. So the point I was trying to make is that the suture, when you're putting overlay suture, the center where it is crossing, the suture is crossing, it should come in the center of the graft so that the compression would be in the center and the graft would sit nicely. Initially, it appears very, very bulky. Don't worry about it. Eventually, it gets flattened up, then it gets vascularized. And eventually, as you follow up the patient in 6 months to 1 year, even the vascularization come down. So in this patient, if I would have done the corneal graft, it would have induced a lot of astigmatism. But with this outcome, after 2 years, patient is now around 612, and with RGP is improving up to almost 6966. So the Tenon's patch graft is a savior in such cases where you don't have the tissue or you don't really want to go for the transplant. And also the AMG cannot provide that tectonic support. You can use this Tenon's patch graft even in larger perforation. That's the point I was trying to make.
Thank you, Swapnil. I think that was a nice case. Dr. Parul is there. She can have some comment. Maybe she's one of the discussant here, but otherwise we can proceed to the next case, which is on
these 2 points that the take-home points is do not do this Tenon's patch graft in infective cases. It tends to melt. So do it only in sterile corneal perforations, especially in Steven Johnson and OCPs and all those cases where dry eyes cases where you get perforations without mostly without infections. So don't do it in infective cases. It tends to melt most of the cases. Thank you.
Dr. Kavita, you're there. You can present your case.
Yes, sir. So my slides are visible.
Please go ahead.
Thank you, MOS, for this opportunity. I'm presenting a case series of 2 patients of bilateral superior limbic keratoconjunctivitis. This is the first patient who is a 42-year-old gentleman who had complaints of both eyes, redness, watering, and eye pain. It was there since 2 months, but similar history was there almost since an year, and he was using topical medications for the same. On torchlight examination, you can see that the superior part of the conjunctiva seems to be congested compared to the inferior part of the conjunctiva. Visual acuity was normal. On ocular examination, we can make out the leash of blood vessels in a triangular fashion in both the eyes, left eye more than the right eye, and he also has an typical exudative nodular lesion on both of the limbal region involving the superior 1/3 of the cornea as well. On Lisamin green stain, we can see that the conjunctiva and the infiltrate is the exudative lesion has taken up the stain. Investigations, routine investigations along with free T3, T4, TSH was done, and the T3, T4 has come normal. Coming to the diagnosis, we can note that he's a young gentleman with bilateral limbal conjunctivitis limiting to superior conjunctiva in a triangular fashion with tarsal involvement in with an limbal exudate of 1 clock hour. Treatment modality, we started him on antibiotic steroid combination with a tapering dose along with lubricants and tacrolimus ointment HS. And he has very nicely responded in 1 week's time. The superior conjunctiva has come down, the congestion is come down in this patient. Now the second patient, similar history, but he's in a diabetic and hypertensive, complaining of dimness of vision along with the foreign body sensation and itching. He had also laser treatment done for his eyes for diabetic retinopathy. On ocular examination, you can see a similar kind of presentation on the superior conjunctiva involving the left eye more. Here you can see partial LSCD along with the superior corneal edema along with the blood vessels. Investigations in these patients, along with the routine investigations, we have done thyroid examination, and this has come altered, and we have started him on thyroid medications as well. This patient also responded very well to this treatment of steroid antibiotic combination along with tacrolimus and cyclosporine. We have added him later on for the long term. With the treatment, there was regression of symptoms, and we have tapered the dose in almost a 4 to 6 weeks month. And we have maintained him on cyclosporine BID along with tacrolimus HS on alternate days, and 6 months of follow-up, and he has there is no recurrence in this patient. Overview of SLK, it is a chronic inflammatory ocular condition limited to superior bulbar conjunctiva. It could be missed if the lid is not been lifted up, and thyroid function are supposed to be assessed. Sometimes it comes positive. Pathogenesis is yet to be unknown, but mechanical cause is most likely. It usually resolves without treatment as well, but medical and surgical treatment modalities are also available. These are the possible risk factors and the treatment modalities of topical and surgical therapies. I would like to discuss how the medical management, how long should it be continued? The surgical management, should we go directly for the resection, and should we wait for the medical management? If it is not responding, then should we go? And is there any specific investigations limited to these patients? The case is open for the discussion. Thank you.
So thank you, Dr. Kavita, for the nice case. A few comments. First of all, amongst cornea specialists, we are okay with starting steroids, but somehow the general ophthalmologists kind of are not very happy starting steroids, and otherwise give, say, lotepred. They need to understand that when the inflammation is high on the ocular surface, you require a more potent steroid, say Predfort or say Dexa. Also, for patients like these who may have filaments, acetylcysteine eye drops works very well. We just have to make it using mucomist injection, which is available with the local pharmacies, and it helps for symptomatic relief in patients with filaments. At this point, I'll add one thing that besides the thyroid investigation, it's important to note whether this patient also has a component of floppy eyelid syndrome. So a lot of patients, say obese, may have laxity of the upper lids, and that can have a similar kind of picture or maybe added to this thing. And it's very important because it has systemic implications on the patient's profile. And having this kind of irritation in the eye can actually trigger their whole, be a trigger for them to take care of their systemic status. Dr. Nikhil Gokhale, sir, if you can comment on whether you've used cyclosporin higher concentration in these cases, and any other panelists can comment on whether they would go for surgery first. Also, the use of autologous serum in these cases.
Yes, Sangeeta, maybe she can.
Yeah, so of course, one can go on to much higher concentrations of cyclosporin, and even the steroids very often, low dose steroid may not give you the best results. And in fact, before low dose steroids came in, I think Nikhil was one of the first proponents where we use Solumedrol diluted methylprednisolone eye drops to get an initial control, and then you can reduce. So in fact, we work from higher steroids to lower. A couple of things I wanted to point out here is that we also need to evert the upper eyelid, which also shows you significant inflammatory response, which can help you conclude the diagnosis. And here I'm not sure, Dr. Kavita, whether the superior bulbar conjunctiva showed similar staining. You would find an area of dense staining just beyond the limbus, which will help to conclude the diagnosis. And along with all this, I think just debriding that surface epithelium right from the limbus can help. Of course, there are many other factors like a floppy lid, and in 9 times out of 10, we don't find a systemic cause or association like disturbed thyroid. Another problem is the recurrence and the long-term treatment that is required in these patients, and somehow they do go into a spontaneous remission after a while.
So I normally am very fond of tacrolimus. So I do put these patients on tacrolimus for 3 months, then a break for a month, and then perhaps we'll again put them on for 3 months. And then if there is only recurrences, will I again add this? So it's a steroid sparing agent. And because SLK is known for its recurrences, I give them initial 3 months, break for a month, and then 3 months again of tacrolimus. I find there is very little side effects of this. Patients get quite used to the burning, stinging, which is at night.
So which are the brands which are better tolerated? Because I find a lot of variation.
I import my tacrolimus directly from Madurai, Tacliment. I find that is the best. They have, as I keep saying, they have very lousy marketing. So it's not available in the market. So I buy it in bulk, 12 tubes at a time. And when I'm down to 6, I buy another 12.
Excellent, thank you.
Yeah. I would like to add on. I do use a lot of tacrolimus. Talimus is one of the brand which our patients, as per their feedback, is better tolerated amongst whatever brands are available.
There is a Talimus LS also, low strength.
Yes.
So no financial implications.
In any of these.
But we use
let me clarify, no financial interest.
Yeah. So Entrax Soothe also seems to work well. So what I would suggest is a little rice grain to start out with the outer corner. And I'm not even sure whether the transdermal application helps. So I mean, I would start straight at the lid margin and then try to get them to use.
Sangeeta, we are blessed because we get tubes which you can put in the eye. But in many countries, the only available tacrolimus is a tacros thing, which is a skin ointment. And I have colleagues in Pakistan who keep bemoaning the fact that they don't get tacrolimus except skin ointments, and they've been using it and it works for most of the things. So they put it on the skin outside at night, and it enough trickles in to give them some effect.
But that is a much stronger concentration. I
Yes,
think
so it's only outside on the skin. It's not put in the eye. In the eye, it causes tremendous burning. Yeah,
true.
Dr. Nikhil, you had a comment.
I have just one very unusual observation. I couldn't find any reference, but these patients I have put on BCL for 2 months, and I have 6-7 cases. The recurrences have almost stopped. Of course, the medications are same and then tapered, and now there are no recurrences in last 2 years. These are the cases I have put BCL before lockdown. So any from the senior members how it is working, or it is just by luck? I don't know.
Yeah, it is just coincidental. It's like urine therapy and cataract prevention.
Did you do any debridement surface treatment because you put the
No, maybe because the floppy eyelids are rubbing on the superior conjunctiva, and that it is creating a barrier, and that is what I feel.
Yeah.
But then after removing BCL, I don't know. But patients are very comfortable just by putting a BCL in such cases.
Just for the benefit of everybody, could you briefly discuss what could be the differential diagnosis, like especially with the infiltrative lesions, infiltrates that you have seen at the limbus? We know that VKC is primarily a disease of childhood and adolescence, but we do have some adults who come with refractory. So is it possible that we are missing bilateral bulbar catarrh? And what are the other, like episcleritis, or especially the second case you showed, the left eye, could it be a sclerokeratitis of a mild form? So maybe we need to consider a differential in these cases when we are treating them and look at the other possibilities.
Okay.
Thank you. Yeah, so the next case is by Dr. Asmita, and it's on HSV. She's there? Yeah,
Yes,
please
sir.
go ahead. Yeah.
Is my screen visible, sir?
Not yet.
Doctor, you need to click on the green button on the Zoom window share screen.
Okay, this is taking a while. If the next speaker is ready, can we go ahead, because it's asking me for some permissions.
Dr. Ganesh, you can
Yes, sir, I'm available.
show your
Yes.
case.
Very good morning to all. Thank you for having me here. Today I'll be presenting on hello. Am I audible, sir?
Yes, yes.
Yeah.
Okay. Today I'll be presenting on an intractable VKC. Slide is not moving. Yes. It is a 12-year-old boy referred to me with both eyes having pulsing papillae and limbal involvement. Patient was treated multiple times in by private practitioner, had steroid and olopatadine multiple times. So I did a vitamin D level in this patient, and that was very low, 14.1. Also, allergy profile was done. Then a patient came positive for carrot, papaya, and buffalo dander. So on the treatment, I asked him to start a prednisolone 1% along with cyclosporine, lubricant, and vitamin D supplement was given, and asked to avoid allergens that will induce the recurrence. But on follow-up, papillae improved, but patient came with a corneal erosion. IOP was normal, so to avoid a further complication, I decided to go for a suprataxial triamcinolone. 20 mg of triamcinolone was given in 1 eye, followed by 15 days after second eye. This is the video of the case. It is a very easy if we place it in a proper plane subconjunctivally above the tonsil. About 0.5 cc easily can be accommodated in that space without any complication. Patient is very comfortable in a topical anesthesia. Post follow-up, patient was better symptomatically. I kept him on a topical cyclosporine 0.1% and asked him to avoid animal protein intake because he was allergic to animal dander. So now patient is doing well and symptomatically better than the topical steroid. Thank you.
Bhagwat and Dr. Kuresh, sir.
Yes, Dr. Ganesh, very well presented. I'd just like to ask one main question. At what stage do you actually decide to go in for supratarsal steroids? I mean, routinely, do you give for refractory or at some particular stage, like this patient came to you from outside after being treated for a few times, you know? So at what stage do you take that decision?
If there is risk of corneal involvement or risk of limbal stem cell deficiency, definitely we should plan for supratarsal steroid.
Okay, and we have a senior specialist here, Muscati sir, and all senior panelists also. I would like to ask a common opinion regarding, advising allergy tests for patients. When you're practicing in smaller cities, it becomes quite difficult to advise a patient to go in for an allergy test. So from your vast experience, is it really beneficial, sir, Muscati sir, like advising an allergy test, like what here Dr. Ganesh mentioned about animal proteins being detected as an allergen?
I normally reserve it for patients who've got other allergies. So if they have got asthma, allergic asthma, or an allergic skin disease, along with so you ask leading questions about the skin itchiness and about breathing difficulties and asthma. So if any one of these is present, then I have a low threshold for ordering allergy tests because the patient is going to benefit. But if it's purely an eye condition, then I just treat the eye as it were. Whenever there is a flare-up, I will give them an anti-allergic pill, an antihistaminic pill at night, one of those cetirizine or fexofenadine type of anti-allergic tablets at night, along with the treatment for the local. And local, as I said, there is now a lot of availability of dual agents, the bipotestine, the L-caftidine, the olopatadine are all available to us, and our requirement for steroid usually is less now. Having said that, all of us come across cases that Ganesh came across now where nothing else except steroid and tacrolimus. I use orosporin. Again, I import it from Madurai, 12 bottles at a time. So I give 2% orosporin and tell them about the burning, stinging, and that they'll have to put a teardrop 5 minutes or 10 minutes before and after the orosporin. But with all this, if nothing seems to work, I would also go in for a supratarsal triamcinolone as a last resort.
So yes. I would normally give supratarsal, when I come across patients with shield ulcers, So
Shield
typically,
ulcer, yes,
these children come with shield ulcers which need to be debrided because they are having a plaque on the surface. So anyway, I have to give them some sort of anesthesia. So at that time, you need rapid control of the cobblestone. So I normally combine at that time. Otherwise, in children, sometimes I don't think it's easy to give under topical anesthesia unless they're a little older. Most of the pediatric age group, you'll have to give it under sort of anesthesia sort of thing.
Yes, sir. And so it works more in kind of having those cases which are having more cobblestone appearance, tarsal kind of a variety.
There is a small segment of, Hita, there is a small segment of patients who for some peculiar reason the bulbar conjunctiva is not involved and there's only cobblestone on the top. In those patients, I debride the cobblestone area. Earlier, I was using amniotic membrane as a cover, but nowadays I'm using the patient's own conjunctiva, like you do for a pterygium. You harvest that and you stick it there or you suture it there. And it seems to work very well. There is some sort of, I feel that there is some preventive factor in the bulbar conjunctiva, which is preventing the cobblestone or the papillae from coming on the bulbar. And when that same bulbar is transplanted to the palpebral area, it seems to work reasonably well.
Okay, sir. Thank you, sir.
One word of caution, like before giving the supratarsal steroid, one must be sure that the patient is not a steroid responder. So I would give at least 3 weeks of even a low dose steroid will give you an idea of whether the patient is a steroid responder or not. And in spite of, I've had patients where I've done papillectomy with supratarsal, and those who are refractory are going to relapse come what may. In terms of allergy testing, unless we have desensitization in our armamentarium of treatment, just knowing, you send a patient for an allergy panel and he'll come with 15 things he's allergic to.
Yes.
The lifestyle gets completely cramped. Don't eat this, don't eat that. This is allergic. So, unless we have an answer to therapeutics, putting a person through an allergy panel for say 10,000-15,000 and giving them a list of 20 don'ts. I think we need to look at a more complete holistic approach. Like Dr. Quresh said, when there is systemic allergy and it's going to affect the quality of life, going in for allergy testing and desensitization using immunoglobulins makes a huge difference. So I think we need to weigh the pros and cons and then go ahead with our schedule. Like Nikhil, he's very well known internationally for his step ladder algorithm in the treatment of VKC. And I think there's nobody better than him to put this whole picture on a palette for us.
Also, ma'am, there was vitamin D levels which were mentioned. In this case, it was slightly reduced. So routinely, do you advise vitamin D testing, or only on those cases, in these cases where it is not responding to your usual treatment, where you're suspecting something else we are missing, or is it really beneficial?
So, like the pharma pushes the antioxidants and the anti-cholesterol agents for decades, and we've been puppets. I think this vitamin D, we need to really have statistics on our Asian population. See, all of us are dark-skinned. The light doesn't activate the vitamin D. And I would say 70% of the population you test is going to be low on vitamin D. So is it one explanation for all? Does it cause keratoconus? Does it cause VKC? Does it cause cataract? I mean, the answer is, who knows? There's no harm in treating the vitamin D deficiency, but I wouldn't implicate it as the cause for VKC.
I would rather do a serum IgA level instead of vitamin D. And maybe if that is something associated with the systemic, then I would rather prefer systemic therapy rather than local injections, because cyclosporin oral is much, or just 5 milligram steroid is a much safer option in such cases, especially with steroid responders.
So oral steroids, how long do you continue usually, sir?
6 to 12 months if required. Yeah.
Okay.
But a very
Any
low
experience
dose.
of using oral cyclosporin or tacrolimus in such cases?
I have used for quite some number of children who are absolutely refractory and they are on a path to blindness sort of thing bilaterally, So either you have recurrent shield ulcers, scarring, limbal deficiency, and, sort of situation where nothing seems to work. In those patients, I have used systemic cyclosporin orally and it works well. Only thing is, I would say it's a rare situation where you need to use it, because we should be cautious that we don't overdo it. So first do all your local treatments, and only as a last resort, maybe you can try and use these type of medications, so that only those we really require it, we should be using it, because it's expensive also, and it needs monitoring with a physician and other things.
I have been using it in very severe cases, many cases for that matter, in children also, in consultation with rheumatologist, because I have a rheumatologist visiting to my clinic every 15 days. So I can really say that it works very well compared to the local treatment, and the overall allergy gets controlled, including the systemic allergies and asthma, and everything gets controlled. So it works well, and the safety profile is also very good for tacrolimus.
Yeah.
Nikhil sir, when do you consider serum Ig levels and mast cell stabilizers in your treatment? Because we don't consider both the things in many of our refractory cases.
No, mast cell stabilizers we give routinely for most of our patients and as a maintenance therapy.
I mean, systemic mast cell stabilizers.
Okay. So systemic I don't use very often, unless the child also has sneezing and some systemic allergies or atopy. Like when there are multiple systemic allergy, if you give something systemically, it will try to take care of multiple things together. But if it's purely ocular allergy, then I normally, because it will cause some dryness of the eye as well.
Sir,
which
how
we don't
often
want.
you advise serum Ig levels?
See, again, all these severe cases, we do serum Ig, but again, we need to understand that all of them, serum Ig is not high. There will be a subset of VKC patients where Ig level may not be high. There will be another subset where it may be systemically high. So the only thing is that if it is extremely high, there may be some role of giving anti-Ig injections, which is again, but has been shown to have limited role in ophthalmic allergies. The omalizumab I've used on rare occasions, but where if the systemic Ig is very high and they have Again, refractory asthma, refractory other allergies, you could come, try to use it. People have published on that. But again, these are less common situations. IgE level or eosinophil counts, we might do quite often actually. Asmita, you're ready?
Yes, sir.
Yeah,
Sharing
go
the
ahead.
screen. Thank you, MS, for this opportunity. Is my screen visible?
Yeah.
Okay. So very good morning to all the panelists and delegates on this beautiful Sunday morning. So HSV keratitis, it's easy to miss a diagnosis. It's primarily a clinical diagnosis as we cannot rely much on the microbiology and the pathology. Also, it is different from other infective keratitis because we have to put these patients on steroids, which is in contrast to the other infective keratitis. HSV can present in various forms, of which dendrite is the one which we have commonly encountered and all of us have treated. But it can be missed if not carefully examined, or if it's in a very early stage, or if it's in the periphery where it gets camouflaged because of the arcus. Like in this case, a broad elimination, quick examination, it was almost missed until we stained the cornea and picked up this dendrite. So it's not an overstatement to say that fluorescent staining is the most important in any cornea case. And however good we think we are clinically, we'll be surprised to see what can be missed if we do not stain with fluorescent. Another scenario where a geographical ulcer or a dendrite can be missed is if the stroma is hazy or has some scar and edema, like this case, which was referred for keratoplasty or for a DSEC as a decompensated cornea. So when you stain, you pick up a geographical ulcer. Sometimes it can there can be a pseudodendrite, like an epithelial defect or a healing epithelium. So here, what comes to the rescue is a rose Bengal staining. Like this is not HSV keratitis, whereas, or not a dendrite, whereas here where we see the double staining is HSV dendritic keratitis. The next form in which the HSV can present is the immune stromal keratitis or HSV endothelitis, that's a disciform. So here classically what we see is a very localized edema with clear demarcation between the edematous and the non-edematous cornea. It may be central, disciform, a very nice round edema, or it may be sectoral. Now, when it comes with keratic precipitates and AC reaction, it's often treated as uveitis, and we add steroids. Without an antiviral treatment, the patient is going to come with worsening and a dendrite maybe. So any uveitis with a stroma, I don't think any other uveitis would present with corneal involvement. So that time we should have a high suspicion of HSV keratouveitis. Another characteristic feature of this localized edema in HSV keratitis is a pot belly edema. That is, there is a posterior stromal bulge in addition to the anterior stromal edema. Now, this slide is to differentiate between the viral and the non-viral form of edema. Like the second picture, it's localized edema due to a Descemet's detachment post-cataract surgery. Here, we do not see that characteristic clear-cut demarcation between the edematous and the non-edematous zone like we see in this first picture. So now, when this is the most challenging part of viral keratitis, that's a necrotizing variety where it looks like an infective keratitis. We have to do a microbiological workup to rule out bacterial, fungal, and other infective causes, but we have to be aware of the clinical features that are suggesting of viral. Like first, I always ask the patient about history of recurrence in the past, recurrent redness. So the patients, especially in the rural area, will attribute it to some vague environmental reasons or illness, which could be mild episodes in the past. And the vascularization and the deep vessels, which set in a very early stage compared to the other infective causes. Also, if we see rapid corneal melting in the early stage of the disease, we should have a high suspicion of viral, because we do see melting and perforation in bacterial fungal cases, but that's quite late in the stage. And in these cases, even if there is an epithelial defect, we do have to put the patient on steroids with antiviral cover. This case, which I very confidently diagnosed as peripheral ulcerative keratitis, did autoimmune workup, which came negative What I missed was this intense peripheral vascularization, and there were some deep vessels. And the patient came back to me with this and this. So when I added oral antivirals to the steroids, he responded very beautifully. We also have to pick up viral keratitis in its inactive state, especially for the patients who are going to undergo any form of surgery, because they need perioperative prophylactic antiviral cover. So what we call as HSV footprints. So if we see these vague corneal scars, which are irregular, patchy, some are superficial, some are deep, with deep vessels, we should suspect that this patient probably is a case of keratitis, HSV keratitis. Or if we see a non-healing epithelial defect or a PED with scar and vascularization like this. So these deep vessels are really trying to say something. Before posting these patients for a cataract surgery, do start them on the prophylactic antiviral. So summarizing, always stain to not miss a dendroid. Pot belly edema, localized stromal edema suggests intrastromal keratitis. Deciform edema, which is characteristic of HSV endothelitis. Beware of the deep vessels and HSV footprints for the perioperative antiviral cover. And most important is be nice and kind to the patient. Explain the recurrence because it is going to recur. Thank you for your patient listening.
Asmita?
Yes, ma'am.
You have very nicely and crisply presented all the various.
Yeah, I think we have lost you possibly. So Dr. Quresh, maybe if you have some comments.
Yeah, it's a lovely compendium of cases that you've assembled in 4 minutes. The only issue that you just mentioned in brief, the neurotrophic keratitis because of viral. Now, this is one place where you don't use antiviral. This is post-herpetic lesion, and these respond to steroids and other things like autologous serum drops. And of course, abroad they use a very expensive oxynervate drug, which is cost in the hundreds of thousands of rupees for this treatment. But neurotrophic is a different ball game altogether. But the other things that you covered very well. Just when you mention antivirals in any presentation, always mention local or systemic, because the audience gets confused about what you're saying. When you say you must give antiviral, you must mention systemic antiviral or local antiviral so that they know what you are meaning. Thanks.
Thank you, sir. Sir, but you're saying in these cases of PED, we put them on steroids without the antiviral. That I thought that applies to zoster HZO post HZO, but even for HSV, wouldn't it recur?
Once it's a neurotrophic keratitis, you get the characteristic epithelium which is rolled up and rolled outwards. These are neurotrophic, so you can scrape that area, but it's not going to heal with any antiviral. It could be post-herpes zoster, it could be post-herpes simplex, but it's not going to heal unless you use some form of steroids, tacrolimus, autologous serum. These are the things, and of course lubricants.
So, but if we're putting them on steroids, we have to give prophylactic cover of the oral antiviral as well, or we can only put them on
No, that is the whole thing. It is without antiviral, oral or systemic, oral or local.
Thank you, sir.
Dr. Prakash Marathe, sir, maybe a final few words of wisdom for all of us.
Actually, thank you. Good afternoon, each and everyone. I think it was a wonderful session and moderated by Dr. Nikhil Gokhale, chaired by Dr. Quresh Maskati sir. All the presenters, all the discussions, they did wonderful job, and all presentations really were very good.
Thank you, sir. So I thank all of
everyone.
Yeah. Thank all of you here, and I'll hand over to the next session who seem to be eagerly waiting. And we've saved 3 minutes, having started about a few minutes late. Thank you. Thank MOS for this opportunity.
Everyone. Thank you so much to the cornea session moderators and all the panelists and everybody. So I would like to invite the panelists speakers and moderators chairperson for the glaucoma session. I would like to first invite moderators Dr. Sachin Dharwadkar sir, who is our own scientific committee member, renowned glaucoma specialist who is based in Mumbai, and Dr. Mandar Paranspe sir, who is the joint treasurer of MOS. Please, you can continue with the glaucoma session. Thank you.
Sachin, you are muted.
Yeah, thank you, Dr. Aditi, for that kind introduction. Good morning and welcome all for the glaucoma session of the MOS midterm virtual conference. We'll continue to have the scientific feast that we had, and we're passing the batons from the cornea side to the glaucoma now. I and Dr. Mandar Paranspe shall be the moderators of the session. We are fortunate to have with us eminent glaucoma surgeons as chairs in the form of Dr. B.K. Nayak and Dr. Manish Shah, and also eminent faculty from Maharashtra who will give their inputs and make the session as informative as possible. So we also have Dr. Shefali Parekh, Dr. Gunjan Deshpande, Dr. Kunal Nikale, Dr. Pooja Bhomaj, and Dr. Rupali Nirlikar, as also Dr. Sneha Kankaria, Karishma Bhate, Amar Bhaskare, Sarika Shinde, and Radhika Sangeet Rao as eminent panelists for the experts for the session. Dr. Mandar?
Yeah, so we'll start with the first presentation. We have Dr. Nidhi Shetty from Mumbai. So if you could share your screen and start the presentation. And we'll have Dr. Pooja Bhomaj and Dr. Sneha as the discussants for this case. Can you share your screen, Dr. Nidhi?
Yes, just a minute.
Is there a problem, Nidhi, with sharing the screen?
I don't know. It's asking me some more permissions.
Doctor, can you do me a favor?
In that case, can we ask the next presenter to start, Dr. Mandar?
Yeah, sure. Dr.
So,
Gayatri Oshing,
yeah.
if you are ready, you can share your screen. You can start with your case.
In the meanwhile, I think the technical people can get in contact with Dr. Nidhi to solve the issue.
Dr. Nidhi, I'm sending you the steps.
Okay.
Yeah, okay. So Dr. Gayatri is sharing the screen, I guess. We can see it.
Even I am getting some permissions.
No, actually, you open your presentation first.
Doctor, I think you're doing it the first time. Just go to the system
No, I've done it
preferences.
in the morning actually. Just one second.
Just close the window. We can see actually.
Open the presentation and
You can
then
open.
share the screen.
Open the presentation and share the screen. That will be easy.
Request all presenters to keep the presentations ready.
And Dr. Gayatri has done it in the morning actually.
Dr. Gayatri, before you start sharing, just open your presentation and keep it ready.
Is Dr. Ashwini Gaikwad ready with her presentation? We can start with her.
Yeah. Can I see now? Can you be seen
Yes,
now?
yes. Yes.
You can see it. Go ahead.
Yeah. Am I audible?
Yes, yes, absolutely. Loud and clear.
Firstly, I would like to thank MOS to give me this opportunity to present this case. This was a 25-year-old male who had juvenile open angle glaucoma and was using steroid for some reason. He had a steroid response also.
Can you make it slide share mode?
Icon.
Yeah.
Click the slide share icon.
Doctor, at the bottom where it is showing 82%, next to that left hand side.
Otherwise, I think you can scroll like this also, no problem. If you can't make it out, you can scroll like this.
Yeah, the best corrected visual activity was 6, and 6, and his pressures were 38 and 42, 38 in the right and 42 in the left with 4 medications.
Your slides are not moving. You're seeing the title slide.
Now?
Click on the next slide.
Click on the next slide.
Click on the next slide.
Yeah, can I be seen now?
No.
You have to click on the next slide.
Next
Please
slide.
click on the next slide.
Yeah, in the left side.
Up at the bottom.
Gayatri, you need to go on slideshow.
Yeah,
Go on
it's not,
slideshow.
can I be seen now?
You are seen, but
only the title slide is seen. You can't see the
One slideshow.
One second.
the cup and the bottom.
Here, no?
Yes.
Click that.
Now?
No, click.
I think there is an internet lag.
I believe there are two devices installed at the same device. Just request you to kindly disconnect one.
There's an echo coming.
Can I be seen now?
Malik, madam, I think you have installed 2 devices.
We can't see your slides moving.
Okay.
Do it again.
I think you'll have to switch off one device. I think 2 devices are on at your place. There is an echo.
Now go on slideshow.
Doctor, on top, there is something on
can I be
slideshow.
seen?
Doctor, on top, there is slideshow. On the top banner, there is
On the top line, yeah.
on the top
Over
menu.
here.
No, it's
Home.
down actually.
Actually, on your presentation, the top bar, the fifth option is slideshow.
On your screen, go to the
On your
top.
screen.
Go to the top, and there will be those 5.
Gayatri,
Huh?
on the top after home, 4 to the right is
Yes,
slideshow.
yes.
Exactly. Click on that. Click on that.
Resume. Yeah, resume.
Yeah, can it be seen now?
No, you clicked on resume. Click on slideshow first. Go back again to that.
But there is some problem with the internet connection.
In the meanwhile, is anybody else ready?
Is doing it again.
Yeah, just click on the
Click on
slideshow.
next slide.
Panel also.
You're not clicking on
Just
it.
click on
Click-
next
Dr.
slide.
Gayatri,
Yes.
on your screen, right side down also, there is another marker. Yes.
Yeah, yeah,
Click
but-
on that, and also you need to share your screen. Otherwise,
Yeah,
it
my
will not
screen
move.
is shared, no?
Its
Yes, already
screen is shared. But she's not going to slideshow.
No, it's on slideshow.
You click it
See,
here.
Dr. Gayatri, even if you click on the next slide, it is okay for us. You need not
Click
go
on
to
the
that.
next slide. Click
Just
on the
click
next
on the
slide.
next slide. On
Left
the left
side.
side,
Go
there
to
are
the left side
this
and
thing.
click on the next
Just
slide.
Go to the next slide and
Now?
click. No.
Yeah, go to the left side and click on the
Next
slide sorter.
slide.
Is it coming now?
No.
Not clicking.
No.
Can somebody else please take over because
Yeah,
I think
please. I think we'll start with Nidhi, if you're
Use
okay.
the down arrow of your laptop. It should move the slide.
Yes.
because they are moving on my screen actually. I'll just take over.
Nidhi, are you ready?
No, sir, it's still showing me that I need to open some preferences and it is not sharing my screen. It's wanting a file.
I sent you the steps on the chat. I put it in the group also.
Okay,
Yeah, I
we'll
did
start.
that, but I'm not able to share
We'll
this.
start with the
screen
next
from
presenter,
here.
Ashwini. Is Dr. Ashwini ready? Ashwini Gaikwad.
Yes, sir. I will try and
Yeah,
share.
please share your screen.
इकडे आहे या side. Video off आहे.
Dr. Ashwini, are you sharing your screen?
Can you share the
Yes, sir.
screen?
Yes, sir.
Yeah, please share the screen.
Is there any problem with sharing your screen?
Yes, sir. Actually, it's I'm doing it.
Ashwini, your screen is also frozen.
Yeah, I think she has some internet issues. That's what I feel.
Sir, I got 1 minute. I will share.
Yeah, please do.
Dr. Ashwini, are you on mobile data?
Yeah, she's shared the screen.
Yeah.
Okay.
Is it visible now? Is it visible?
Yes, it is visible. You can start the slideshow. And for this case, Dr. Shefali Parekh and Dr. Ragita Sangitrao will be the experts. So kindly start the case.
Put it on slideshow mode.
Slideshow. Yes.
Right side bottom.
You can go to bottom also, or you can do it from the top.
Top also, yeah.
Right, इसके साथ वाला.
Is it visible now to everyone?
Yeah,
Yeah,
it's visible. Correct. Go ahead, please.
Am I audible to everyone?
Absolutely, loud and clear. Please go ahead.
Yes. Hello everyone. Good afternoon. This is Dr. Ashwini. I'm a glaucoma cataract consultant at PBMA's HVDC Eye Hospital, Pune. Thanks for getting me this opportunity for presenting an interesting case. It's an interesting case with hidden factor in glaucoma etiology. This 53-year-old male gentleman resident of Pune presented to us in 2001 with complaints of gradual painless diminution of vision since last 1 year. The rest, there was no significant other history. On examination, we found that in left eye, the visual acuity was 6/36 on Snellen's visual acuity chart. On anterior segment evaluation, the pupil was sluggishly reacting. On posterior segment evaluation, the cup to disc ratio was 0.95 with significant pallor. Right eye evaluation, the anterior posterior segment evaluation was within normal limit. The visual acuity in right eye was 6/6. On applanation tonometry, IOP in right eye was 27 and IOP in left eye was 36. The angles were open in both on gonioscopy. So we diagnosed this patient as both eyes primary open angle glaucoma with left eye advanced disc damage. The patient was immediately started on oral and topical anti-glaucoma medications. And with control of pressure, we did left eye combined surgery in patient. The post surgery, the vision improved to 618 and the pressures were under control. So the pressures were under control for next few years. After 2 years, 1 year in 2002, he developed borderline pressure in left eye. So we had to add prostaglandin analogs plus beta blocker in the left eye. Eventually, in next 2 to 4 years, in right eye, the disc was progressing with borderline to control pressure. So in 2006, we take decision to do a trabeculectomy in right eye as the patient was progressing. So the patient underwent trabeculectomy in right eye in 2006. The meanwhile, even left eye was showing progression with controlled pressure. So the topical anti-glaucoma medications were stepped up in left eye. So the pressure in patients were under control for next 3 years. In 2009, again, the patient developed a borderline pressure in right eye with progression of the disc with inferior notch with early superior notch. So we added prostaglandin analog in right eye, and again the left eye, the vision was deteriorating. With this medication, the patient's pressures were stable for next few years. In 2016, the patient presented with right eye diminution of vision. Patient found to have a cataract in right eye. So he underwent a right eye cataract surgery. The pressures were under control post cataract surgery. So in a recent visit, the pressures were under control with prostaglandin analog in right eye and with free medication in left eye. But again, we constantly noted a progression in both disc and visual fields. So this is a right eye disc. The photograph taken in 2022. You can see it is a moderate size disc with cup to disc ratio of around 0.8 with pallor and inferior notch. This is a left eye disc with advanced cupping around, it is 0.95 to near total cupping with significant pallor. So these are sequential fields from 2007 onwards. We can see there is in 2007 there is an early superior arcuate corresponding to the inferior thinning. It has progressed to a superior arcuate defect which corresponds to the inferior notch until 2014. So again, 2017 to 2022. So we can see there is the superior arcuate defect has progressed. Even the mean deviation progressed from -4 to -9. So so we noted that what was the cause of glaucoma progression over years. In spite of the IOP was well controlled, and we did all measures. So this led to intense brainstorming and whether we are missing on something, and there is something else which is playing in the background. So on detailed interrogation and detailed history, the patient gave history that he's a habitual snorer, history of habitual snoring since college age, which he was very reluctant to share with. A slightly obese patient with hypothyroidism on treatment, and we advised him evaluation when patient was very reluctant to undergo evaluation. On constant persuasion, patient undergo evaluation and he diagnosed with obstructive sleep apnea. So since then, the patient, this happened in around 2015 and 16. So since last around say 6 to 7 years, the patient is now on continuous positive variable pressure machine at night during sleep, and with that the patient's overall systemic well-being has improved, and also glaucoma is eventually stabilizing with good pressure control. So we diagnosed this as a primary open angle glaucoma with left eye advanced disc damage with additional obstructive sleep apnea causing the progression.
Okay. Can you conclude, because we'll have to wind up the case. It's already more than 4 minutes.
Okay.
So I think we'll put it to the moderators, because the case is by now fairly well understood. So I think any comments, Dr. Shefali and Dr. Radhika can come in now. First, Dr. Shefali. Any comments on this case, Dr. Shefali?
Yeah, I think it's very nicely presented, Dr. Ashwini. But only thing is, I would like to highlight few points.
Yes.
One thing on the first slide, when the first examination, you showed the there is asymmetry in the disc cupping. 0.4 was absolutely healthy versus 0.9. See, you see asymmetry in glaucoma, but on here it is absolutely normal in one eye and this one. So that is one asymmetry you should always take into account, that there has to be some other reason other than primary glaucoma. Second thing, throughout the other future visits, gonioscopy has not been done. So that is one very important thing, that in every visit, whenever patient is showing progression, we must do gonioscopy, because even if there is a progression in synechia, this change in synechia, that is considered as progression. And third thing, yes, what you have done workup, that if the patients are is showing progression with despite the pressures well under control, we have to do the full workup. Only thing is, whenever patient comes to you, you always have to think that take that patient as a glaucoma suspect, and what you have done right from the history taking, that all the steps are very important, right from like you have done history taking also. If there is any history of any surgery, trauma, or then comes the ocular examination. Now, if the pressures are suppose fluctuating, if the pressure, second step is the intraocular pressure examination. If the pressure shows high fluctuation, then there are very few types of glaucoma where there is high fluctuation is seen, like acute angle closure or maybe pseudo-exfoliative glaucoma, pigmentary glaucoma. Then comes the gonioscopy. As I said, the gonioscopy helps to diagnose, to differentiate between the primary and the secondary glaucoma. It helps to tell whether there is how many synechia are there, what is the location of synechia, and if there is any other cause of glaucoma other than primary glaucoma. So if there is any neovascularization, like if you see asymmetry, that is very important cause. If there is, if you see this, then gonioscopy is must on these cases. And then you come to the other findings, like if the on slit lamp examination, if you see a lot of pigments, Krukenberg spindle, you know it is pigmentary glaucoma. If you see the pupil very small, miotic pupil not responding, that means the cause is in here inflammatory glaucoma, most probably uveitic glaucoma. If it is mid-dilated pupil, you can again pinpoint that cause may be acute angle closure glaucoma. Similarly, lens findings and retinal findings. So I think these are the important findings where whenever patient comes, proper examination is the bottom line where you must do. And whenever you see something going wrong, which is not clinically, which is not answering all your questions, I think there you must do all the proper examinations and proper testing, which you have already done, like you considered sleep apnea here. But repeated pressure checkup multiple times, that is very important. And you have to see those things. Water drinking is another important parameter which you have to ask. The number of times you will see that patient will give history of that I'm taking water, drinking nearly 1 liter of water in the morning. So all those history, that is important.
Wonderful. I think points very well taken. Anything that you would like to add, Dr. Radhika? Because you have to start with the other case.
Yeah, just that ma'am has covered most of the points. I would also like to, if patient is still progressing when I'm giving anti-glaucoma medication, maybe a diurnal fluctuation of pressure, and maybe like, after getting the patient admitted for a day to see really how much fluctuation is there. And secondly, to check the blood pressure, maybe like the nighttime blood pressures, and whether because of that there is decreased optic nerve head perfusion. That would be another thing that could be considered.
Okay, wonderful. So what we'll do is we'll jump to the next case because of shortage of time. We'll come back to this case later. You can note down your points in the meanwhile. So I think Nidhi, can you share your screen now? Yeah, so your screen is well seen. You can just make it a slideshow. For this session, Dr. Pooja Bhomaj and Dr. Sneha will be the experts. We'll stick to 4 minutes. So Nidhi, try to wind up as early as possible so we get time for discussion.
Yes, sir. Good afternoon, everyone. I'm Dr. Nidhi from Mumbai. I'm a practicing glaucoma specialist. I've done my long-term fellowship from HVD Pune. So here we come to a very interesting case. I wouldn't follow the PPT because we want to wind up in 4 minutes. So here is a young male who's 30-year-old. He's an IT professional. He has a fair myopia of -3 diopters. There's no history of obvious trauma apart from the office birthday bumps. So he's immersed in work and he ignores every other aspect of his life. So he had a first episode of severe headache as well as eye pain on the right side. And he was like, ki paracetamol de do, theek ho jayega. Next day, he wakes up with blurred vision. So he visits his ophthalmologist. IOP is 42. There's corneal edema. Anterior chamber looks deep. The ONH is not visible. The left eye is 0.4, which is normal. So he gives him mannitol and timolol, and he tells him come back in 1 month. So he thinks that this is the eye pressure from a lot of computer use or work. And as usual, he doesn't turn up in 1 month. Next episode, October 21, he has a high pressure, 38. This time there's no corneal edema. So disc is seen, it's about 0.4. He started going to the gym. That is the only new history development. So the doctor is also like, he maybe steroid le raha hai, maybe he's gymming too hard. So he said, gym band karo. Let's see you in 5 days. He gives him Dimox this time, twice in a day. And he puts him on a brimonidine timolol combination. Next episode is November 21. Here he's on an offsite Ahmedabad. Again, the same episode. Now this time he goes to an ophthalmologist and he gets a very thorough checkup. IOP is again 40. Cornea is clear. ASOCT was done. Angles were open. RNFL OCT is normal. Perimetry is borderline, but there's no obvious defect. And it's his first perimetry, so nobody gave it much importance. He was referred to neuro because he wanted to rule out raised ICT. The neurologist wanted to rule out keratoconus fistulas, any raised episcleral venous pressure, since it was a unilateral case. But as you can see, the MRI was normal, the carotid Doppler was normal. So now the patient is absolutely chilled out because everything is normal. So as an IT professional on a new year, you'll be in Goa. So he has discovered the magic drug, which is Dimox. So every time he's had an episode, he's going on taking Dimox and he's being comfortable for the time being. January 2022, he ends up at the clinic and he's just uncomfortable now every day working. IOP is 32. He has no corneal edema. He has history of taking Dimox on and off. On examination, I do a gonioscopy and I see very heavy pigmentation in all of his angles. So I'm thinking pigmentary glaucoma. Obviously, there's no Krukenberg spindle, there's no transillumination defects, but I'm like, since everyone ruled out everything else, let me keep this in mind. The next was, I saw the disc, and the disc looked about 0.7. There was a bit of inferior thinning, and every other record he had, it was only shown 0.4. For a clear view like this, it shouldn't have been missed. So it must have progressed, is what I thought. We did an OCT. OCT showed some amount of RNFL thinning as well as some thinning in the neuroretinal rim. We did a perimetry. The perimetry also showed development of an early superior arcuate, some nasal step. So for management, we went ahead. Again, I gave him Dimox and I did a maximal medical therapy. But the IOP was back to 38 once he was off Dimox. So we took the decision to intervene surgically. We did a trab with MMC. Patient is maintaining IOP at 14 and he has not had any episodes since then. So my take-home message is always listen to your patient. A good history is 50% of the work. Like maybe the gymming was causing some amount of pigment dispersion. That's why he's had an episode even after the gymming episode. Don't break protocol. ASOCT is fine, but it doesn't replace gonioscopy. And a clean slate sometimes will give you an answer faster, which I'm saying is sometimes the patient will come to you for the third, fourth, fifth opinion. So if you follow the same trail of failure, you are not going to reach anywhere. So sometimes it's better to just start again and go through your own protocol and figure out. Maybe you'll get a diagnosis. Thank you.
Nice case, Dr. Nidhi. Would Dr. Pooja Bhumach like to comment on this?
Yeah, I think a very properly diagnosed, detected case. Pigmentary glaucoma in young patient when they come with very high pressure. As a standard protocol, we need to do rule out other causes like doing gonioscopy, identifying the cause. I have also frequently seen patients, young patients who come with very high pressures. Nowadays, these young generation people are involved in a lot of weightlifting, and I think the incidence of weightlifting related rise in IOPs and sudden spikes is also very common. Alcohol induced spikes also I have noted. I don't know how many of us have come across such episodes. So asking the history of alcohol intake associated with extensive gymming, I have seen pressures go high. We should keep that in mind. Nice case presentation. Yeah.
Okay, so what we'll do in the meanwhile, we'll ask our chairman to give us some comments. Dr. Manish, sir, any comment on this case?
So actually, yes, this kind of cases are occurring, whereas Pooja pointed out excessive gymming, excessive physical activity. In fact, there are reports of central retinal artery occlusion following excessive gymming also. There have been reports in the press, in the publications have been there. So asking in young people, history of excessive gymming is important. Also, as she mentioned, she has ruled out, but many times you have patients who present with fine KPs, which are often easily missed, and that is a kind of a Posner-Schwarzman which comes and goes.
Actually, if I would like to interrupt you, sir, since this was a very cramped up case presentation, we also did that. We also gave him like a course of steroid, but he stopped using the steroid in 3 days because he said it was, the pressure raised even more after he started using the steroid. So we ruled out Posner-Schwarzman as well.
So what I was trying to say was not to give steroid to rule out Posner-Schwarzman. If you don't see the white KPs, you have ruled out. I would not give a trial of steroid if I have not seen white KPs. And in your presentation, you clearly mentioned that you did not see any KPs or any pigments on the endothelium. So I'm just saying alternative diagnosis. I agree that you have ruled it out. In fact, I would not give a trial of steroids because steroids are known to raise pressure unless you have a definite inclination that there is inflammation, anterior segment or posterior segment. I would not give a trial of steroids at all in such a case. And if there is no inflammation, I would be happy to use prostaglandin analogs. I don't know, in the initial treatment, I was missed that, but I saw bremonidine, timolol being used, but no prostaglandin analog was advised. So even in pigment dispersion is there, you can use a prostaglandin analog and try to control it. But typically, as you mentioned, these are cases where the pressure suddenly goes up and then it comes down also. And they are not going to do very well on medical treatment if that is going to happen. And probably the right thing you have done is the surgical intervention. Only thing what I don't understand is what's going to happen to the other eye. Is a similar thing happening there? Number two, have you advised the patient to avoid gymming and very strong weightlifting and things like that, and stick to aerobic exercises like running, swimming in moderation, that too? So that would be one additional advice you would like to give besides continuous monitoring.
Okay, any additional comments, Dr. Sneha?
No, I think Manish has covered what I wanted to ask is what is the status of the other eye? What is the pigmentation in the other eye? And we'll have to observe the other eye closely as well. Yeah.
Okay, thank you, Dr. Sneha. So with that, I think we'll move on to the next case, Dr. Mandar.
Yes, sure.
From Dr. Ashwini and Dr. Nidhi has finished. So we can go to Dr. Aparna or Dr. Sanket. Sanket, Aparna, who is ready?
I am ready, sir.
So you can share your screen then.
Okay.
So I think Sanket is sharing the screen. So for this case, Dr. Gunjan Deshpande and Dr. Sarika Shinde will be the experts.
Can you see my screen, sir?
Not yet.
If you have any issues with sharing the screen, maybe we can go to the next
Yeah,
presentation.
Dr. Aparna, are you ready? Aparna, Dr.
Yes,
Gayatri.
sir.
Dr. Aparna is ready?
Yes, I'll share
Yeah,
my
you can share
screen.
the screen then. No problem. Go ahead with sharing your screen. Okay. I think Aparna
My
is sharing
face
the
is
screen.
visible.
Yes. Yes, it is visible. Yeah.
Good
So we
afternoon.
want you to conclude, Aparna, in the next 4 minutes so that we have time for discussion. Thank you. Go
Yes,
ahead.
sir. Good afternoon, everyone. I thank Dr. Mandar sir for giving me the opportunity to present on this platform. My case is a year-old male, known case of hypertension, non-diabetic. He first presented in September 2021. He was diagnosed with both eyes significant cataract with pseudo-exfoliation and closure glaucoma both eyes. The right was more severely affected than the left eye. He had undergone iridotomy elsewhere a year ago. So subsequently, he had uneventful right eye phacotrabeculectomy with mitomycin C. Patient was doing well. At 6 weeks, 12 millimeters of mercury, the bleb was well formed, the anterior chamber was well formed, and the best corrected visual acuity in the right eye was 6/9. He was advised to return for eye pressure checkup after a month. Unfortunately, this was outstation to follow up, and he presented only after an interval of 15 months in March 23. Patient was apparently all right after surgery until he developed redness, pain, vision, and sensitivity to bright light, bright eyes, and so medical examination in the eye, his visual acuity had dropped to 3/54. There was ciliary congestion and corneal edema. The moderately elevated was a uniformly shallow anterior chamber with few cells, a dull glow from the yak PI and the surgical PI. The IOL appeared. There was no history of trauma to the right eye or no history of any recent change in medications. Because the fundus view was hazy, a B scan was done, which ruled out the presence of choroidal detachment. So we started him on intravenous 200 cc tablet, 250 milligram QID, prednisolone eye drop QID, brimonidine timolol combination eye drop BD, and brinzolamide eye drop thrice a day. So when the corneal edema cleared, his visual acuity improved to 6/12 with a refraction of. However, the anterior chamber was still shallow. The central as well as the peripheral anterior chamber was very shallow. There was a patent gap PI and surgical PI. The IOP had come down to 30. The disc was 0.8 cupped with bipolar thinning. Retina was attached with no choroidals. So at that time, UBM was not available. So anterior was done, though it has a limitation in imaging posterior to the iris. And the closure with extensive iridotomy apposition in the right eye. So with a diagnosis, with a present anterior chamber, patent iridotomy, raised IOP, a normal fundus with no choroidals, pseudophakic pupillary suprachoroidal hemorrhage were ruled out. Working diagnosis. So mydriatic cycloplegics in the form of atropine 1% thrice a day and phenylephrine were added. Continued with topical steroid, anti-glaucoma medication, and acetazolamide tablets. So subsequently, we referred this patient for a UBM elsewhere, and the right eye showed a forward shift of the IOL diaphragm. There appeared to be a forward rotation of the ciliary body and in contact with the IOL. Small amount of supraciliary fluid was also noted. So after 1 week of medical treatment, the IOP was 30. The anterior chamber, however, remains status quo. So a YAG laser posterior capsulotomy and anterior hyaloidotomy centrally and through the peripheral iridectomy, but there was no change in the anterior chamber depth. So we planned surgical intervention, and this advised a pars plana vitrectomy and an anterior hyaloidectomy. Unfortunately, is not reverted back then. So malignant glaucoma could be a late present feature of filtering surgery, which emphasizes the importance of a meticulous follow-up in cases of glaucoma. Anterior displacement of the IOL due to zonular weakness by pseudo-exfoliation be a contributory factor. There should be a high index of suspicion, a prompt diagnosis clinically and with appropriate use of imaging modalities such as UEM, a stepwise approach with medical and laser treatment, a close follow-up to assess for improvement, early surgical intervention in case the improving clinically are crucial in the management of glaucoma. Fellow eye management is important as these eyes are predisposed for an episode in the other eye. So whether to consider phacoemulsification alone, which has a lesser chance of malignant glaucoma, or avoidance of intraoperative and post-op chamber shallowing, prolonged cycloplegia if field surgery is considered, or doing a prophylactic vitrectomy in high-risk fellow eyes are points we need to consider. Thank you.
Thank you, Dr. Aparna, for a nice case. The case is open for discussion. I would request Dr. Kunal to comment on this case.
Yes, Dr. Aparna. Thank you, Mandar sir. Nice presentation. Most of the points have been covered nicely. I think the anatomical predisposition of angle closure glaucoma, they are prone to develop malignant glaucomas, which can be within few weeks of surgery, or post-surgery, it can take 5 to 10 years also to present. So more commonly after filtration surgery, as already seen. Medical management has a little role in these cases. Moreover, surgical management has to be properly done, and we can surely save the eye from considering the other eye, whether to go for filtration surgery or phacoemulsification. That has to be clearly thought of, because other eye also can is prone to go for malignant glaucoma. So enough of cycloplegics post surgery, and less use of miotics and use of steroids post surgery can surely help the other eye. If required, anterior vitrectomy has to be done in such cases, and step up process has to be done in such cases, like whether to go for filtration surgery first or to go for lens extraction in angle closures. That has also helped in some review articles as we have gone through.
Okay, point well taken. Dr. Amar, would you like to add anything else?
Usually the small axial length is a contributor to malignant glaucoma. So it is very important in such cases to be cautious previously. YAG hyalidotomy helps most of the times, but if it doesn't help, we have to go for a surgical management procedure.
Okay.
Also, one thing is differentiating malignant glaucoma from shallow chambers post-operatively is quite important, which the student has done quite well. So it's almost okay. Maybe we have discussed most of the points, I think.
Okay. One point I would like to ask our chairman, Dr. Manish sir. There was some element of supraciliary effusion also, I think, in this case. So any comment on that?
So supraciliary effusion, there are 2 points on which I would like to comment. One is that supraciliary effusion, as you pointed out correctly, and that could be the cause of the whole anterior movement of the lens iris diaphragm. And supraciliary effusion, usually they have already given steroids. So steroids is the treatment to give for the supraciliary effusion. However, if you can even give systemic steroids, but if it does not resolve, like that also does happen sometimes, it does not resolve and the IOP does not come down. In that case, a surgery would be required. One more point I would like to make, very important point, though it may not be applicable in this case because it's not very clearly seen. But when you do anterior segment OCT or a UBM in such a patient and you see iris completely stuck to the cornea, but you see space between the iris and the IOL, that is not a malignant glaucoma. That is just an acute angle closure kind of picture due to the sticking of the iris and closure of the angle. In a trap operated patient, in certain cases, if the patient has put pressure or like a massage, but excessive pressure, the fluid escaped from the bleb and the iris moved in front and got stuck there. Once it is stuck because of inflammation or whatever, it does not move back and you get a picture exactly like malignant glaucoma. But in that case, if in the early stage you intervene, reform the chamber and put a little viscoelastic in the anterior chamber and leave it there for some time, this can resolve without doing a vitrectomy. However, this is a diagnosis which only can be made on UBM, because on UBM you can really see the whole picture. In this case, I was not very convinced that the IOL was behind. So I'm not making it applicable in this case. Probably whatever they have said is important. And last point I would like to add is when you do the vitrectomy, you have to make sure that a very nice communication channel is opened between the posterior segment and the anterior segment. And whenever I have treated such patients, we have made sure that we put a vitrectomy cutter from the posterior segment, from the peripheral iris coming into anterior, so that it full communication is established properly. And many times, if this has been a long-standing situation, you may need to put a Ahmed valve in the posterior chamber as well.
Okay. Thank you for those additional points, sir. I think we'll go to Sanket. Sanket, are you ready? Or Dr. Gayatri?
Sir, I'm ready.
Yes.
Shall I?
Okay, let Dr. Gayatri share the screen first because she
Sure,
was
sure.
in, so let us see whether she can get a presentation through. Okay, so we can see your screen. You can start presenting. Even if you scroll the slides in the same manner, it is fine.
Doctor, don't do slideshow. Just yeah.
Bas,
Keep
this
on
is fine.
sliding, that's
Just go ahead, please. Just go ahead.
So this is a case of a
We'll keep it to
25-year-old
3 minutes
male.
now because you already lost time. We'll keep it to 3 minutes.
Yeah. This patient was 25-year-old male having 6 and 6 and applanation IOP was 38 and 42 on 4
Please go ahead.
medications. The disc as seen is 0.6 and 0.8. These are his visual fields showing an biarcuate in the left eye. Patient underwent left eye trabeculectomy, which was post-op, it was uneventful. He had pressures of around 22 to 24 with massage. The blood increased and the pressures remained 80. 2 weeks later, he underwent right eye trabeculectomy with mitomycin C. On the first post-op day, his vision was 612 in the right eye and applanation was 44 with massage given to the right eye.
Dr. Gayatri, please, you need to click on the slides. You're going to click on the slides. Once you just click on the slides to prove.
So
yeah.
When he was on massage, his pressures were 14. Then the next day, on 7th day, the releasable suture was removed for the right eye. The pressure dropped down to 2, and after 3-4 hours, the patient complained of sudden diminution of vision, and we found retinal hemorrhages in both eyes, more in the right eye. This is the images of the right eye and left eye. Severe subhyaloid images with central white dots also were seen in the right eye. Left eye also showed few hemorrhages. So the patient was closely followed up. On the 9th post-op day, his vision was around close to face. IOP was 6. The hemorrhages continued to be there. 11th day, he developed vitreous hemorrhage. The IOP was 2. On the 14th post-op day, his IOP again began to rise, and that's why he was started on Dimox and a topical anti-glaucoma medication. He maintained his pressures of around 21 for the 6-week follow-up, but vision was hand movements. Vitreous hemorrhage persisted. Though the left eye hemorrhages started to resolve. So patient underwent vitrectomy in the right eye after 1 month. Post vitrectomy, his vision was 612. Applanation tonometry was 18, but now there were 2 medications used. Fundus was clear, media was clear. Fundus showed resolving with him. Patient was maintained for follow-up. After 1 year, we saw him. His bleb was scarred. Vision was 6/9 and N6. Pressures had again started to rise in the right eye. There was a resolved heme. The retinal hemorrhages were almost gone. However, some macular changes were there, and the disc was as before. So this is the patient again underwent right eye retrap, but this time I gave a pre-op mannitol for him. So first post-op day, his vision was 612, IOP was 18. Third post-op day, again the vision was 20, but I didn't intervene for anything. Then after 1 week, his IOP remained to be 8 and vision was 6/9. So this is what the patient's on the final visit, his best corrected visual acuity after 6 weeks was 6/9 and 6. 1 scarred bleb and 1 diffuse bleb was there in the right eye. Left eye showed a good diffuse bleb. This is the fundus photograph for the right eye and the left eye at 6 weeks follow-up after the second surgery. So to conclude, this was a case of decompression retinopathy. I would suggest there are 2 theories, mechanical and vascular. The take-home message is that in such cases, we need to have a gradual reduction in the IOP So there are known cases in which we can have severe hemorrhages. However, these hemorrhages are self-limiting and they dissolve on their own. Very few patients, in my case, he required a vitrectomy. Thank you.
Okay, thank you, Dr. Gayatri, for that excellent case presentation. I would invite Dr. Rupali Nirlikar and Dr. Karishma in that sequence to offer their comments in the next 3 minutes.
Okay, so very nicely presented. A couple of things. So typically the decompression hemorrhages occur when a very sudden large drop in pressure has occurred. So here the pressure was 20 and with massage came down to 2. And yet you had hemorrhages in both eyes, which I feel there must be something else happening along with the decompression. Secondly, the removal of the
releasable
at that point in time could have been held off, maybe because the disc was not so bad. So a pressure of 20 for a little longer with a little more massage may have, but I cannot explain why the fellow, can you explain why the fellow eye got hemorrhages?
Yeah, even I was a little surprised.
Also,
maybe he had underwent of trabeculectomy just 2 weeks earlier. So was that the reason? But the fellow eye hemorrhages disappeared after 1 month almost for the follow-up.
Yeah, but the eye pressure never dropped in that eye.
The pressure
and
didn't
there was
drop
no
in that eye.
massage and nothing that suddenly caused fluctuation in the intraocular pressure. So maybe there was
the
some
pressure didn't drop. The fellow eye pressure remained to be around 6 to 8, not very low.
Yeah, and maybe there was some underlying vasculopathy other than this.
Yeah, because a young male, so that needs to be evaluated actually.
Yeah, so maybe especially when you're going back in and reoperating, you need to be mentally prepared. And typically these decompressions occur in neovascular glaucoma, high pressure glaucomas, when you even if you gradually decompress with a side, like by making a side entry before you go in and make your trabeosteum. These are the patients who tend to develop it, and usually it is like on table you've decompressed and they have had a fairly big decompression and then they develop hemorrhages post-op day 1. It's unusual to see them later on. Of course, the drop in pressure could have explained that.
Yeah.
But I think maybe a systemic evaluation also would have helped, because he did bleed into the vitreous breakthrough bleeding. So it was a fairly severe
the right eye bleed was fairly severe actually.
Dr. Karishma, would you like to comment?
Yes, sir. There have been certain studies that have shown that not only, post-op sudden hypotony or a reduction in eye pressure causes decompression retinopathy. Sometimes even prior to the surgery, if there has been sudden rise in IOP, like I think this patient was a steroid responder, so he must have got an high IOP, suddenly for a few months or few weeks. So those patients or patients that have intermittent IOP spikes are known to have decompression retinopathy, even if you have done all the surgical steps correctly and they have not got a hypotony post-surgery. Second, whenever I think in a early, if you want to remove a suture, very early, then I would just like to put a gonio and see if my ostium is open or sometimes it's blocked with blood. Then I would want to wait for some more time before moving the suture. That's all.
And Manish, would you like to say something?
That last point which Karishma made out is very important, that you look for, because blood is very commonly the cause of this immediate post-operative failing to filter. And I would like to wait. Even I think massage also, I would not be very happy to give massage in the first 7 days, because your conjunctival wound is still not healed and it will leak from there. So I would wait for doing anything. At the most, I'll give Dimox, but I would not release any suture. I would not massage even in the first week. After the second week, then I'm happier to do massage, because by then the conjunctiva is healed and you won't have a leak outside. So that is very important point, that very early you should, as even Rupali pointed out, very early post-op, if the pressure is high, especially if it is in 20s, you can just leave it alone or give Dimox if you really are very scared, but don't try to manipulate anything. Wait for a little more time and then do the manipulation. And I have never seen, actually, in my experience, decompression retinopathy does happen, but having a decompression retinopathy which went on to develop vitreous hemorrhage is not at all common in my experience. For last 25 years, I haven't seen that ever happening. And so that's why I am still suspicious that there is some vascular pathology, as both Gayatri and Rupali pointed out. but we have to be watchful because nothing is appearing, and doing vitrectomy at that time, the retina surgeon must have seen the whole retina to look for anything which is suspicious,
Yes.
but it did not appear. So,
Sir, I think if Sanket is ready, I think we can start the last case because there are 8 minutes remaining for the medical retina session to start. Sanket, can you share the screen, please?
I will just need 30 seconds more, sir. I'm just trying here.
I think until that time we can if anybody has some additional points from the panel about any of the cases, you can just bring it forward.
Would you like to add something?
I think in this the case, just which was discussed, I think in such type of cases when the pressures are high, the sudden decompression can be avoided if you give preoperative mannitol. So I think that is one of the very important steps that we must follow. Second thing, what Rupali said and what presenter also said, there has to be some vascular cause, because if there is a decompression retinopathy, it cannot be in bilateral because of massage in the one eye. So I think in young patient, we have to keep in mind, due to the pressure of surgery only, sometimes the pressure, hypertension, that the blood pressure may shoot up in patient and it may, or there may be some other cause of vasculitis. I think that should be on the point.
Dr. Sanket, are you ready with your presentation?
Any other points anybody wants to bring out in any of these cases?
Also, could the could it have been that there was a decompression just having happened a little just pre-op and had been missed, because you don't always look at the fundus right before you take the patient up for OT, and maybe it was there in between scheduling surgery and actually in the post-op period.
No, I think we'll take that a bit later, because I think Sanket is ready with the case. So we'll just let him finish. Sanket, please finish in 2 minutes now.
Yeah, good afternoon, everyone.
Yeah.
Yes, I am presenting a case who presented to us with vegetative matter trauma and had a corneal infiltrate covering almost all cornea, for which he underwent a therapeutic penetrating keratoplasty. During the surgery, the cataractous lens was also removed and the eye was kept aphakic. Post-operatively, patient was doing absolutely fine as far as the cornea is concerned. Vision improved to 618. The IOP shot to 43 millimeters of mercury, and the disc was worsening as the time was passing by. Because of the advanced disc damage and uncontrolled IOP, we had to make a decision to go ahead with the filtering surgery, either tube or trabeculectomy. Even though TVT study states that it is the best option at this point of time, I followed my gut and did trabeculectomy, which actually failed within 3 weeks, and the IOP again shot to 30 millimeters of mercury. At this point, we went ahead and did oralob-aqueous drainage implant, took 2 ligatures of 6-0 vicryl to the tube, a scleral patch graft was placed, and the IOP went down to 15 millimeters of mercury post-operative period once the ligature opened up, but the happiness was short-lived, as after 1 week of controlled IOP, again IOP shot to 30 millimeters of mercury, and what we found that the tube was blocked by the vitreous which was surrounding it. At this point, we had to do another intervention to save the eye. We did a vitrectomy with a dialer, swiped off the vitreous strand which was inside the tube and completed the core vitrectomy, and pressure again then came down. I was doing great. Even after 4 interventions, the cornea was crystal clear. The graft was doing well. IOP was also down. This you can compare and contrast the pre-op picture and the post-op. The patient was very happy. 618 visual acuity with +10 diopter sphere, and IOP was 16 millimeters of mercury. Even though we have kept the patient under follow-up, after 10 months of follow-up, the patch graft has slowly become thinned out, and the tube is showing the subconjunctival area. This was the learning we used in another patient of ours and used a thicker scleral patch graft, and this patient is doing well with the implant. The take-home message is the aphakic eyes, post-PK, vitrectomized eyes, or in complicated cataract surgeries, primary tube can be considered as a superior option for IOP control. Core vitrectomy is required in such cases to avoid tube block with vitreous, and a thick scleral graft for covering the tube is necessary for long-term safety and to avoid tube exposure. Thank you.
Okay. Thank you for that excellent case presentation, and we'll have a quick few comments from Dr. Gunjan and Dr. Sarika in the next 2 minutes before we hand over the session. Dr.
Yeah.
Gunjan Deshpande? Yeah.
Yeah, so good afternoon, and this is a very nice case presentation. I'm very happy for the patient despite everything. Even after 3 or 4 surgical interventions, he was doing very well. There is only one question that I would ask Dr. Sanket. Any reason why you chose Adi over AGV? Because I think the patient already had reached 30-35 pressures, and you would like to have a reduction, a good reduction in the intraocular pressure in the immediate postoperative phase. So why choose Adi as compared to AGV?
I had done few Adi cases in my institutional practice, but here I found out that the socioeconomic status of the patient was not very great, and I had to choose between AGV and Adi. And even though in my mind AGV was a better option at this point of time because of the economic constraints, and I did Adi in this patient. In the long-term results with Adi are better.
Yes.
When I came to know about other studies, and this patient is doing exceptionally well, and which increased my confidence in Adi, and I again followed up with Adi in next cases also.
Yes, because
That was the
interestingly,
first
there is
thing
please.
That came to my mind. AGV was the option for me, but I was also not very comfortable doing it, but I had to choose it.
Yeah, because there is one study which was published by PGI Chandigarh in which they studied long-term outcomes in both Adi and AGV. They were comparable. The only thing, one important thing that they found was after 3 years, the amount of surgical interventions in AGV were more as compared to Adi. I think this could have helped in this patient. Therefore, definitely Adi is a better option for him as compared to AGV because you really don't want to touch this patient once again.
Okay, so point well taken. We are near the conclusion of the session. So, Dr. Nayak sir or Dr. Manish sir, any comments on effect of venting slits in managing pressure in post-Adi status? And how well is the pressure controlled with venting slits with medical management till the time the tube ligature opens up? What is the IOP trend that you have seen in your practice? Manish sir?
So I have no experience in using Adi. I have never used an Adi. And I have never used venting slits. Sorry, I can't really help over here because I am totally always been a Ahmed valve patient. And I feel my experience spans more than 15 years now. And I don't think Ahmed valve has much problem in the long run. Many more problems than Adi. I have very good results even at 15 years. Of course, there are patients who fail, and I'm sure Adi patients also fail. It's not that 100% any one of the two is successful. But yes, a lot of studies show that Adi is good. And I have nothing to say on that. Only thing in this case, as was pointed out by Gunjan, in the early postoperative period, pressure control, and second point, incidence of shallow AC when your suture opens. Both are likely in Adi, and therefore I would be preferable to use Ahmed valve. But I think for financial conditions, the cost is vastly different. So yes, when we are forced to use Adi, then I think he's done a good job for managing. And yes, when you put a tube in the posterior chamber, whether it is if there is no IOL, vitrectomy is very essential. And vitreous does come and block the tubes. And if in this case, no, but in cases where you have just iris blocking the tube, which happens with anterior chamber implants, I have used the YAG laser very successfully. Just blow out the iris over there, and you don't need to do surgery in those cases. Thanks. Yeah.
Okay, wonderful. So with those concluding remarks, Dr. Mandar, do we hand over to the medical retina and the UVA session?
Yes.
Just yes, Sachin, just one comment about all cases were presented very nicely. But one thing, probably, I think one message should be made very clear from at least 2 cases were like that whenever you see a unilateral glaucoma and so much asymmetry, then always think of secondary glaucoma. Then you may say if it is ruled out secondary glaucoma, then the primary glaucoma is definitely options are there because the 2 cases which were, and the first case which was there, in that I think still because the pallor of the disc was there. So in that, neurological investigation also should have been done.
Okay, sir. Point well taken. So, Dr. Mandar, concluding remarks, please.
Yeah, so it was a good session on glaucoma, and in the interest of time, we'll end this session and hand over to the next panel. Thank you.
Thank you, everybody, for this wonderful session.
Thank you for a wonderful glaucoma session, and in spite of technical glitches, finishing the session in time with great tips also. So I would like to invite the moderators of the next session, which is medical retina and uvea. The moderators are Dr. Santosh Agarwal sir, who is the Vice President of MOS, and Dr. Atul Kadhane sir, who is the Joint Secretary. Over to you, sir, for the next session.
Thank you, Aditi. Good afternoon, everyone. Myself, Dr. Santosh Agrawal, and Dr. Atul Kadhane are going to moderate this session. As you know, this session is on medical retina and uvea. And I congratulate all the MOS team for the wonderful conference, virtual conference. And this session includes 5 presenters, which are very young presenters, novice surgeons, Dr. Ayush Sangole, Dr. Samyak Mulkutkar, Dr. Drishti Raichura, Dr. Vandana Iyer, and Dr. Harshavardhan Gunale. And the young panelists are Dr. Shilpi Nanavare, Dr. Samir Ambadekar, and Dr. Ashish Holani, Dr. Mayur Morekar, Dr. Garima Chadha, and senior panelists are Dr. Manoj Sasode, Dr. Nitin Prabhudesai, Dr. Sharad Bhomaj, Dr. Suresh Ramchandani, and Dr. Ashish Vaidya. And Dr. Sunaina Malik and Dr. Shriram Karandikar, who are our teachers, who are going to chair this session. So over to Karandikar sir and Sunaina Malik ma'am, please.
Thank you, Santosh. Good afternoon to everybody. As briefed by our Honorable Secretary, President, and Chairman Scientific Committee, the purpose is to encourage the academically sound but silent souls of our society. So this is a unique and well-deserving activity. So let us go straight to the activity proper. The first speaker in this session is Ayush Sangole. I hope all the presenters are ready with their presentation. The first speaker is, as I told you, is Ayush Sangole. He is a he did vitreoretinal fellowship at Chitrakoot. As you all know, Chitrakoot is a large volume. Pardon? Chitrakoot is a large volume.
I think everybody else needs to mute.
So he did vitreoretinal fellowship at Chitrakoot. As you all know, Chitrakoot is a large volume draws large volume of patients, and the turnover is very, very large. Not only that, he pursued his passion in ROP and pediatric ocular oncology at Arvind, Coimbatore. He is also recipient of travel grant from AAPO. His topic for today's presentation is Okuchi's disease with Nakamura phenomena. Over to Ayush, please. Sangole. Ayush.
Good afternoon, everyone. Yes, good afternoon. Thank you, sir.
Yes. Share your screen. Share your screen.
Is it visible, sir?
Yeah. Go ahead.
So at the outset, I would like to thank MOS for the opportunity. I will be presenting a case of Mizu's Nakamura phenomenon, Oguchi disease with Mizu's Nakamura phenomenon. So this is a case of 10-year-old male came to the OPD with the chief complaint of diminution of vision at night since 4 years. Is non-progressive. Daytime vision is normal, color vision is normal. But there is a history of trauma to the right eye 2 years back. Only positive history that the patient's parent has a consanguineous marriage. On intersegment examination, right eye fundus is tricycle with PL negative vision. Left eye intersegment is absolutely normal with 6/6 vision and with a normal intraocular pressure. On fundus examination, the left eye shows a golden yellow sheen all over the fundus with normal disc and vessel. Foveal reflex is normal, but fovea appear a little bit darker due to the background golden yellow sheen. So we did the fundus autofluorescence as routine. Fundus autofluorescence of the patient is absolutely normal. We did the OCT. On OCT examination, vitromacular interface is normal. foveal contour is normal. All the inner retinal layers are normal, but the outer retinal layer, especially the RPE layer, cost layer, and ISOS junction are hyperreflective. And these layers are separable in subfoveal region, but all these hyperreflective layers are indistinct in parafoveal region, also in the peripheral OCT. So what is the diagnosis? We have a few clues. First is the history, the night blindness, the history of consanguineous marriage, vision is 6/6. Second is golden yellow sheen of the fundus and OCT with the hyperreflective outer retinal layer. With these clues, we make a working diagnosis of Aguchi disease. Considering this as a primary diagnosis, we did the dark adaptation. We patched the eyes of the boy for 4 to 6 hours. After dark adaptation, we found this picture. Now the fundus look absolutely normal. There is no golden yellow sheen. Disc vessel is normal. Foveal reflex is normal. This phenomenon is called as Mesos-Nakamura phenomenon. So we also did OCT before and after dark adaptation. So after dark adaptation, as we see the before dark adaptation, we have hyperreflective outer retinal layers. They are indistinct, which are now separable after dark adaptation. We can easily see all the three layers, RPE, post layer, and ISO are very well separated. We did ERG before dark adaptation, rod response are decreased, but cone response are normal. After dark adaptation, there is a marked enhancement of the rod response. So we have few more clues like Mesos-Nakamura phenomenon, OCT findings, and electrophysiological tests. We make a final diagnosis of Aguchi disease. So what exactly the Aguchi disease is? It is primarily described by the Japanese ophthalmologist in 1907. It's a type of autosomal recessive disease. It's a type of congenital stationary night blindness. The patient complaint of slow dark adaptation. It has two types depending upon the gene which is involved in the disease. It is mainly caused due to disruption in activation step of the rod phototransduction. The exact mechanism of Mesos-Nakamura phenomenon or the golden yellow sheen of the fundus is not known, but it was speculated that it was due to the elevated extracellular potassium level due to the excess rod stimulation. And some author also suggested that it is due to the Muller cell dysfunction, which act like a potassium scavenger and which accumulate in this disease. And also the exact mechanism of this hyperreflective outer layers are also not known because this is very rare. So it was presumed that it is due to the functional alteration of the rods, which are mainly present in the parafoveal and peripheral retina. So the Aguchi disease is a congenital type of congenital stationary night blindness. Diagnosis mainly on history, clinical findings, and ERG findings. Counseling is very important in this patient to avoid any unnecessary investigations. And we also need to aware the people regarding the drawbacks of the consanguineous marriage because it is mainly related to the consanguineous marriage, and genetic testing is a gold standard but is very costly, and also gene therapy is main treatment for this disease, but it is very costly and is under not proven yet. Thank you.
Thank you. Very nice presentation.
Good afternoon
from the panelists, please.
Good afternoon, all. I am here to introduce our young and the senior experts for this. In order to have a smooth discussion, we have assigned one senior and one junior for each case discussion. The person who is going to be a young expert in this case is a Dr. Samir Ambadekar, a vitreoretinal fellow from Lions Nab Hospital, Miraj, at present working as a VR surgeon in Amravati. So this is generation next, and the senior expert is our stalwart Dr. Ashish Vaidya sir, Shankar Netralaya fellow and practicing as a VR surgeon in the last 25 years. So over to you, Dr. Samir sir and Dr. Ashish sir for the discussion.
Thank you, sir. Am I visible?
Yeah. Yes, you are visible.
Yeah. Very nice presentation, Dr. Ayush. It was a very rare case that you have presented. So it is a rare congenital stationary night blindness case. I would like to add few more things. These kind of reflexes that fundus shows, also known as capital fundal reflexes, these are also seen in other cases like retinitis pigmentosa, X-linked retinoschisis cases, and some corn and road dystrophy cases. But there are some different type of reflexes in such cases. The diagnosis is mainly depends on the history taking, OCT, and ERG findings. So in Aguchi-Nakamura disease, we'll see a normal cone function in ERG, a delayed rod ERG dark adaptation, and a marked rod desensitization to when there is a bright flash shown to the eye.
Treatment part is still in trials, like it still depends on the counseling, history taking. We should avoid consanguineous marriage and gene testing, but it is a costly part. Gene therapy involves adenovirus associated trials and lentivirus. But mainly the treatment part depends on the counseling part.
Dr. Ashish, please.
Yeah, can I add a few points? I think number one is that the gene therapy is costly, but it is only related to the RP65 gene and not for the Oguchi disease. Second point is that what happened to the right eye? Why was the right eye icicle?
The old history of trauma was there, sir.
Yeah,
History of
if
trauma
there is
was
an
this.
old history of trauma, that could be because of various reasons. One reason is we need to do a perimetry of these patients because we need to see how much to the side they can see. The second thing on the practical basis is that you need to tell the parents that this child, should be maybe not allowed to go too much outside in the dark, because of him not seeing in the dark, was that the cause of his injury is something we need to know.
Correct.
Yes.
So that should be advised to the parents that he should not go out too much in the dark. Other than this, I think it's an excellent case presentation which has been done and covered all the aspects of it.
Thank you, Ashish.
How many cases were recorded so far of this particular disease in the literature? How many number? Anybody?
I think whichever articles I have seen, there are just 2, 3 or 4 cases which are there.
Yes, sir.
So it's very difficult to think of also before you conclusively prove the things. Unless you do the ERG, it is difficult to know the.
Actually, there are 4 types of autosomal recessive these
autism.
congenital stationary night blindness, and these are very rare.
So these are
normally we see fundus albi punctatus very common, but other like Riggs disease and Oguchis are very rare.
Okay, thank you.
So thank you very much. Now the second speaker is Samyak Mulkutkar, who is going to present on ocular syphilis.
I'll just give a brief introduction. Good evening, everybody. First, actually, it is a night for me because I'm in USA. So I'm joining you from here. Dr. Samyak Mulkutkar is trained as an ophthalmologist and further in surgical retina and uveitis, both at the prestigious Advanced Eye Center, PGI Chandigarh. At present, he is consultant vitreoretinal surgeon and uveitis specialist at PD Hinduja Hospital and Medical Research Center, Mahir, Mumbai. So his case presentation is on ocular syphilis. Please go ahead, Samyak.
Thank you, madam. Am I audible? Are my slides visible? Yes.
Yes.
Thank you so
both.
much. Thank you, Moss, the scientific committee, for giving me a chance to present my case. Now, this is a 26-year-old male who had a recent history of bilateral diminution of vision, right more than the left eye, since the past 10 to 15 days. He was recently diagnosed during the same time as HIV positive and also started on heart. He was seen first at Center A before he presented to us, and he was diagnosed as bilateral CMV retinitis. He received injections of intravitreal ganciclovir in both eyes, 2 doses in both eyes. However, there was no clinical improvement, and vision in the right eye kind of deteriorated to PL positive. When he presented to us, he was using moxifloxacin nefacanac eye drops. Now, if you look at his labs, of course, his CD4 to CD8 were low. CD4 was about 288. The CMV viral load was done, which was less than 57.1 copies per ml. The imaging of the abdomen showed multiple non-necrotic mesenteric lymph nodes, and the chest X-ray showed fibronodular opacities and left pleural base thickening, which is suggestive of old Cox. His IGRA was negative. The VDRL test was done on 2 instances, one which was negative and one which was positive in 2 different labs. However, the titers were not available. His TPHA was positive. His toxo IgG-IgM also was done, which was positive. Now, if you look at the fundus photo, this is the photos of the right eye. There is significant vitritis. You can barely see the disc. And you can see that there are multiple hemorrhages, superficial retinal hemorrhages along the vessels. So you can see that there is perivascular sheathing as well. And this is suggestive of occlusive periphlebitis. In short, he's had multiple inflammatory BR views. There was RAPD positive and cells and flare in the anterior chamber. There were snowballs inferiorly. However, there was no retinitis in the right eye. In the left eye, which was slightly clear, the vision was 6/12. Few anterior chamber inflammation was present, and also in this eye there was perivascular sheathing and hemorrhages, which was suggestive of occlusive periphlebitis. We scanned the entire periphery with indirect ophthalmoscope. However, no retinitis lesion was seen in either eye. Now, if you look at the points such as occlusive periphlebitis, bilateral involvement, no retinitis, his TPHA was positive, VDRL was positive, and he was an HIV positive. CMV viral load was also negative, and there was no response to intravitreal gancyclovir. So, considering all the clinical pictures and his laboratory tests, he made a diagnosis of ocular syphilis. He was treated with injection ceftriaxone 2 grams IV for 2 weeks, and his HIV treatment was continued. There was a short course of oral steroids which was given to supplement for the inflammation. So after the treatment, this is his right eye. Within 7 days, his vitritis started getting better. He could see better. And within 4 weeks, most of the hemorrhages have gone away. His vision is improved to 6/12. This is surprising. From PL to 6/12, his vision is improved. And we can see the retinal vessels now. In the left eye, his vision is improved from 6/12 to 6/6 in the next 4 weeks. So now we know that syphilis is the greatest masquerader we know in uveitis. It can have multiple variants, but the pattern recognition and clinical correlation is very important. Vascular involvement in ocular syphilis is documented in multiple case reports. All kind of vessels can be affected in the retina. They may range from subtle vascular involvement or subtle vascular tortuosity to perivascular exudation. The arterioles can be involved, and so much so that it is found in about 10 to 14% of patients with ocular syphilis in the posterior uveitis. Retinal phlebitis is the most common vascular phlebitis. These are my, this is the bibliography where you can find vascular involvement. All of them have confirmed this. Thank you.
Very nice presentation, Dr. Samyak. For this case, we have this young, dashing, fitness enthusiast, Dr. Mayur Morekar as a young expert. He is presently an associate professor of ophthalmology and consultant eye surgeon at Bombay Hospital Institute of Medical Sciences, Mumbai. And the senior panelist is our stalwart, Dr. Nitin Prabhu Desai, sir. He is a Shankar Netralaya fellow and experience of 25 years and more of retinal practice. Over to you, sir.
Thank you very much, sir. Am I audible?
Yeah.
Yes. Thank you, sir. So this is an excellently managed case. Most of the times in uveitis, our diagnosis is based on pattern recognition. And most of the times we understand that the pattern recognition depends upon the interaction between the etiology and the immune system. And therefore, pattern recognition is something that becomes one of the major things with which we diagnose. And as soon as the patient is immunocompromised, like in HIV, the entire pattern recognition thing goes for a toss. Probably the only pattern that one thinks of with HIV is that of CNG retinitis. Now, there are 2 or 3 points about this case is that first you have a patient who is HIV positive. The fact that he has had old pox, there are mesenteric lymph nodes. The fact that IgM is positive for toxoplasma, and the fact that we have a TPHA visit which is positive. One comment that I would make is when things present this way, they classify as neurosyphilis, and that is why they need to be treated as neurosyphilis. The other definite positive point that comes out of this is the choice of the antibiotic. The choice of the antibiotic is intravenous ceftriaxone. Now, intravenous ceftriaxone is something that will have action against syphilis and toxoplasma both. So, having understood that this is a case of ocular tuberculosis because of TPHA being positive and because it masquerades the way it masquerades as retinal periphlebitis, the choice of antibiotic is the best thing about this case. They have chosen ceftriaxone. Of course, the response is extremely good. You are going straight from PL positive to 6/12. So an extremely good presentation, very well documented, and of course the management is extremely good. Very good.
Thank you, Mayur. Dr. Nitin, can you comment?
I think Dr. Nitin Prabhu Desai is not present here.
Right. Okay. Anybody else want to have their comment on this case?
if Manoj is there, he could comment. Manoj Sasarode, can you comment on this? Is he there?
So we'll move on to next case then.
Yeah.
Yeah.
Drishti Raichura, Dr. Drishti Raichura, she is going to speak on interesting case of executive RD.
Right. Actually, Drishti Raichura did her post-graduation from SN Chennai, and we are training under Dr. Vatsal Parikh. Because of the similarity of names and what a coincidence. As per her name, she is at present working in Drishti Eye and Retina Care Center, Mumbai. Her topic is interesting case of executive RD. Yes,
Good afternoon, one and all. Am I audible, sir?
Yeah, please
Yeah,
go. Go
Share
ahead.
your screen.
Yes. Okay, so
Drishti, go to
thank
full
you.
screen.
Yeah.
To full screen. Yeah,
Right.
good. Go ahead.
Thank you, Moscon Scientific Committee, for giving me this opportunity to present an interesting case of exudative retinal detachment today. So this was a 75-year-old gentleman who came to the OPD with a chief complaint of diminution of vision since 1 month, which was 2 weeks after his cataract surgery, which happened about 1.5 months. He had been treated for CNVM in both the eyes with injection Eylea 2 years back. He is a known diabetic, hypertensive, and IHD patient, metabolically controlled. He was using Predfort, Nevenec, and Homide when he came to us. On examination, his uncorrected visual acuity was 618 parts N36 in the eye of concern and 60 N30. Yes.
What happened?
You continue, ma'am.
Yeah, so his anterior segment was within normal limits. He was pseudophakic in the right eye and NS2 in the left eye. IOP was normal. He had his vitreous was clear in the right eye and he had a cataractous haze in the left. His optic discs were within normal limit. Macula looked clinically on upon examination, and left eye was within. He had a scarred CNVM with hemorrhage. Peripheral retina showed 360 degrees of bullous retinal detachment with choroidals, and no breaks could be seen on clinical examination. And shifting fluid was present on examination. Left eye retina was on. This was the right eye at presentation, as we can see. And upon doing the OCT, we saw that there was some serous fluid and cystic spaces, cystoid edema present in the macula. So this was the left eye at presentation. We did an FFA and ICGA, and in the mid and late phases, we could see staining and pooling of the dye in the peripheral dilated veins. And also there was some macular staining seen in the mid and late phases. The ICGA showed dilated choroidal vessels with crossing over at the horizontal range. And we sent the patient, we got a UBM done, which showed an elevated iris, and the ciliary body and ciliary processes were medially rotated due to the supraciliary effusion. And the B scan in the sitting and the supine positions beautifully showed the fluid shift, which was position dependent. The configuration of the detachment changed. So assuming it to be an inflammatory pathology, we started the patient on oral steroids 40 milligrams per day and reviewed him back after a week, where his visual acuity had dropped by 2 lines and the fundus picture had also slightly worsened. So he was 636 after a week, less than N36. The detachment had increased all around, and the fluid at the macula was also slightly more. We stopped all the steroids and called the patient back after a week, and then we saw that the retinal and choroidal detachment was more. The condition was not improving and the vision had still maintained. So this was at the 2-week follow-up where the fluid had increased over here. So at presentation, this was the picture where the level of the detachment progressively in 2 weeks had reached up to the macula, and and superiorly and nasally also it had increased. And this was the progressive OCT which we have done at 2 weeks. So it is postulated that this patient is an exudative detachment due to uveal effusion syndrome post-cataract surgery. And we have posted the patient for surgery next week, where we are planning to make scleral windows and do a choroidal drainage. I thank you all for your patient hearing.
Thank
Very
you.
nice case.
Yeah,
Very nice
very
case.
case, Drishti.
Thank you,
For
Dr.
this,
Drishti.
we have Dr. Naresh Holani, a vitreoretinal surgeon from Aurangabad, as an young expert. He is
Ashish Holani.
sorry, Ashish Holani, as an young expert. He had done his fellowship from the Retina Foundation, Ahmedabad, and the senior person is Dr. Sharad Bhomaj, again a Retina Foundation fellow. Since last 20 or more years, he is a consultant at Shanti Saroj Netralaya, Miraj. Over to you, sir.
Hello.
Yeah.
Am I audible? Hello.
Yes,
Ashish, yes, go ahead.
Yes, Ashish, go ahead.
Yes. Good. Good afternoon, all, and very good case and very good documentation. May I know, means on angiography and ICGI, you have diagnosed this as a uveal effusion syndrome.
Yes, sir. So basically, there are no other factors. We first thought that it would be an inflammatory detachment, which is why we started with steroids. But he was not even. We thought of. We did an this thing A scan also. His axial length and all does not fit into the nanophthalmos category, and there is no other positive finding that we had actually. So now it was an exclusion. I mean, diagnosis of exclusion basically, that we postulated it to be a uveal effusion syndrome.
And the anterior chamber finding, like shallow AC, iris Bombay, like these are there?
No, sir. No, sir. Anterior chamber was within normal limits.
Okay. Because there should be some anterior chamber signs like in uveal effusion, like shallow AC, iris Bombay, something like this. This is a good case and good documentation, means like you have diagnosed with exclusion finding and all treated with oral steroids, no? Yeah.
Which only worsened his situation, so we stopped the steroids then.
Okay, it was worsened, yeah.
With the oral steroids, sir.
Yeah.
Okay.
So now you are planning surgery. Dr. Sharad?
Dr. Sharad,
yeah,
please.
Good afternoon, everybody. Can you hear my voice?
Yes.
Yeah. So the points which are not in favor of uveal effusion syndrome is that it does not present at such an elderly age. This patient's age is around 72, something like that, above 70. No?
Yes.
So it does not present at such elderly age group. Other thing is that what is the IOL power for this patient?
So it was 23 diopters.
So slightly hypermetropic, but not severely hypermetropic.
Yes.
So there is no, and generally they present bilaterally, so they may be asymmetrical or sequential presentation. So the points which are against is that elderly age group, absence of any significant refractive error like severe hypermetropia, and unilateral presentation. The thing is that FFA and other things generally do not help because they are all normal in these uveal effusion syndrome patients. The other thing which I would like to say is that being pseudophakic patient and unilateral presentation, I would still feel that rhegmatogenous detachment, where you are not picking the bricks because of the massive choroidals, should be kept as a distinct possibility. Because the choroidals are blocking the small break, and generally in the severe choroidals, the breaks are generally very tiny. And we should first think of any detachment is, unless otherwise, has to be considered as a rhegmatogenous. So intraoperatively, I would suggest that, first we can place an anterior chamber maintainer and in the choroidals and have a look thoroughly inside the eye first to rule out the rhegmatogenous detachment in terms of a few small break or something like that. And in case you don't find anything, I would suggest that we should aim to do only the medical management first. External management, that is external drainage. And scleral windows and other things, I would not advise to do in this particular case, because this is not a classical uveal effusion syndrome. So I would just suggest that you drain the choroidals, use an antechamber maintainer, have a complete thorough examination intraoperatively of the fundus to find a break. and most likely it is most likely to be a rheumatogenic detachment where the break is not visible because of a massive choroids. Yes.
How
That
do
would
you
be my
explain the
opinion.
shifting fluid? How would you explain?
Once you the break is closed and you have got a fluid and a massive choroids, you can have it is not a mandatory. You can see
Okay.
how the picture has changed over in the OCT. You can see now it has become complete subretinal fluid. It's a detachment of the macula, which was initially just a subfoveal fluid and intraretinal edema. Because of the progression, it is not responded to steroid also.
Yeah, that is
So
also a point.
no, I'm just saying that we should keep this in mind, that the
Okay.
most common cause is a rheumatogenic detachment in an elderly patient with a unilateral presentation with no significant underlying refractive error. So this is what I would suggest, this line of management.
Yes.
Thank you, Sharad sir,
Can
for
I make a
your
point?
expert comment. Anybody else want to comment?
Yeah, Santosh, can I make a point? Ashish here.
Yeah,
Yes.
please, please.
Go ahead.
I think I totally agree with what Dr. Sharad has said, is that since this lesion has progressed in spite of giving the steroids, there's a very high chance of it being a rheumatogenic retinal detachment. What I would do is that just give a bolus of 1 gram of solumetrol for about 2 or 3 days. And if that does not reduce it at least to some extent, then we are definitely, I would go more in favor of rheumatogenic retinal detachment. So I would give a pulse steroid therapy first and then see how it works out.
So Drishti, that puts a different perspective on the whole thing. And now I think we go to the next speaker, that is Dr. Vandana Iyer. She's going to be talking on a case of presumed ocular tuberculosis. She has done her MBBS from Maulana Azad Medical College, Delhi, and her MS from University of Medical Sciences, Delhi, and her Vitreoretina Fellowship from Shankar Nethralaya, Chennai. And she's done a short-term FACO Fellowship from Datta Meghe Institute of Higher Education and Research, Samangi. At present, she is Assistant Professor of Ophthalmology, Subspecialty Vitreoretina at AIMS, Nagpur. So over to you, Vandana. Can start sharing your slides. Are you there, Vandana?
Yes, she is there.
Yes, ma'am. Yes, ma'am.
Go ahead.
Can you see my screen?
Yes.
Yes,
Yeah, yeah.
absolutely. Go ahead.
Can you hear me, ma'am?
Yeah, yeah.
Perfectly.
Yes, go ahead.
Good afternoon, everyone. First of all, I'd like to thank everyone for giving me this opportunity to present. This is a case of presumed ocular tuberculosis. So, 1 second, I'm not able to move to the, yeah.
Yes, yes, it is moving.
Yeah. So a 26-year-old female presented to us in OPD in March 2023. She's a nursing staff by occupation. She presented with left eye sudden onset diminution of vision for 2 days, which was progressive in nature, with mild non-specific eye pain and mild redness. Her ocular and systemic history was unremarkable. In past ocular history, she had had some 6 to 7 episodes, similar episodes, lasting 2 to 3 months over the past 7 years. And her old papers revealed varied presentations from both as anterior uveitis to intermediate uveitis. These were treated with topical oral steroids in every episode and followed by some recurrence. Uveitis workup had also been done elsewhere, which was unremarkable. The patient was operated for complicated cataract surgery secondary to chronic uveitis, and also had got perioperative oral steroids. Patient regained good vision over a period of 1 or 2 months. Then 1 year back, the patient developed vitreitis in the same left eye when she was treated with posterior septinone triamcinolone, and the patient regained back her vision to 6/6. So mostly the episodes were associated with left eye. With right eye only the findings, but not deterioration in vision, according to the old papers. There was a past systemic history of lichen planus on treatment, and she was treated with some antihistaminics and some emollients. And then the patient also had malar rash on exposure to sun, which was not investigated. The patient had no history of tuberculosis, diabetes, mellitus, or hypertension. On examination, the right eye best corrected visual acuity was 6.6 and left eye was 6.36. The anterior segment examination revealed occasional KPs in the right eye, while a few more KPs in the left eye. The antechamber was having cells and flare 2+, while right eye antechamber was quiet. There was also cells in the vitreous 2+ in the left eye. Again, fundus examination, right eye revealed normal fundus, while left eye had mild vitreitis, and you can also see slight hyperemia over the disc. But rest of the fundus was normal. Perimetry was normal in the right eye. Left eye was showing few scotomas in the superior part. So, second, yeah. So these few scotomas, yeah. The OCT also revealed bilateral segmental thickening of the retinal nerve fiber layer, while macula was normal in both eyes. So, provisional diagnosis of right eye chronic anterior uveitis, while left eye recurrent intermediate uveitis with spillover vitreitis with pseudophakia was made. The aim was to look for the cause. So we did a uveitis workup again. The complete blood count came out to be normal. ESR CRP came to be raised, and Montaux showed no induration, while chest X-ray, HRCT, chest and abdomen were also normal. We had made the IGRA for TB pending because the patient had already spent a lot on so many investigations. So we went ahead with anti-nuclear antibody test, which was positive for diffuse and speckled antibody. Then vitamin D levels were found to be low, and torch IgG for rubella was positive. We also found anti-TPO antibodies raised and TSH level raised. The patient was diagnosed, revised diagnosis was made to be SLE related uveitis, left greater than right, with bilateral optic neuropathy secondary to hypovitaminosis and hypothyroidism. Patient got systemic treatment in the form of vitamin D supplementation, calcium carbonate, thyroxine and IV methylene prednisolone, 4 doses, while I also injected posterior subtenon triamcinolone in the left eye. Despite all this treatment, the patient had no response after 4 days also. Then physician made further plans of further investigations like C-ANCA, P-ANCA, ANA profile immunoblot, and thyroid scan, IGRA for TB, and repeat vitamin D3 and TSH after a month of treatment. While a trial of ATT was instituted, usual course, the 4-drug HRZD for 6 months. So the patient immediately responded to ATT just after the first dose. The day 1 vision improved from 636 to 624, second day 618, and over a period of 1 week, it was 69. So the final diagnosis of presumed ocular tuberculosis were made. So my points in favor were, like the patient was a healthcare worker working in close contact with patients. She responded to ATT. Granulomatous keratic precipitates were there. Varied forms of presentation were seen in the past: anterior uveitis, intermediate uveitis, vitreitis, pan uveitis. Then there was a false rise in autoimmune antibodies. It has been seen that there is a false rise in autoimmune antibodies in patients of latent tuberculosis, like ANA titers or thyroid peroxidase antibody. And we have also seen that low vitamin D levels are found to be there in chronic tuberculosis. The patient in the past had responded well to oral steroids, but again recurred. But this time, the patient is responding only after giving AKT, while we are slowly tapering the steroids, but the vision is constant at 6.9 for past 1 month. So, so the diagnosis was like, is it tuberculosis, which has led to secondary increase in autoimmune antibody and SLE kind of malar rash presentation? Or is it SLE, which is secondarily leading to ocular tuberculosis, presumed ocular tuberculosis, because they have a complex interaction, it seems. And we also have lichen planus in the history. So lichenoid tuberculid is also a condition which is associated with tuberculosis. So, so which goes more in favor of presumed ocular tuberculosis. So I still had a debate with the medicine people whether it is SLE uveitis, but only one point in favor is that patient has responded to ATT. So,
excellent case, Dr. Vandana. Very nice case.
For this case, we have a young, vibrant Dr. Shilpi Narnavare as a young expert. Shilpi works as a vitreoretinal surgeon and ROP specialist at Sarakshi Nethralaya, Nagpur. And the senior person is our stalwart, Dr. Suresh Ramchandani, sir, a Shankar Nethralaya fellow and almost a vast experience of 25 years and more in the retina practice. Over to you, sir.
Atul, 1 second. Dr. Suresh sent a message that he has had to leave suddenly. So if someone can cover for him, if you read on the WhatsApp. He'll ask Prashant or anyone else to take over for him.
I think you
can Dr. Sharad is there, Dr. Ashish is there.
Yeah.
We have many people. No problem.
Dr.
It is only for the smooth conduction we assign a senior.
Yeah, I know.
Anybody can comment.
Yeah. So let's go with the young expert first. Shilpi?
Yes, ma'am. Ma'am, we all know that the COT study, which was done, and the data was released in around 2021, that in the first report, they said that in cases of presumed ocular TB, until and unless you have all the radiological investigations and the blood investigations, which are in favor of tuberculosis, there is not much of a difference between whether you start ATT or not the ATT. But the another report which was released, that is the COTS 2 report, it is seen that in cases of anterior uveitis, vitritis, recurrent cases, or the vasculitis, even if one investigation comes out to be positive, we can think of starting ATT, especially in cases of recurrent cases which are not responding. Yes, the statistical significance was not seen. And moreover, we cannot trust on Montagu's value because it can be falsely positive or negative, especially in endemic cases. So better is to go for TB Gold or the better test, which can just HRCT or these things. But yes, the cases in which even if these tests are positive, they are constantly recurring. And moreover, if the clinical suspicion is that it can be related to tuberculosis, there is no harm in starting cases, ATT in such cases.
In this case, Montagu's is negative, I think.
Yes, sir. That's what I said. Falsely negative and falsely positive is...
Actually,
very true.
As Vandana has already suggested, they wanted to do IGRA,
yes,
but because of the financial constraints, they could not.
Yes, sir.
Other thing which comes to my mind as a general or comprehensive ophthalmologist, on one side, on the right side, there are mutton fat KPs and other things suggestive of classical tubercular uveitis. While on the other side, it may be immunological reaction itself.
Correct.
Yes. Expert.
But sir, it is found that in most of the cases, if you start AKT, then recurrence rate is less.
Yes.
That is a very well finding, and most of the cases they do respond to anti-tubercular treatment.
Right.
Sir, it is not per se, I think, the active inflammation, but sometimes the release of the antigen antibodies or something, the immunity has decreased and there is certain... Yes.
Then what is your take-home message for starting and steroids in presumed tuberculosis cases?
Sir, if it is a first case, it is just a first presentation, patient presenting for the first time, and there are no tests which are just in going hand in hand with the case of that it is a case of a tuberculosis, you can start with the steroids. But in cases of recurrence, or if you're very much sure that this is a case related to tuberculosis, first you start with the AKT, and then after a week or two, then you can start with the steroids.
So all the general ophthalmologists like me who work as an anterior segment person, they usually are present of whenever a case of uveitis come, the first we start steroids only. Because we never investigate on most of the people.
There should be suspicion if there is a mutton fat KPs and recurrent iridocyclitis or uveitis.
Santosh, we have Dr. Manoj with us. Okay, go ahead.
Yes,
Manoj, go ahead.
Yeah, Manoj, please, your take on.
There is a term called as a diagnosis by exclusion. The same way it is true here, treatment after exclusion.
Correct.
Tuberculosis, we have suspected only. We have started already given a trial of several times steroids, and still the patient is having recurrences, relapses are there, and that all investigations are negative, including tuberculosis. We are in a tuberculosis pandemic country, so the tuberculosis suspicions comes first, and our trials also go hand in hand.
Can I make a comment?
Sorry.
Yes,
may I
Mayur.
say one thing? May I say one thing?
Yes, sir.
What I find important is not only a treatment with steroids to start with, as everybody will start. That is to take care of the immunological reaction.
Phenomenon.
But when the mutton fat, KPs and other things are there, and as we have already suggested, our area is endemic for tuberculosis. Simultaneous treatment with both anticox as well as with steroids will be of help in such patients.
You would like to comment something?
Yes, yes. The first presentation is of a granulomatous uveitis. And I think the take-home message should be that when one is seeing a granulomatous uveitis, it may be a good idea not to make the patient spend money in tests like HLA-B27 RA factor and probably even torch, because these are not going to yield much. That's point number one. Point number two is the patient obviously is from a TB endemic area like our country, plus is a healthcare professional. So getting a Mantoux test negative in such a patient would be something that is very unlikely.
Alarming.
So that is most likely going to be a false negative test.
Maybe patient
Now,
is on steroids. Maybe because of patients on steroid.
yeah. Now, having said that, the same argument goes against us relying completely on the Mantoux test, because if the Mantoux test is positive also, one could say that it could be positive in a healthcare professional. So for me, probably in the presentation it came up that the physician had advised for IGRA. So I would wish to know what that IGRA was most likely like. In the first panel, probably we could have limited the investigations to ESR, ACE, Mantoux, and probably contrast enhanced test CT, and try to think of ocular tuberculosis first. I think that would be how I would have looked at it.
Okay, thank
I
you,
have
sir.
one comment to make. Actually, nowadays, I think we don't think so much about TB because we feel that the rates of TB have fallen considerably in our country. But I think we should always keep that in the back of our minds when we get cases like this with very obvious granulomatous uveitis. I think even an MBBS student would think of tuberculosis first.
And we should also rule out immunocompromised patients because in immunocompromised patients or patients on steroids, for so many cases, they are more prone for all those things.
For tuberculosis.
Yeah.
Okay, sir. And she's a healthcare worker.
So now we'll
I
switch
just
on
like
to next case, please.
Yeah, we have to go to the
one
next
small
case.
point, one small clarification.
Yeah,
The
please.
patient was having malar rash in response to sunlight and also having lichenoid lesions on the body, which is why probably the physician thought of so many things in addition to, he presumed ocular tuberculosis was the last thing he thought of.
Yes.
Yeah.
Physicians will never support that.
Responded also.
That's
So
fine.
we had
That's
to
fine.
really fight it out with them.
Both these
I
things
think we'll go to the next case. Dr. Karandikar.
Yes, please.
Yeah. The final now winning shot is from Harshavardhan Gunale. Gunale received his training in vitreoretina at Miraj under Dr. Bomaj, who is senior expert in this session. Harshavardhan is practicing at Sambhajinagar, Maharashtra. He will be talking to us on CSR in pregnancy. Kunale, please.
Yes, good afternoon, sir. I'll start my...
Yes, please. Go ahead.
Yeah.
Share your screen, yes.
Sorry. Good afternoon, sir. Am I audible?
Yeah,
Yes.
audible.
Yeah.
You can see the slides also. Yes.
Yes, sir.
Go ahead.
Good afternoon. Myself, Dr. Harshavardhan. I am presenting a case report of CSR in pregnancy. On 30th of January, May, a 31-year-old female pregnant came to our hospital for the presumed choroiditis or retinitis from an anterior-segment surgeon. So patient was in her third trimester and she was a primigravida. She was complaining of blurring of vision in her both eyes since 3 to 4 days. She has no ocular pain, no history of taking any corticosteroid externally. She has no same event has occurred previously. So on presentation, excuse me.
Yes.
Yeah, you are
on presentation, the right eye and left eye, the best corrected visual acuity was 6/18 in right eye and 6/15 in right eye and 6/18 in left eye, and near was 6/8 in both eyes. Pressure was normal and pupil was already dilated under tropicamide, and rest anterior segment findings were within normal limits. On posterior segment examination, fundus photos of the both eye we have taken. On examination, the media was clear in both eyes. The disc is slightly tilted in nature, and disc is normal in shape, size, and color. And CD ratio was around 0.2 to 0.3 in right eye and 0.2 in left eye. The disc margins were distinct, and vessels around the disc were normal. In the macular area in the right eye, we can see a well circumscribed SRF patch. SRF area is elevated area seen in right eye. In left eye also, we can see some opaque area and some elevated SRF patches, which is not well circumscribed, is seen. In the both macular area, we can see some opaque patches, and also in along the inferior arcade, we can see some opaque patches in the both eyes seen. Another investigation we have done for this patient is of OCT for the both eyes. In the right eye horizontal section OCT of the through the macular area, we can see a smooth elevated hump of the SRF neurosensory retina is seen in both eyes, and in right eye in right eye we can see a little break in the RP area, which is the potential leakage point from the for the SRF fluid is seen in the right eye, and there is a thickening of the choroidal tissue is seen in the right eye. In the left eye we can see a hyperreflective organized material, fibrin is seen in the left eye subretinal space along with some SRF and hyperreflective dots, and there is a somewhat thickening of the choroidal area is seen. From this OCT and fundus photo, I came to a conclusion of this is a CSR, acute CSR in both eye, and along with subfibril deposition in left eye in this patient. Differentials I have concluded are the two. First is the exudative retinal detachment from preeclampsia, but there is an absence of pregnancy PH and proteinuria and pedal edema. And other differential is the punctate outer retinal toxoplasmosis. Due to the left eye, there is in left eye we can see a well circumcised hyperreflective material, punctate lesion is seen subretinally. So I am thinking of punctate outer retinal toxoplasmosis, but for this it should be a unilateral case, and dome cheptochoroidal thickness should be associated with it. So I have came to the conclusion of CSR for this patient. As pregnancy is a hypercortisolism state, it is believed that high levels of endogenous steroid cortisol would trigger a chain of events altering the blood retinal barrier.
Harshavardhan, please go a little fast.
Yes, sir.
You can end up.
Some of the fast.
Go ahead.
Sum up your case.
Yes. So for this patient, I have come to the conclusion of CSR. As it is acute condition and first presentation, I have assured the patient we should wait and watch for this pathology, as it is a self-limiting disease. So we have not given this patient anything which could hamper the pregnancy, the baby and the female itself. So thorough ophthalmical examination is very important in pregnant cases for the diminution of vision, and early and correct diagnosis is important to avoid an inadvertent therapeutic measures which may cause potential complications in pregnancy for mother and baby. Thank you,
Harshvardhan. For this case, we have a young dynamic gold medalist, Dr. Garima Chadda, as a young expert. She practiced as a vitreoretinal surgeon in Nagpur, her own setup since last 15 years. And the senior person is not so senior, perpetually young, Dr. Manoj. He is a well-known VR surgeon from Aurangabad, Sambhajinagar. He is there in practice since last 17 years with his own setup. So here you are. Over to you, sir.
Garima.
Garima.
Nicely presented case, Harshvardhan. One thing correctly said is in the case of CSR in pregnancy, we should look for toxemia of pregnancy because very severe cases of CSCR in pregnancy usually present clinically like toxemia of pregnancy. So it was very nice for you to consider the patient for toxemia of pregnancy and you got it evaluated. And because your patient didn't have hypertension or proteinuria or pedal edema, that was ruled out. One investigation I would add here is with OCT, we could have done OCTA also in such a case. OCTA would have helped us as we are not able to do FFA in case with pregnancy. We could have done OCTA to rule out other entities also. And as we know that CSR is self-limiting in pregnancy, we should keep a case on close observation. And very classically, it is seen most of the cases of CSCR in pregnancy have subretinal fibrin deposition, which is usually seen in
Yes.
Yeah.
Yeah. Well covered, Garima.
Time is getting.
Manoj,
Yes,
do
Manoj.
you have any?
Yeah. Yes, she has very well covered the things. The only purpose of presenting this, knowing this case was that CSR is a very common, but very uncommon in a pregnancy, particularly in females. Bilateral presentation is different. Exudative CSR or SRF is very different. And we know that this, as he has mentioned, that pregnancy is a state of physiological alterations, so many physiological alterations, or increased cortisol levels. The treatment is as such, we know that the pregnancy itself is a cause. As soon as the pregnancy is over, the treatment, the SRF will obviously will reduce. Yeah, that's what. And the investigation as such, in third trimester, there is no harm in doing the angiography.
Yeah.
But that's if you wish, you can do it. And after doing the angiography, you can do the micropulse yellow lasers or anything. Treatment also, if the patient is very anxious because of the loss of vision. Otherwise, termination of pregnancy as soon as possible is the only remedy for such.
It's very difficult to say something after the comments from the experts. But whatever I know, if during pregnancy, the anxiety factor means the cases of sterility or some problems in the previous pregnancies are there, then because of this anxiety factor, the chances of developing CSR in pregnancy increase. Am I right, sir?
But
Yes.
she's a primary. The primary.
Now
she's a primary.
But anxiety can be there in primary also.
Yeah, stress.
Now
Pregnancy itself is a stress.
More so.
Yes.
So thank you everyone. We are going to conclude now because it's 2 o'clock now. So everybody has contributed very well. A very excellent session. Thank you everyone, including junior experts, senior experts, panelists, and chairman, co-chairman, our teachers, everybody for your valuable contribution. And we have got so many take-home messages for varied cases. Thank you very much.
Yes.
Thank you very much. Thank you, Dr. Santosh.
Thank you, everyone.
Thank you, sir.
See you all soon at Kochi.
From Team MOS, we would like to thank the coordinators and
Lunch
moderators.
ready.
Yes,
क्या
sir.
खा रही हो अमेरिका में?
Yeah.
अमेरिका में हूँ देखो ना आज के 1:30 बजे
लंच टाइम हो गया ना?
अरे
कॉन्फ्रेंस का लंच टाइम
1:30 बजे रात के मैं जगी हूँ खास इसके लिए क्या एंथुजियाज्म है मेरा सोचो जरा
मैम आपका एंथुजियाज्म तो 7 समुंदर पार चले गए अभी
चलो गुड नाइट
Over to Vardhaman.
Thank you, sir. And
Thank you. We will start the next session now.
Yeah. Am I audible?
Yeah.
Yes, you are audible.
Thank you. So thank you so much from Team MOS. I would like to thank the moderators and coordinators of the previous session, Dr. Santosh Agarwal sir and Dr. Abdul Kadani sir. Special thanks to Dr. Sunaina Malik ma'am. She has been there in the US, actually being there up in the night to attend this session.
And also thankful to Dr. Karandikar sir to be there, as we really respect you, sir. Thank you so much for being in this episode. Thank you. So I
Thank
think
you. It was a wonderful session.
thank you, ma'am.
Great.
A lot of learnings thanks to all the experts, panelists, and everybody. Thank you so much. So I think we will move on to the next session, which is on surgical retina, and I'm sure this is equally exciting session. And to take forward this session, we have the chief coordinators and moderators, and also senior retina surgeons, Dr. Manoj Sasavde sir from Aurangabad. I'm sure sir doesn't need any introduction. He is one of the pioneers of Veter Retina in Marathwada, has been at the forefront of both technological as well as the clinical surgical advancement.
Thank you, Vardhaman.
And with him is Dr. Shamik. He is equally qualified young Veter Retina surgeon from Nagpur. Over to you, sir, and to Dr. Shamik. Thank you.
Good afternoon, everyone. I would like to thank and congratulate MOS, particularly Bhide sir, Vardhaman, and Atul Kadani sir, Dr. Santosh Agrawal, for conducting this special midterm conference, especially for the beginners who have not yet presented, and they have offered the platform for the people who are not yet usually seen on the any conferences. That's why once again I congratulate MOS for conducting such event, or bringing up the people who are not yet on the MOS platform. So for today's session, this is particularly a surgical retina session, which the chairperson is Dr. Prashant Agnihotri from Nagpur, and Dr. Prashant Bavankale is a co-chairman. He is also from Nagpur. Myself, Dr. Manoj Sasavde, and Dr. Shamik Mukadami are the moderators. We have 5 presenters: Dr. Rahul Vahekar from Buldana, Dr. Amit Nene from Thane, Dr. Shruti Shirwadkar from Mumbai, Dr. Piyush Bansal from Pune, and Dr. Sitish Tamboli from Nashik. We have young panelists, Dr. Vivek Adve from Buldana, Dr. Santosh Tupdikar from Latur, Dr. Kaustubh Kandle from Solapur, Dr. Harshit Vaidya from Mumbai, and Dr. Abhidnya Surve from Aurangabad. Senior panelists, we have Dr. Bhushan Khare from Pune, Dr. Rohit Mode from Mumbai, Dr. Prashant Agnihotri sir from Nagpur, Dr. Rushikesh Naigayokar from Jalna, and Dr. Ajay Tamewar sir from Aurangabad. Dr. Shamik, will you continue with the first introduction of Dr. Rahul Vahekar?
Yes, sir. Very good afternoon to everyone. It's a pleasure to introduce Dr. Rahul Vahekar. He's working at Sanjeevani Nethralaya Buldana as of now, and he has done his DNB from Sushrut Eye Foundation, Calcutta, and his Vitreoretinal Fellowship from Sri Shankardeva Nethralaya, Guwahati. I think, Rahul, without much of a delay, let's start the session so that we are on time.
Thank you, sir. Thank you for my introduction.
You can share your slides.
Your slides are not seen. Can you? Sir, I'm not getting any option to how to share. So
he needs to be made a presenter.
Shamik, can you help him out?
So I think he needs to be made a presenter, or he needs to be made a admin or something. So that is how we can share the screen. I think tech support would be able to help us.
Sunilji, can you help, please?
Aditi can help you out.
Yes. Dr. Rahul, can you see any green button down?
Rahul, at the bottom of your screen, you'll have a
green button.
Share screen.
Sir, on the Zoom window, there is a green button. Just click on that. Are you on the Zoom window, doctor? So can we move on to the next one?
Panelist link.
I think we should skip this and go for the next by the time we are ready with this.
Yes. For the time's sake, we will continue with the Dr. Amit Nene. Dr. Amit Nene is a vitreoretina surgeon at Thane. He has done his vitreoretina fellowship from Yali Prasad Eye Institute, and he is a member of Royal College of Surgeons, Edinburgh. Now, presently, he is working at Isha Netralaya, Thane, and he is very well known to all Maharashtra for presenting the videos, vitreoretina surgery cases every day. Congratulations for this academic upgradation of the society. Dr. Amit, hand over to you. You continue with your case.
Thank you so much, sir, for your kind words. And I would like to thank Moss in the beginning. So without wasting any time, I will start with my video presentation. Am I audible and the screen is visible?
Yes, screen is visible.
It is not visible.
Sir, your presentation is not visible. The screen is. Can you open the presentation?
Start the presentation.
Yes.
It seems now it's visible.
Yeah, so this is not a presentation as such. I will directly be going over the video. Just a basic information. So the patient was a 68-year-old male and he presented with sudden painless diminution of vision, complaint since 1 year. His vision was PL positive, but it was PR inaccurate. And on examination, it was found to have a dislocated cataractus lens and a chronic retinal detachment with grade 3 PVR. So we planned his vitrectomy under very guarded prognosis. Now let's see how the surgery went. So I started with a 23 gauge pars plana vitrectomy. The routine 3 ports were made. Infusion was checked whether it was inside or not. It is important to check the infusion properly because sometimes the infusion might remain behind the retina and it might cause further trouble. So as you can see, there was a thick membrane over the retina with PVR. So the PVD was partially induced. So I peeled off the membranes and completed the vitrectomy. So you can see this lens which was very adherently attached to the retina. So I tried to separate it out using my cutter and light pipe like chopsticks. So once the lens was separated from the retina, I had two options, whether to go for a pars plana lensectomy using a fragmentome or just take it out from the anterior root. So this is the PFCL which I had injected now to prevent damage to the macula for any of the maneuvers. So I decided to take the lens out from the anterior segment. I constructed a sclerocorneal tunnel. So with the help of cutter, I levitated the lens towards the AC, and with the help of light pipe from behind, I pushed the lens completely into the anterior chamber. With the help of wire vectors, I was able to get out the lens properly. So now, even after the PFCL, there was a macular pucker present. So I got rid of the pucker with the help of ILM peeling forceps. I didn't do any ILM peeling in this case. So the peripheral additions, I'm trying to remove all the membranes with the help of the same forceps. Now the retina was very stiff at the periphery, so I decided to do a 360 retinectomy in this case. So with the help of diathermy, I am marking the site of retinectomy. It also helps to cauterize the blood vessels along with it. So while doing a retinectomy, we need to make sure that the peripheral frond of retina, which is left, we should trim that also completely. Now I'm filling up the vitreous cavity with the help of PFCL so that it entirely covers up the retina. Endolaser is being done now. So this is under PFCL, not under air. So I make sure that I make at least 3 to 4 complete rows of laser around the retinectomy site. So the retina was well settled. After this, I did a fluid air exchange. By keeping the flute needle at the site of retinectomy, I made sure that no PFCL escaped beneath the retina. And then later on, the posterior pole PFCL, which was there, I removed that. Then I filled up the vitreous cavity with oil. And the case was then closed. So this is the follow-up picture after 2 weeks. The retina was well attached and the vision had improved to counting finger 2 meters.
Wonderful, wonderful presentation. Now for the discussion of this case, we have two people. One is a young panelist, Dr. Santosh Tuplikar, and senior was panelist, Dr. Bhushan Khare, who has taught me also. So Santosh, your comment, please. Is it Santosh is available? Dr. Santosh Tuplikar? If he is not available, Dr. Bhushan sir. Dr. Bhushan sir, you can.
Yeah. Thank you, Manoj, for allowing me to participate in this. Thank you, Vardhaman. Congratulations to Amit on a wonderful surgery which he demonstrated. Now, in such a case, I would like to ask him.
You're not visible very well.
Sir, can you just cancel out the screen background? Virtual background?
Probably.
Just make it none, Dr. Bhushan. On the choose virtual, yeah, perfect, sir. Thank you.
So I would like to congratulate Amit on a wonderful surgery.
That's good. Yeah.
Thank you.
In this, I will want to ask him to highlight 2-3 things which I will want him to discuss. Critically, lens being dislocated in the inflamed eye may have led to higher chances of PVR, which we could see. So removing of the vitreous completely with the membranes, what did he do? What all steps he will emphasize on to do a complete vitrectomy along with a complete removal of all membranes? How will you identify and remove all membranes? Amit, please.
Yeah. So as it was a chronic case, there were pigment clumps associated with the PVR. So it was very easy for me to find out where the exact PVR points were, where the folds were. But in the initial stages, it is always better to stain with triamcinolone, and always you can use brilliant blue dye also to find out any membranes, leftover membranes which are there.
In addition, just like what you emphasized, sometimes we may have to resort to a longer cannula when we start the case, because subretinal infusion can be very common in such a case when choroidals can also be there in the surgery. A 360-degree retinectomy, although you did, the posterior pole looked quite healthy. And what was the visual outcome of this patient?
So right now the patient is in follow-up with me. So it has been now 3 months. So his vision has improved to 636 now, and I plan to keep the oil for further 3 to 4 more months till it emulsifies. And if possible, I plan to do a SFIL along with silicone oil removal for him.
Congratulations again. A wonderful case. Thank you. Thanks, Manoj.
Dr. Santosh Tuplikar, you want to comment something?
Yes, sir. Basically, I must congratulate Amit, sir, for his wonderful surgery. Long-term output. I want to ask that whether that vision of this such patient for longer time, does it improve or stays PVR recurrence PVR cases, like recurrence of PVR comes in the picture?
So as of now, there was no more PVR there, and his posterior pole is also good. Means in this case at least. So we are learning by trying trial and error things. I have many cases in which I have failed. This was one of the good cases in which I had a good outcome. So we always burn our fingers and we find out what is to be done and what is to be not. But taking the patient into confidence is very important in such cases.
Any reason for not doing ILM peel, sir?
Means it was a long surgery and I
After
didn't.
doing such an extensive surgery, you have left one thing which is still into inverted commas, whether you should do or not do.
Yes.
I would have preferred going in for a ILM peel and then hope for the best, because nothing more can be done. And did you think of a secondary IOL in the later phase?
Yeah, so now I'm planning the secondary IOL along with oil removal for the patient.
Okay.
So you can do the ILM peeling along with your sir.
Yes, along with
We'll move to the next case.
Okay.
Dr. Rahul Bahekar
Oh, nice.
is now
Very,
ready.
very well done.
Well done, Amit.
Thank you, sir.
Next case, please.
Dr. Rahul Bahekar, please.
Yes, sir. Thank you. Rahul, you okay? Yes, sir. That's great. You can go ahead. Please don't wait for the things to start because it takes.
First of all, I would like to thank the scientific committee of Moscon for giving me this opportunity. I'm presenting a case of retinal detachment with choroidal detachment. A short theoretical part of this. Choroidal detachment with RD is a rare condition. Incidence is 2 to 4%. Hypotony is the cause. The choroidal detachment, two types, serous and hemorrhagic. Risk factors may be recent eye surgery using blood thinners, eye trauma, inflammation of the eye, glaucoma surgery, etc. The mechanism behind choroidal detachment is hypotony due to RRD. The hypotony is due to diminished axis production and increased outflow. The fall in intraocular pressure may lead to vasodilatation of choroids, then breakdown of the blood ocular barrier, then transudation of fluid into the extravascular space leads to the choroidal detachment. This choroidal detachment looks like this picture. Then the pars plana vitrectomy for the management of this condition was reported by this. So the role of steroids is also there to decrease the inflammation. So what vitrectomy advantages are: immediate drainage of the choroidal detachment fluid, restoration of intraocular pressure, removal of the bulk of the implant vitreous, and better identification of the retinal breaks, and the use of the endolaser. So this is the case of retinal detachment with choroidal detachment. First of all, we should be sure for the placement of the infusion cannula, so that it should be in the vitreous cavity only, not behind the retina or
we can't
Rahul,
see
we
it.
can't see your video. I think you need to go as a full screen presentation. Hello, Rahul.
Yes, sir.
Full screen presentation mode मध्ये टाक. Ha, this will be better.
Fine. Yeah.
So first check for the proper placement of the infusion cannula. It should be in the vitreous cavity. Then you can see the choroidal detachment on temporal side and nasal side also. I'm doing the thorough vitrectomy first. Complete base dissection should be done in such cases. In every case. Staining the vitreous with triamcinolone for PVD induction. And doing thorough base dissection for the total settlement of the RD. This is the primary break here. Then we'll go for conjunctival dissection and sclerotomy 1 to 2 mm at the highest point of the choroidal. You can see the gush of fluid, yellowish fluid, serous fluid coming out of this for drainage of this choroidal, suprachoroidal system. Do some pressure, the remaining fluid will come out. Cauterizing the primary breaks. The retinotomy is being done and the fluid gas exchange is being done as like normal RD surgery. Endolaser to the primary breaks and the retinotomy is being done. Here you can see the choroid on temporal side gets subsided due to drainage, but nasal side is there. But we can't do sclerotomy from that side. So we are putting oil and this nasal choroid gets subsided within a week or 10 days post-op. Thank you. Then the conjunctival closure is being done. Thank you.
A wonderful presentation, Dr. Rahul. For the case discussion, we have Dr. Kaustubh Kandle from Solapur and Dr. Ajay Tamewar sir from Aurangabad. Kaustubh, your comments, please.
Very nicely done video, very nicely done surgery. I would like to stress on a few points which Sir had already mentioned. First of all, because of the inflamed choroid, there might be bleeding, suprachoroidal bleeding or subretinal bleeding while doing the making the sclerotomy port. So prior oral steroids, 3 to 4 days prior oral steroids would be helpful. It will decongest the choroid first. The second thing would be if, as rightly mentioned by Sir, if possible, if required, to keep 6 mm cannula for infusion ready, so that there might be less chances of the cannula going subretinal. Otherwise, and another one more thing is that there we have to be aware of a chance that there will be underfill of the oil in such cases if the choroidals are a little bit of choroidal drainage is still remaining, as complete choroidal drainage is very difficult in such cases. Otherwise, everything was very nice. Thank you.
Yes, sir. Ajay, sir.
Thank you, first of all, for giving me the opportunity to talk here. Nice surgery by Dr. Rahul and comment by the Kaustubh. Though this condition RD with choroidal detachment is uncommon, everybody must have faced these cases in routine practice and faced the challenges. Now with the advancement of this MIVS, the two challenging situations in this case are, one thing is because of the hypotony, it is very difficult to insert the trocar cannula, and also you have to use longer cannulas. 6 mm cannula which may not be available every time. So now the options here are, and the second challenge in these cases is the surgical and anatomical outcome. A post-surgery anatomical and functional outcome in these cases is already guarded. That has to be kept in mind, and the recurrence of RD and PVR is always very common in such cases, and that has to be counseled to the patients pre-operatively. Here there are various options, as you rightly did the drainage of the suprachoroidals through the sclerotomy. You can use preoperatively steroids either systemically or locally, either intravitreal injection of triamcinolone or periocular injection of triamcinolone to reduce the side effects of steroids, systemic steroids. Even now the people have tried giving suprachoroidal triamcinolone to reduce the inflammation, to settle the choroidals, and then go ahead with the surgery. So at the end, it was a nice surgery, and congratulations to Rahul. Thank you.
Yeah, wonderful, wonderful presentation. Agnihotri sir, you would like to?
I think whatever the best possible under the circumstances has been done.
Yes, he has done.
He has
Would you
done
like
it,
to
and
continue
I
the
think-
steroids post-op?
Yes, steroids to be given post-op. And second thing is that we have to keep our prognosis very, very guarded. We have to realize that we have a lot of challenges in such cases where we have to look at the cannula, we have to look at the approaching the posterior part. But overall, well done. I'm sure this is the beginning and you will do much better in the future course.
Thank you. Thank you very much, sir. We'll move to the next case. Third case is going to be presented by Dr. Shruti Shirwadkar, madam. Dr. Shruti Shirwadkar, madam, has done the PG, MS from Sion Hospital. She had done the fellowship at Nair Hospital under Dr. Saroj Sahadev, madam. She is now at present working as an associate professor in Lokmanya Tilak Medical College and Hospital, Sion, Mumbai. She has a very interesting case. Let us see what she is going to be present. Dr. Shruti, please share.
Please share your
screen. Thank you, sir. Thank you, sir, for a kind introduction. Am I audible?
You're audible, but your screen is still.
Okay. So can you see the screen now?
Yeah.
Yes.
Yeah. So I would like to thank all the respected MOS committee members for giving me this opportunity to present the case. It is about the unusual presentation of bilateral dislocation of lenses on assault. So basically, this is a case of simple vitrectomy. So actually, I don't have a saved video of this, but the unusual presentation on the follow-up, which is why I would like to share it with you all. So there was a 31 years old female which came with a complaining of sudden diminution of vision, which was associated with pain, redness, and watering since 1 week. And she gives a history of assault by her husband by fist 1 week back. There was no history of any systemic illness. There was no any other family significant history. No history of any drug allergy or any history of any ocular diseases like glaucoma or anything in the family. So when she presented, this was the anterior segment presentation. Both the eyes had dislocated crystalline lenses, which was in the anterior vitreous stage. And there was a mild congestion. So when she presented, her right eye had a vision of finger counting 1 meter, whereas the left eye was finger counting close to face. The other anterior segment findings were okay, except that the lens was dislocated in the anterior vitreous space and the intraocular pressure in the right eye was 24 millimeter of Hg and in the left eye it was 26 millimeter of Hg. So we did a primary evaluation, ophthalmic evaluation. Her both the retinas were normal. And on B scan, we could see crystalline lenses in the anterior vitreous cavity. There was no evidence of retinal detachment. So we did the further investigations for the axial lens to rule out any myopia or Marfan syndrome. To rule out any skeletal problems, we referred her for the other specialities. Also to rule out V. marchesini or homocystinuria, we did her serum urine levels of homocysteine and methionine for homocystinuria. We did 2D echo evaluation for the Marfan syndrome to rule out Marfan syndrome or aortic aneurysms or mitral valve prolapse. So everything was normal. Generally, if we follow a chart for the ectopia lentis, we did all the family history. Family history was not so significant. We did her stature, her the length, the everything, the height was also okay. So the other genetic test, she could not do it because of the financial conditions. And since there was a clear history of trauma, we did not go for that. So then after that, we planned, after starting proper anti-glaucoma medications and low-strength steroid drops in the eyes, we planned a past plan of vitrectomy with the removal of dislocated crystalline lens was done for the left eye first, followed by the right eye. And we did iris claw lens implantation in both her eyes. So initially, on the first day post-op, the intraocular pressures were low in both her eyes. The left eye was operated first. It also showed the low IOP, and also in the right eye, which was followed by the left eye after a week's period, it also showed a low IOPs. CDL test was negative. IL was stable. There was no choroidal detachment on indirect ophthalmoscopy. The patient's IOP monitoring, we did it regularly, and patient was put on Predfort eye drops 8 times a day and Homide eye drops. On post-operative day 8, there was spike in IOP, like around 30 millimeter of Hg, and there was associated with corneal edema. IOL was stable. For the spike in IOP, we had to start systemic carbonic anhydrase inhibitors along with timolol eye drops. But with one single drop also, it was not under control. So we started brimonidine eye drops also. So on post-operative 1 month follow-up, there was still uncontrolled IOP levels. After giving topical anti-glaucoma drug for 3 weeks, we did gonioscopy, but the angles were open. There were no peripheral synechiae. So we planned for trabeculectomy for the left eye first. So a trap was done, and there was a nice filtering tape, you can see. Even after the trabeculectomy, the IOP was low as 8 millimeter of Hg initially, but it built up over a period of 1 week. So we were really wondering that was the decision of trabeculectomy was right or wrong. So then later on for the other right eye, we sent patient for my opinion. And there the patient underwent a transconjunctival cyclophotocoagulation. So after this glaucoma management, 15 days post-operatively, patient's vision was 660 in the right eye, whereas in the left eye it was 636 parts. Other things, the cornea was clear now. In the left eye, the blade was filtering, and the pressures were maintained to 16 and 18 millimeter of Hg. So with this post-op follow-up, like we were really confused whether what is the cause of this low IOP after immediate post-op and then the spike afterwards, almost 8 to 10 days after the cases. So I went through a few of the literatures. The one paper showed by the Dr. Yumi Hasegama and et al. It showed that the intraocular pressure valuation was found approximately in 1/4 of the cases within 1 day following post-vitrectomy. The risk factors of IOP elevation included number of laser photocoagulation, combined cataract surgery, severity of post-operative vitreous hemorrhage, and use of expanding gas tamponade. There was another paper by Dr. Philip Muthar, which concluded that the groups which required medical treatment most often and should therefore be closely monitored. And care must not be taken to overlook the delayed IOP elevations. There was third paper which I went through by Jing Chao et al., which concluded that the IOP elevation was a common complication of vitreoretinal surgery, and the risk factors being ocular hypertension include C3F8 injection, silicone oil injection, lensectomy, endo laser, diabetes, and increasing patient age. So I would conclude that the laser photocoagulation is a common post-operative increased IOP, but in our case, we did not do any laser photocoagulation. There was a combined surgery. I agree to that, but there was no use of any gas tamponade nor silicone oil. Early onset of IOP spike is seen generally in post-vitrectomy vitreous hemorrhage or inadequate vitrectomy. But in our case, there was no vitreous hemorrhage post-operatively. There was no pupillary block. Inflammation can be one of the cause. And the late onset IOP causes could be peripheral anterior synechiae, rubiosis iridis, long-term steroid use, and again inflammation. But with the gonioscopy, we ruled out all these causes. Like there was no peripheral anterior synechiae, there was no rubiosis. So I actually don't know like what could be the cause of low IOP post-operatively immediately, and afterwards, after a week's period, there was a spike. So my take-home message will be a regular post-operative follow-up and evaluation time to time of all the parameters is very important. Subsequent management of any complication, if at all, is important for any surgery. And whenever needed, don't hesitate to take other subspecialty opinion. And I would like to ask the panelists, like, can you please give your expert opinion, like, what was the cause behind this post-op IOP fluctuations? Thank you so
Okay,
much for
thank you.
kindly
Thank you,
presenting.
Dr. Shruti. I think this is the case of the day, which consists almost hereditary, congenital, traumatic, as well as cataract, glaucoma, and retina component, as well as the pre-op and post-op complications. Everything is there to discuss, and we have two experts to discuss your case, Dr. Harshit Vaidya from Mumbai and Dr. Rohit Modi from Mumbai. Harshit, your comment, please.
Yeah, hello. Am I audible?
Yes, yes.
Yeah.
Yes, you can.
Great case, Dr. Shruti. So there are a couple of points which comes to mind. Is it possible that the trauma is trivial because the presentation of both the subluxation? So it's basically, it feels like a subluxation of the lens more than dislocation because it's in the pupillary area. So we would suspect that there is zonular weakness, and a trivial trauma has accentuated the problem. Number one. Number two would be the fact that most of the IOP spikes, a lot of vitreoretinal surgeries do have IOP spikes, like the causes you mentioned. One important cause could be a steroid response, which has kind of been probably because you started steroids, and you know that after a week or two the steroid has responded, and possibly this is the ocular hypertension which with AGMs could have been taken care of, because our 24-30 IOP we could have avoided a trabeculectomy according to me, but this is what my take would be. Dr. Rohit could probably add on, especially for this case.
Yeah. First of all, I would like to thank Dr. Manoj and Dr. Shamik for giving me the opportunity, and the MOS office bearers. Well-managed case, Dr. Shruti. Couple of points which Dr. Harshit has raised, I agree with him. My approach would be slightly different. Instead of iris claw, I would have preferred, going for a glued IOL, preserving the superior conjunctiva, because these patients who have a history of trauma and then subsequently dislocation of lens or subluxation, they have a high risk of IOP spike in the post-op. And the first week, usually what happens, even if you have sutured the ports, sometimes there is hypotony because the ports are not properly probably sealed, the vitrectomy ports. And once that healing occurs, then the IOP buildup happens, and sometimes there can be a steroid response. At what time the decision for TRAB was taken is important. And again, post-trauma in a young patient, simple TRAB may fail. We can think of doing TRAB with MMC. And whatever little knowledge I have about glaucoma, cyclophotocoagulation is unpredictable with respect to control of intraocular pressure. So I would have preferred probably going for a glued IOL and through a clear corneal incision and to save the superior conjunctiva. But to each on his own. Everybody has their own approach.
Is it that because of the iris claw, the pressure has spiked up later on, or because of the steroid response?
Another point I would. So possibly making a PI in an iris claw lens could possibly help if it's an iris claw that we are planning. Putting in having a PI would possibly help us at least in avoiding a block of sorts. And
I used to do PI with the iris claw, but nowadays I have seen that there is no IOP, right? So then I stopped.
Another concern is, when we do iris fixation, in a young patient, in that over a period of time, maybe you can see iris atrophy, which has led to dislocation. So I've seen a few patients in which I had to explant the previously implanted iris claw and put in a SFIL. Thank you.
Very challenging case. Dr. Agnivetri sir want to comment something?
No.
The chairperson of our session.
No. It's a wonderful presentation. My only concern is that there are so many reasons to think about that, whether the trauma was responsible for the part of dislocation, whether if there is angle recession also there when you saw the patient, because initially you have a low IOP and then it spikes, and it spikes very big. So I think a lot of things have to be discussed on this particular case. However, it's a wonderful presentation, bilateral. You did a the best possible surgery.
Yes.
And you hope that things will work out now. Let's go to the next.
Thank you, sir. Shamik, for the next case.
Yes.
Thank you, Shruti, for a wonderful, challenging case.
Thank you, Manoj.
We have 2 cases to finish before we call it a session.
Yes, that's right.
So we are going ahead with presentation by Dr. Kshitish Tamboli on role of TPA in submacular hematoma. So
that was,
yeah,
you're going for this first.
Yes, sir.
Yes, the POC is engaged somewhere.
Engaged somewhere, sir.
Okay, this time.
So just in brief about Kshitish, he did his VR fellowship at Rajiv Gandhi University. MS Ophthalmology at Rajiv Gandhi University. Completed his fellowship at RIK Karnataka, and he also did a ROP fellowship with LV Prasad at Hyderabad. He has 8 research publications presented and won various awards for research papers in state and national conferences. And he's currently at Tulsi Eye Hospital, Nashik. So over to Kshitish, please please go ahead with your presentation.
Is my screen visible, sir?
Yes, please.
Yes, it is visible.
At the outset, thank you, MOS and Dr. Manoj, sir, for providing this opportunity to me. Let us come to the case, speaking on role of TPA and vitrectomy in submacular hemorrhage. So this was a patient, 62-year-old lady who came to me. She was a non-diabetic but hypertensive since 20 years on irregular medications. She had a history of cervical spondylitis. She'd come with diminution of vision in right eye since 1 week. The vision was hand movements, and rest of the examination anterior segment was normal. However, we find submacular hemorrhage, as you can see in the figure. The other eye examination was normal. So when we did an OCT through the hemorrhage, we found that there was a sub-ILM component along with the sub-retinal component here. So basically, we did not know the cause in this case. We were suspecting 2 or 3 causes, but then we decided not to go with anti-VEGF. We decided to go with TPA 24 hours before the vitrectomy. We proceed to the video. So this is this was the pre-op picture you can see here, and this is the intra-op picture 24 hours post TPA. And when we started the surgery, started with putting the ports, and then PVD induction is being done here. So basically, as we know, there are a variety of treatment strategies for submacular hemorrhage. There is displacement by expansile gas, or you can use anti-VEGF in cases where you are suspecting CNVM or PCV. But here we have used TPA, and we found considerable result after 24 hours. The hemorrhage had the quite a bit picture has been changed. So after doing the PVD induction and removing all the vitreous, we found that clearing the sub-ILM blood would have been more effective with soft tip. So we started using soft tip and started clearing the sub-ILM hemorrhage there. It was working. Most of the hemorrhage was getting cleared over there. So at the end of clearance of the hemorrhage, started to find the cause of the submacular hemorrhage, and we can see a yellowish spot over there. It'll be more visible in a couple of seconds. So it is a macroaneurysm. So basically, this may be a ruptured ram that caused the submacular hemorrhage. So after clearing all the hemorrhage, we decided to stain it with brilliant blue dye. If any ILM was remaining or not, I just saw it. So there was hardly any ILM remaining. So it was confirmed that it was sub-ILM hemorrhage only, and most of the part of it. So it got cleared. And then I decided to go with the endolaser to treat the macroaneurysm. Around the macroaneurysm also, the short endolaser. And this is how it appeared on the table.
So the dose of TPA was given 12.5 microgram, which is quite a safe dose from the literature, is considerable in 0.05 ml. These are various causes of submacular hemorrhage. Won't go into details of it, but the TPA was first used by Heriot in 1996. It was a less invasive procedure. Rather than using it subretinal, you can also use it in the intravitreal form, and the results are there in literature to compare. After 6 months and after 6 weeks also, both the results were comparable in the literature. So we used it intravitreal. Thank you.
Thank you, Kshitish. Very well presented. To go ahead with the case, we have two of our panelists. The younger panelist is
who starts?
Vivek is there?
Yes, sir. Sir,
Vivek Adve
first
and
of all,
Agnihotri sir.
yeah.
Yeah,
nicely managed.
We want to.
Hello, Dr. Deshpande, myself has joined.
Actually, you have joined there.
Yeah.
No. Let's.
As the chairman of this meeting on 3 o'clock.
Oh, you have still time. We have still 10 minutes.
Yeah.
So you can join us later. I would let's finish this particular case. You think?
Continue. No problem.
No, I think we have time to continue.
Vivek, share your screen.
Yes. I think we have been disturbed by them. First, tell me, was it a sub-ILM or was it a submacular?
See, it was so basically clinically we thought it was a submacular hemorrhage. There was both subretinal and sub-ILM component.
Okay, how much of it was sub-ILM and how much of it was? Because it seems to
most of it was
it is sub-ILM. And the difference is only, I mean, of course, the management remains the same. I mean, you do use TPA to settle these patients. And we may not be very aggressive, really to remove that sub-ILM leak or because it really gets absorbed. Rest of it is very well done. I think end of the day, if you get a good vision back to these patients, you have done your job. The RAM lesion or whatever you have the lesions which are causing hemorrhage, you have to find out the cause. When if you find the cause and you treat the cause, probably you will have a better prognosis. Rest, I think that is enough of anything. Anybody else would like to add something?
Sir, I would want to.
Expert.
Yes.
If he has something to add.
Yeah, because we have less time now.
Yes.
I just wanted to ask one more question. Even if there is smaller amount of subretinal bleed, would Sir Kshitish sir, would you like to add gas at the end of the surgery?
Basically, we did not think of using gas in this case because patient had cervical spondylitis there. So we did not even inject it after the surgery. And in this case, it was not possible. Yes, but if it was significant in the macular area, I would have definitely thought of it. But there was not, subretinal hemorrhage was not seen after surgery in the macular area. So in any ways, it was not needed.
Have you ever thought of injecting or using YAG laser to reduce the bleeding?
Yes, sir, have done.
Because those are sometimes, extreme cases with, you can try it out and hopefully that works. Anyway, I think we can close this so that we have one more case to be finished.
Yes, wonderful, Dr. Kshitish.
Thank you,
now
sir.
we have a last case. It is on the RD with PVR. Dr. Piyush Bansal is going to present. This case, Piyush Bansal has done the Vitreoretina Fellowship from LV Prasada Institute and from Italy. He is a senior vitreoretina surgeon working at Pune, and he is a very dynamic young ophthalmologist or vitreoretina surgeons from our state and nationwide. He has several presentations. Now we'll see his presentations on RD with PVR. Here's to you.
Thank you very much, sir. Am I audible, sir?
Yes. Go ahead. You're doing good.
Thank you very much, Manoj sir, and Shamik sir. Thank you for having me over here. Thank you to MOS, and many congratulations for giving so many youngsters the opportunity. I don't think I'm that senior, so in the presence of all the senior most teachers of Maharashtra and my dear friends, some excellent videos, surgeries by Amit and Shruti and Kshitij. So essentially, it's kind of a repeat scenario what Amit had shown. So this is essentially kind of a triple trouble where we had a spontaneous dislocation of the nucleus into the vitreous cavity. There was a chronic retinal detachment with obviously extensive PVR. The patient had just light perception in the right eye. His other eye also was opaque because the nucleus had gone to the back. On the right, the eye that I will be showing was essentially a globe salvaging procedure. The IOP had started to reduce. It was 6 at the time of surgery. So that's the reason that, as a last resort, the patient was taken up for surgery. So as you can see, trocar cannulas are being introduced, and it has, many people have pointed out, it's very important to make sure that the cannula is not subretinal. It's also important to make sure that all the vitreous is being trimmed around all the instruments that are being inserted inside the eye. And first, since the nucleus is soft, the cutter itself is used to get rid of the nucleus, obviously making sure that the vitreous is first separated around the nucleus so that it is free. Now you can see it's a closed funnel RV, and there's a lot of difficulty in finding the right membrane. So an opening is made, and this essentially into the vitreous, and then this essentially helps in kind of searching out the right plane for a peel, because it's going to be especially challenging. And you can see that now once you found it, you can kind of start removing the membrane in piece also, or in toto, as you can see over here. One has to be careful in such situations as to not inadvertently cause a break as well. You see that the retina is extremely friable over here, and gradually trimming of all membranes and the vitreous as much as possible is being done, and the retina is being unfurled as we go ahead. Now that we can see some amount of the posterior pole, PFCL is then injected to kind of unfurl the retina, and you can see a break that has just exposed itself. So SRF begins to flow out, and what we need to do is aid this SRF, remove as much of it as possible, so that this helps in flattening of the retina despite the membrane. The next step after you do this would be perhaps to make sure that whatever vitreous is stuck to this particular break is all dissected and cut out, and then subsequently remove any other star folds or any other membrane that is possible. Put in some more PFCL after this, so that you can see what more area can be made flat. Now the next, since the retina, you see how taut the peripheral retina is. So now the next step, obviously, you wouldn't want to do a retinectomy in most situations, because you're exposing the choroid and you're causing increased chances of PVR in an already existing case of PVR. However, you're left with no option. So the next step would be to mark the area of retinectomy with an endocautery, as you can see, and then begin to cut the retina over there. This essentially, like Amit said, it reduces the chances of bleeding and also marks that particular area so that you don't have any doubts when you're beginning to laser. So after the 360 degrees retinectomy is done and the anterior retina is cut, the next step would be, now since you're going to put in silicone oil, you make an inferior iodotomy and then go in and see whether it's holding flat. It is in this situation. So the next step would be to use endolaser. Now, like Amit rightly said, we add as many rows of endolaser as possible, at least 4 to 6 rows of endolaser. And after this is done, the next step that it was done in this case was to do air exchange along with and remove PFCL. Now, there was a question by Dr. Anindya saying that why would you not want to do a PFCL silicone oil exchange? It can be done. I do that most often as well. But then, when you have the opportunity to put in air and see whether the retina stays back, that pseudo feeling of the retina being attached under PFCL is kind of done with. So that's the reason that you put in air and make sure that you, at the borders especially, there is no chances of slippage, and you make sure that it is bone dry as you can see in this particular situation. And after you have achieved this, then the next step would be to add a silicone oil. Obviously, it's very important to achieve a good fill, not an under or an overfill in such a situation. And then the ports are removed. So you see post-operative day 1 and then subsequently also the retina has managed to stay attached. We were able to give the patient ambulatory vision, it was 460, and more importantly, the IOP was building up. So the other eye was also taken up for surgery later. So thank you very much.
Thank you, Piyush. Thank you for discussion of this case. Very complicated you have presented. We have Dr. Abhidnya Surya. She has done fellowship from AIMS Delhi and now working at Healthcare Hospital, Aurangabad. And Dr. Rushikesh Naigavkar. He is a medical director and a senior veterinary surgeon at Sri Ganpati Netralaya, Jalna. Abhidnya, to you. We are running little short of time, but
yes, sir. Thank you, sir, for the platform. Piyush, sir, a very nice surgery, very difficult case, and extremely nicely managed. And giving a vision of 4/60 is more important to that patient. While we went through the cases, we saw that there were a lot of PVR changes, and I think as a junior person, I would think we have to think about how to stepwise go about the cases. So first thing is, whenever we try to do such a vitrectomy, we try to pull out all the membranes, give a gentle traction, and then try to release those membranes. And slowly releasing it from the posterior to anterior, we try to remove those membranes. Further, if not removed or there is significant traction, we try to use PFCL. We saw that you were putting right amount of PFCL, removing the membranes, then injecting more amount of PFCL. So that is how we go ahead in such kind of surgeries. And then we go with relaxing retinotomies. And if not managed with that, then the retinectomy is the last option which we should consider. Very nicely case managed, sir. And what are the role of do you consider bands in such scenarios of grade 3 or 4 PVR, where there is high amount of PVR present?
Thank you for your points, ma'am. I'm not that senior, but I don't personally use bands very often, especially in these cases with the extreme amount of PVR. I did have an idea that perhaps I'm going to require to do a retinectomy, especially, it helps to do a B scan, even though you have a visualization of the retina in such situations, but doing a B scan pre-operatively can give you a certain idea whether you can have a right plane. So again, this kind of closed funnel RDs, it's very unlikely that a belt buckle, even a 240, is going to be of much help. So that's the reason that, and again, IOP. Again, IOP, considering the fact that it was a very soft eye, unnecessarily inviting more trouble would not be my cup of tea. That's the reason that I did not put a belt.
That's very correct. That's very correct. Dr. Rushikesh, sir, your comment?
Yeah, the only thing that I would like to add in such cases, now the patient has already had low IOP, is to check the ciliary body thoroughly intra-op and see if there are any ciliary body membranes and remove them as much as possible, and see if there are any atrophic changes in the ciliary body. This could help us prognosticate the case. Luckily for you, the IOP built up over a period of time post-operatively, so the patient was also lucky. Otherwise, we see a lot of cases where the retina is very well settled, but these patients eventually go into phthisis because of the chronic hypotonia. Oil comes into the AC and the patients eventually develop band-shaped keratopathy. So overall, a well-managed case. As Avidnya pointed out, some cases I would consider putting a band as well. And the only one case I would like to add something is about Dr. Rahul's case, sir, with the CD. The nasal choroidal detachment amount was very high. So what I do in such cases is I keep injecting oil from the other superotemporal port. And the superinasal cannula, I would just pull partially so that the inner tip is in the suprachoroidal space, and that would help us drain some more amount of SRF. Because what happens in such cases is there's some kind of underfill in cases with CDs when you are actually injecting the oil. And when the retina and the CDs settle down, there may be some perisilicon proliferations in such cases. So, and these patients also have hypotony post-operatively. So that's it. Nothing more to add from my side, sir.
May I add
Excellent,
something, sir?
excellent.
Yes, sir.
That's an excellent point that you brought about Naganga, sir. In fact, that's the part of the recording that was not there within the case, but there was, in fact, membranes on the ciliary body is here as well. So again, I made it sure that after I did everything, I went over there because I've had such experiences in the past that despite doing the best possible vitrectomy, the ciliary body shutdown still eventually happens. So making sure, taking that extra minute and just examining, depressing a little more and making sure that if there are any membrane, then at least attempting, it might bleed. It is a risky scenario, but it is worth just making sure that if there are any membranes, try to at least remove some of the major membranes there.
Yes, yes. Thank you, Piyush. Piyush, handing over to our chairperson, Dr. Agnihotri sir, to conclude the today's session. I would once again thank to Scientific Committee MOS for giving and bringing up the beginners. Particularly, I hope Rahul, Amit, Shruti, Piyush, Kshitish, Vivek, Ketan, Kaustubh, Harshid, and Avidnya, who have already presented and come out of the box and started presented and coming on the dais. There is always a need of someone. Once upon a time, someone has given me the lift,
Yes,
and now I am
True.
state and national faculty. Same thing. I hope all, and my good luck to all presenters and young panelists for the good future in the ophthalmology.
And I can only give.
Agnihotri sir, your comments, concluding comments, please.
I just want to thank everybody of you who has come forward and presented. They have done an excellent job. The first time it might be difficult, but the way you've taken a step forward, it's always going to be a positive step. Thank you so much to everyone, because we are now running in short of time. God bless all of you. Enjoy yourself. Have a good weekend, all of us. Bye.
Thank you, everyone.
Thank you, sir, and thank you, Dr. Sasavade sir and Dr. Shamik, to take this amazing session with all young retina surgeons.
Yeah,
and
you are
the
there.
main motto was to give them the right platform. They have done amazingly well, and thank you so much, Dr. Agnihotri sir, for being the chair and guiding all our young experts and young presenters as well. Thank you. It was absolutely wonderful session, sir. Thank you.
Thank you so much.
Thank you.
Bye-bye.
Thank you, sir. So I think now we will move on to the last and very important session, equally important, which is oculoplasty. And this is going to be taken forward by our very dynamic moderators, Dr. Aditi Watve. And I'm happy to introduce Aditi. Aditi is of course, very well-known oculoplastic surgeon trained at Arvind Eye Hospital and LV Prasad Eye Institute as well. She's doing very good work in Kolhapur as oculoplastic surgeon, but she's doing equally amazing work as secretary of the scientific committee. I'm very lucky to have her as a secretary, and kudos to her for all the hard work for this meeting as well. And also welcome Dr. Shubha Zawar ma'am. You can see the paintings on her backdrop. She is truly a multi-talented personality, and both of them are going to take us through amazing world of oculoplasty. Over to you, Aditi and Dr. Shubha ma'am. Thanks.
Thank you for the introduction, Vardhaman. I think Shubha madam, you want to start.
Thank you so much, Vardhaman, for this introduction. Yeah, thank you so much for a wonderful introduction, and I congratulate MOS for conducting this wonderful midterm meeting online. And it's a great opportunity for the youngsters to put up their cases. So without much ado, let us start with our session.
Chairperson and co-chairperson have also joined. So I would like to first thank Dr. A. Deshpande sir and Dr. Pakhre sir for joining us as chairman and co-chairman for the session. Thank you so much, sir. They are like our past presidents of MOS and senior ophthalmologists. So I don't think any introduction for them is needed. Everybody knows them. Thank you so much, sir, for joining us. Shubha madam.
Yeah, welcome A. Deshpande sir from my own place, Aurangabad, and welcome Pakhre sir, also from Marathwada. I'm glad to have you here, sir. So first of all, we would like to invite Dr. Prerna Tahiliani for her case on overcoming the light side of the periocular region. So Prerna has been presenting cases everywhere in all oculoplasty sessions, and she's a very active oculoplasty surgeon who is practicing right now at Mumbai Eye Plasty Center, Mumbai. So over to you, Prerna. Please share your screen.
Yeah. Thank you so much, Dr. Shubha.
So without any further ado, I would like to start my case. So the reason that I chose this topic and called it the light side of the periocular region is because as oculoplasty surgeons, we very often focus on dark circles, which itself is an enigma. Now going to an untraversed territory, let me discuss this 8-year-old girl's scenario. So she's a girl who had periocular white patches since 3 years before she met me. She was already diagnosed as non-segmental stable vitiligo and was already taking treatment in the form of topical tacrolimus, which is a calcineurin inhibitor, steroids, and phototherapy. However, the response was patchy and unsatisfactory. The reason she was very bothered is she was being bullied at school, and that was very discouraging for her parents. So when we look at treatment options for vitiligo, the pharmacotherapy and the phototherapy is really not our arena. But what are the side effects or what are the plus points of surgery versus this treatment? Whenever you look at pharmacotherapy and phototherapy, these are prolonged therapy sessions. So you need multiple visits. There are systemic side effects of oral immunosuppressives and obvious potential adverse effects of topical periocular steroids. So considering all this, we were thinking of surgery, going a little bit into a basic of vitiligo. So there is a segmental variant and non-segmental variant. The segmental variant responds very, very well to surgery. It's basically on one side affecting only one segment or dermatome of the body versus a non-segmental, which is the typical, which affects both the sides and is a little bit more aggressive. So surgery can also be a missing piece in the puzzle in the non-segmental vitiligo. With this, there are two very popular forms of surgery. One is a mini punch grafting. It is a derivative of something that started off as an ultra thin skin graft, and then it has been modified into this technique, which is a tissue-based graft. It is quicker. You don't need a lot of equipments. The only side effect probably could be cobblestoning and polka dot appearance, with which expertise and experience you can eliminate these effects as well. And the non-cultured epithelial cell suspension is a cellular graft where you need a little bit of pathology equipments, reagents, enzymes. The advantage being that there are no epithelial irregularities. So considering this was bilateral, I wanted something quicker. The 8-year-old girl decided to undergo this under local anesthesia. So 1 millimeter mini punch donor grafts were taken from the upper outer thigh because that was a good color match. And there is a ready available punch that is usually used for biopsy. I use the 1 millimeter discs. The epithelial discs are then removed or extracted. They are placed in Ringer's lactate. A tarsorrhaphy is done to immobilize the eyelids so that the grafts do not get displaced in the immediate post-operative period. And these recipient donor bed is made ready by excising the hypopigmented skin over here. So usually a 1 centimeter apart placement is adequate, but for uniform coloration or repigmentation, a 0.5 centimeter is what is recommended. So this surgery was done very easily. 1 week after surgery, the graft is being taken up. At 2 months after surgery, you see this polka dot where the melanocytes are spreading out and repigmenting the hypopigmented skin. At 4 months after surgery, you see that there is better coverage. And at 8 months after surgery, she was very happy because only with her eyes closed, a little bit of patch was seen. Here you can appreciate that the inner corner has some cobblestoning. This was one of my initial cases. So over time, I realized how I could eliminate this side effect. And at 1.5 years, without any adjunctive treatment, she has repigmented her upper eyelid completely. So the going a little bit into the non-cultured epithelial cell suspension, this is something I tried on this patient. The difference in treatment here is you microdermabrade the epithelium, which can be done with a diamond burr that all of us have in decompression surgeries. A blood sample is taken and the trypsin is used to basically take the donor area and trypsinize it and remove the collagen or the dermis from the epithelium. Then a suspension is made from the epithelium and it is actually placed like a gel with a very simple collagen dressing on top. So I found very encouraging results with this surgery. I've done 9 cases so far. And I really want to focus that we bring periocular vitiligo in to highlight why. Because when I look at the literature review from ophthalmologists, there are a group of ophthalmologists that are replicating, studying dry eye and meibomian gland dysfunction in all the dermatological diseases. There's not much known about vitiligo and the eye. Sometimes it can affect the iris and the choroidal pigment. That is rare. But people talk about dry eye disease, and none of these patients that I have seen, there is any inflammation. The very specific cell line that is targeted in vitiligo is only the melanocyte. So I do not see dry eye disease. I do not see any kind of punctal inflammation, but I see these reports being replicated over time again and again. So with this, I just wanted to bring in something new because we always talk about the same things, and I wanted to share my experience about these cases. Thank you.
Thank you very much, Prerna. And I would like to invite our experts for this case, senior expert, Dr. Rajat Maheshwari, who is also my co-organizing secretary for the Midterm Oculoplasty Conference, and he's serving as an oculoplasty surgeon at Netra Seva Foundation, Jalna. So welcome, Rajat.
Yeah.
And also the young expert, Dr. Kshanada Gupta. She's a fellow from Shankar Netralaya, Chennai, and is currently practicing in Thane and Mumbai. So this was a wonderful case, Prerna. So over to you, experts.
Yeah, I think congratulate you for fantastic results. And no doubt that vitiligo is a non-life-threatening asymptomatic disease, but definitely the psychological and social impact that has is maybe more than what at par with the patient having some severe life-threatening disease. So one thing I want to I would like you for the our viewers to highlight is how do you determine the severity of the disease and any predictive variables when you decide on taking the patient for surgery?
So like you mentioned, this is not a life-threatening disease. It definitely has a psychosocial effect. So severity, basically, there is a dermatology team. That is not my job. But what I've learned from them is it has to be stable vitiligo before you go in for surgery. Right. So confirm the diagnosis. You can even use a simple Woods lamp. Very often I get vitiligo patients and ophthalmologists have referred them as drug reactions. So that is completely different. That is a commonest mistake we make. Drug reactions will reverse because there's nothing attacking the melanocytes once the drugs have been stopped. Versus vitiligo, where it will either be progressive or it will at least be stable. Then you look at the margins for activity like you do in oncology. If the margins are not well defined, then it's an active disease which is still spreading. You observe the patient over time. Once you start in topical or oral or phototherapy, if the margins are sharper or you see the melanocytes coming from the surrounding normal skin inside, then you know that this is a resolving kind of disease. But obviously medical therapy and phototherapy, like I said, it's more number of sessions and the duration is long. So for patients who want quick relief, and if it's a stable disease, I'm all in for surgery. And I think the periocular area, because the skin is the thinnest and you have to do microdermabrasion, you have to do the punching, immobilization. So we can definitely work as a team with dermatologists for this disease.
Yeah, I mean, correct. So fantastic results. And I think the key words would be stable disease.
Yes.
And accurate diagnosis.
Yes. So I leave that to the dermatologist, but just some knowledge that they've passed on to me, that's what I understand then.
Yeah, but, I mean, hats off to, venturing out on a new area. Thank you so much.
Thank you. Thank you so much.
Hi, Prerna. Shanada here. Wonderful presentation.
Yeah.
And Prerna, thank you for bringing in a novel case to our oculoplasty armamentarium. And being periocular, so it is still relevant to us, right? Prerna, I just wanted to know, there are certain prerequisites that we take into consideration when we embark upon a medical therapy, when we embark upon surgical, which is resistant to medical. So as Rajat rightly pointed out, maybe it was the stability of the vitiligo that was one factor that you embarked on this certain therapy. Would you for the benefit of audience, would you like to tell whether there are certain other factors that need to be taken into consideration, like the type of vitiligo, or the age, or certain factors that you would like to add?
Yeah, so I have had the oldest patient being 70 years old, and he has also repigmented well, but definitely younger patients will have a more favorable response. The difficult areas in vitiligo to treat usually are the acral parts, the tips of the fingers, toes, the genitalia, areas basically which are devoid of hair, because hair shaft is where the melanocytes come from. And periocular also is found to be sometimes resistant to traditional forms of therapy. So if there is a non-segmental vitiligo, like this girl here is bilateral, she's non-segmental. So she has to be counseled, the family has to be counseled that they may need adjunctive phototherapy to maintain the results. But sometimes, like this girl, she did not need any therapy, and at 1.5 years, she did not lose any of her pigmentation. So all this counseling has to be factored in much before. But as such, it's not a very challenging surgery. And it is something we should definitely look at, because I feel we drive a lot of energy into dark circles, which is not a medical disease. We also don't have the answers for it. And here there are patients who have diseases where we can help them, and we are not focusing on that.
Very true.
Sure. Thank you. Thank you so much, Prerna, for this novel case. Thanks.
Yeah.
Thank you, Prerna, for a wonderful talk. And are there any find any? What was your follow-up till now?
So 9 patients, earliest was done in 2017. So that is more than 5-year follow-up. And the last I had done was last month. So I've had average like short-term as well as long-term follow-ups. And some of them, like I said, do need narrowband UVB or excimer laser or some kind of adjunctive therapy. Those are the non-segmental cases.
Thank you, Prerna, for a wonderful case. I guess we'll go to the next one.
Yeah. So we welcome the next speaker, Dr. Sonal Yadav. She would like to speak on globe salvage in orbital squamous cell carcinoma, achieving the unachievable. So Sonal is right now practicing at HV Desai, Pune. Over to you, Sonal.
Thank you, ma'am. Am I audible well?
Yeah, you are.
Yes, you are audible.
Thank you so much. I would just shortly like to send my kudos to Prerna for introducing a very novel case. Might not be novel for the dermatologist, but definitely for us, and taking the oculofacial aesthetic practice to a newer level. Okay, so moving on, I will be talking about a case from the oncology specialty. So here I have a 68-year-old female who presented after noticing drooping of her upper eyelid for around 3 to 4 months. She was actually a very compliant patient for her primary open angle glaucoma that she had in both the eyes, and our glaucoma consultant basically noticed that this new finding that she's having a drooping of the upper eyelid in left eye. Other than that, she did not have any significant medical or surgical history. So going on for further examination, I did notice a firm irregular mass lesion which was occupying the superior lateral orbital quadrant, which was causing a mild inferior globe dystopia and partial restriction of movements and elevation as well as abduction. The sign that told me that something sinister is going on, that the eversion of that upper lid was not possible at all in OPD, even after using topical anesthesia. She showed mild enophthalmos, and Schirmer's test was marginally reduced in her left eye, showing that some kind of disease is also affecting the lacrimal gland. Looking at the 9-gauge extraocular movement picture shows the partial restriction in elevation as well as abduction. So we went ahead and got a CT scan done, which showed a fairly well-defined mass in the extracorneal compartment of the left superolateral quadrant, which was extending from the anterior orbit to mid-orbit. And it was conforming to the globe curvature without causing any significant globe indentation. The LPS-SR complex as well as the lacrimal gland was, however, not visible separate from the mass. So in terms of differential diagnosis, what I was thinking about are the lymphoproliferative disorders, lacrimal gland tumors, possibility of a conjunctival squamous cell carcinoma, or a secondary orbital metastasis looking at her age and profile. So we took her up for incision biopsy. And this was her intraoperative picture, very vascular lesion, rightly sitting on the upper border of the tarsus and getting disappeared behind the superior orbital rim. Histopathology came out as a moderately differentiated squamous cell carcinoma arising most probably from the conjunctiva. So this was looking at the morphology of the disease. This was probably arising from the fornicial conjunctiva. So we went ahead with a whole body PET CT scan to rule out any regional as well as distal metastasis, which she didn't have any. So here, looking at the vascularity of the lesion and the unusual size and shape and location, I did want to go ahead and try a globe salvage therapy. An invasive orbital squamous cell carcinoma is kind of an aggressive malignancy. And if we look at the literature, orbital exenteration is one of the actually the treatment of choice as mentioned. However, we did want to try globe salvage in this patient. So she went ahead with a neoadjuvant chemotherapy using paclitaxel and cisplatin, following which we reimaged, and there was not much change in the dimension of the lesion per se on the CT scan. Then we went ahead with an en bloc surgical excision of the entire lesion. What the chemotherapy also helped in a little bit of consolidation of the lesion and decreasing the vascularity, which helped during the surgical procedure. Following which we gave her adjuvant radiotherapy using the intensity modulated protocol to minimize the dose to the cornea and ocular surface, which was around 60 grain, 30 fractions. The histopathology after the final surgery also confirmed the diagnosis of invasive squamous cell carcinoma arising from conjunctiva, and it also showed foci of lymphovascular invasion, which actually prompted us to definitely use the adjuvant radiotherapy. So this is her at presentation and at 24 months of follow-up after multimodal treatment using neoadjuvant chemotherapy, complete surgical excision, and adjuvant radiotherapy. She at 24 months of follow-up, she has stable visual acuity, no locoregional recurrence. Though we did an IMRT, she did have consequences of ocular surface toxicity from radiation in terms of dry eye and episode of trabeculitis. However, everything was controlled medically and the vision remained stable. Also have the CT scan images of her pre and post treatment follow-ups. Here you can see at the 24 months of follow-up, the entire lesion is regressed without any sign of recurrence in both the axial as well as coronal sections. So basically, invasive squamous cell carcinoma of orbit, as I said, is a very aggressive malignancy and is one of the indication for orbital exenteration. Primary SCC is rare. However, secondary, as in our case, as orbital involvement in advanced conjunctival SCC is very well known. Though the squamous cell carcinoma is extensively explored in head and neck region by our colleagues, no consensus-based protocol is present for use of either neoadjuvant therapy or any other therapy for orbital SCC. Anecdotal cases of use of neoadjuvant therapy has been published in literature. So here we present a case of invasive orbital SCC, likely originating from the fornicial conjunctiva, which is also a rarer area of origin, with multimodal treatment, including neoadjuvant chemotherapy, wide local excision, and adjuvant radiotherapy, resulting in globe salvage. Here, as a take-home message, I would like to highlight the use of neoadjuvant chemotherapy. Though it did not reduce the dimension of the lesion, it definitely helped in consolidating the vascularity and making the surgery easier. So I would like to recommend extensively discussing the protocols and possibilities with your medical oncologist as well as radiation oncologist, because we all are aware of the resistance we get for using neoadjuvant chemotherapy for squamous cell carcinomas. These are my references, and thank you for patient listening.
Thank you, Sonal, for a wonderful case presentation. I would like to invite the experts here, senior expert, Dr. Akshay Nair, who is the Director of Oculoplasty of Dr. Agrawal Group of Hospitals, Mumbai, and a young expert, Dr. Anup Chandak, who is an oculoplasty from Shankara, Bangalore, and is currently the Director of Eye Skin Hospital, Amravati.
Thank you, ma'am, for the kind introduction. I think it was a very well worked up case. I think the important thing that the audience should know is, like Dr. Sonal rightly did, when you have a primary lesion in the orbit, like a squamous cell carcinoma or any tumor like a lacrimal gland tumor, nowadays getting an ultrasound abdomen, liver function test, chest X-ray is absolutely not adequate to look for metastasis or for a primary that could have metastasized to the orbit. So if there's a lacrimal gland tumor or an orbital primary that you do not know about, a PET CT is absolutely mandatory in telling us two things: A, if the orbit is the primary and if there are mets otherwise, or if there is a primary elsewhere and the orbit is a mets, which we can detect, we can figure out later. And I think the only issue will not be issue, because I think eventually the management would have been same, that it could be a very unlikely possibility of a squamous cell carcinoma of the lacrimal gland itself. There are a couple of rare cases reported, and especially, you showed that anatomy so beautifully, creeping under the levator just up to the tarsus. It almost looked like the palpebral lobe and the orbital lobe of the lacrimal gland.
I did explore the possibility even exactly like as you said during my incision biopsy, but looking at the biopsy of the entire lesion too, they were just, it was just invading the lacrimal gland partially in its lateral extent. That's what my pathologist came back with, because I did tell him to extensively look at the slides and tell me the origin of the lesion as much as with surety with which we can. So as it was not involving any other, not majorly involving the lacrimal gland structure, then we kind of concluded that it was arising from the fornicial conjunctiva.
Yeah, I think that was the only thing that I had to say. And perhaps, I mean, it's an academic discussion, but say Vimentin or any other immunohistochemistry to look for myoepithelial acini could have helped in confirming that. But,
yes.
Yeah, but
yes.
I think either ways, the management would not have changed. En bloc excision, post-op radiation, and post-op PET CT to monitor would have been the same. It's the same thing you've done. So I think a great job in saving the globe. A lot of us may not would have thought so much and gone ahead and directly exenerated.
Yeah, that's actually one of the reasons I wanted to present this case. And I did discuss the option extensively with the family at the after getting the initial diagnosis and the PET CT reports. However, the family was very keen on trials for therapy, and this is like I actually tell my fellows that this is one of my star patients, very compliant patient, very compliant family, following the advices to the T. So it was actually really, really gratifying to save her globe and keep her happy after experiencing an orbital invasive carcinoma.
Dr. Anup, any comments, please?
Hello, yes, sir.
Yeah, you just wondering if you have any questions or comments on this case.
Yes, sir. First of all, sir, it is I would like to congratulate Dr. Sonal that she got very excellent result in such case, because I was already very surprised that there is no recurrence on 2.5-year follow-up, though it was a secondary squamous cell carcinoma with probably neural spread because the patient presented with ptosis. And there are some case reports like in Saha et al. And Arbelu et al., where they had case reports with primary squamous cell carcinoma. They did wide excision, they given chemotherapy, intensity modulated radiotherapy, and still they showed recurrence after 1 year of follow-up. So I was very surprised that she got very good result in this case.
Yeah, I would say probably the neoadjuvant chemotherapy worked. And second of all, we did not have any perineural invasion. The ptosis was more of acquired nature, more of mechanical in nature because of the lesion sitting at the location that it was. We did have foci of lymphovascular invasion. So I would say she's a lucky lady to not have had any recurrences. But she's under a very close watch with yearly whole body PET CT scan and 6-monthly CT scan of the orbit to look for any local or a regional recurrence if at all it comes out.
On histopathology,
maybe last
on
question we can take.
Yeah, I would like to ask Sonal, any role of any radiotherapy or something?
Yes, ma'am. We did adjuvant radiotherapy after surgery.
Okay.
Yeah, that also helped, because after learning about the lymphovascular invasion, that was kind of a mandatory adjuvant therapy for this patient.
Yeah.
But I was extensively involved with the radiation oncologist in planning her radiation to make sure that she gets minimal dose to her cornea and globe, which is inevitable. The ocular surface and cornea is going to get irradiated, even if it is an 3D conformational radiotherapy. However, it really helps if you have a detailed discussion and let them know which areas they can avoid, if at all it helps.
So now, can I ask a question? If the spread is
Yes, sir,
not
please.
there in scan, that is then we will advise the chemotherapy.
Yes, so like I said, the chemotherapy per se did not help in reducing the size of the lesion, but it definitely helped in consolidating the vascularity, which helped the further wide excision or the further surgery a little bit easier. Because if we go back and see the image of the incision biopsy, it was a very highly vascular lesion, and which the bleeding control was achieved meticulously even after a small incision biopsy. So if without that neoadjuvant chemotherapy, probably her surgery would have been very, very difficult, and getting the entire lesion out would have been impossible.
Okay, that
The
radiotherapy.
neoadjuvant chemotherapy, in my opinion, helps in
Radiotherapy instead of
neoadjuvant chemotherapy
giving
many times helps in actually reducing the micromets also, distant micromets, in case they have already occurred. So yeah,
definitely, yes.
Yeah, we will go to the next case for the.
Thank you,
running behind the schedule. So I would like to invite Dr. Pallavi Khedkar. She is a renowned oculoplasty surgeon from Aurangabad. After getting trained for DNB from Shankar Netralaya, she has done her oculoplasty fellowship from Arvind Madurai. Dr. Pallavi, over to you for the presentation. And till she shares her screen, I would take opportunity to introduce our experts. Dr. Rishikesh Tadwarkar, who is a senior oculoplasty surgeon who practices in Mumbai and Navi Mumbai, trained from Arvindaya Hospital, and Dr. Ravindra Vankade from Solapur. They will be giving their expert comments. Over to you, Pallavi, for the case. Your slide is visible, but you are not audible in case you are talking. Pallavi, you are not.
Am I audible now?
Yes, now you are audible. Please start.
After the excellent cases of Prerna and Sonal, I'm presenting a story of unexpected guest from the neighborhood. This was a 10-year-old boy who presented to the clinic with watering since few years, and on examination, his anterior segment examination was completely normal. Vision, conjunctiva, cornea, and ocular movements also completely normal. On the particular right eye examination, tear film height was normal, red lid margin was normal. Puncta was both the puncta were patent, and Roplas test was negative. Particularly the anterior medial canthal displacement was observed. And I would like to mention the special mention about my colleague ophthalmologist, general ophthalmologist, who actually had noticed this mild anterior displacement. And on palpation, there was a firm to hard mass just above and below the medial canthal tendon. There was no tenderness, no erythema, no pain on palpation, and syringing was patent from upper and lower punctum. So this, if we compare to the left eye, we can see that mild effacement and the curvature of the medial canthus is also changed, and it is the anteriorly displaced medial canthus. So imaging was advised, and on CT with contrast, it was seen a well-defined lesion. It was expansile in the right anterior ethmoid region, and it was extending up to the nasolacrimal sac and the duct. And there was a suspension of bony erosion in the area of medial wall of the orbit, abutting the medial rectus and pushing the medial wall of the globe orbit. So what next? We had decided to go for a surgical removal of this expansile cyst. And if there is any bony defect or any erosion was observed, then reconstruction of the bony defect. So the challenges were options of medial wall reconstruction. The options were titanium mesh, porous polyethylene sheet, or a calvareal bone graft. So the Lynch incision was chosen as an approach towards the lesion from the medial canthus to the nasal dorsum, and dissection was done up to the periosteum, and it was elevated with the special care to preserve the lacrimal sac. And here we see the guest in the medial orbit, and it was completely separate from the lacrimal sac. I could go up to the separation of the lacrimal sac and the cyst, and even the lacrimal sac was separated from the fossa up to the nasolacrimal duct. But from the lateral margin, the cyst was completely adhered to the ethmoid and the lacrimal bone. So we decided to do the marsupialization of the cyst and the cyst wall laterally, the bony spicules from the lacrimal bone. Everything was removed and sent for histopathological confirmation. And the cavity was washed with thoroughly with betadine. And at the end of the surgery, the lacrimal sac patency was confirmed and closure was done. So this is the result on day 1 of the surgery. And provisionally, I was thinking whether it is ethmoidal mucocele or a choriostoma, but on histopathology, we found it a respiratory epithelial lining of the cyst, which goes in favor of choriostoma, which is very rare in the medial orbit particularly. So in this case, I chose this case as there was a challenge whether to excise the mass and how to reconstruct if there was a bony defect. So thank you, Moscon Scientific Committee team and my mentors.
Nice case, Dr. Pallavi. Any comments from the expert panel? Dr. Rishikesh Tadvalkar, Dr. Ravi.
Yes, good afternoon and thank you, Moscon. First of all, Pallavi, very nice case, and also congratulations to you and your team, because you must have had a very high index of suspicion, because there was a very subtle change in the anatomy, at least on the two-dimensional photographs that we saw. So very nice that you picked up on the distraction of the medial canthus, and the investigations also, they were very stepwise manner done. Also very good surgery and documentation. My only question is that, did you consider an endoscopic or an endonasal approach for surgery? Because eventually you had to take a very large incision.
Yes, sir. Actually, because we were suspecting bony erosion and removal of the bone reconstruction, that is why I chose the open approach. Otherwise, definitely for this particular case, if there was no suspicion, then definitely endoscopic approach would have been much better regarding cosmesis.
And now, since the surgery, now how long is the follow-up now?
So it's a very short follow-up. Till now, it's only a month. So.
But is the patient showing some resolution of symptoms?
Yes, sir. Yes, yes. There is a resolution, and there is also the medial canthus has gone back to the normal position, and it's looking good.
Very good. Congratulations.
Hello.
Yes, you are audible.
Yes, sir.
Yeah,
yes, sir.
thank
Go
you.
ahead.
Yeah, I think Dr. Pallavi needs congratulations. It was a very nicely presented case, and even the important thing was preserving the sac during the surgery, and because it should not be damaged. So it is, although looks simple, but it was difficult to preserve the sac as well. But the only thing which I even the sir commented, the incision was little bit bigger in size, but otherwise I think it was the need of the hour during the surgery. But I congratulate Dr. regarding that.
One point I would like to add, like for the benefit of all residents or comprehensive ophthalmologists, whenever any lesion in the medial canthal region is there, the first DD will always be dacryocystitis, but we need to see exact location of the lesion. Generally, dacryocystitis or mucosal lesions will be below the MCT, which is medial canthal tendon. So anything around it or going above the MCT should always be looked upon like with a suspicion, just to make sure that we are not missing anything else and labeling it as a dacryocystitis. So in those cases, I would recommend don't hesitate in imaging, at least a basic CT scan. That will give a great idea in case there is something else. So that is one point from me. Yeah.
Just to add up, Aditi,
perfect.
recently, just one of my small experience. Recently, I had a swelling which was above the medial canthal tendon, and then I was expecting it is not to be a sac at all. But when we did CT DCG, it turned out to be the diverticulum of the sac because of the chronic inflammation. Just to add up, I mean, but in general, your dictum is correct. It is below MCT. It should be a sac. If it is above MCT, then generally it is not a sac swelling.
Very true, because even this patient is now 10 years old and he was roaming here and there every other ophthalmologist for watering, and he was getting treated with frequent antibiotics, anti-allergics, and symptomatic relief, and thinking of it as partial NLDO or something like that. And ultimately he landed up in oculoplastic clinic.
Nice presentation, wonderful
very good,
case.
nice presentation.
Good
So
case,
we
Aditi.
will go to the next presenter, Dr. Richa Dharapwak. She is oculoplasty surgeon trained from LV Prasad Eye Institute, Hyderabad, and currently based in Nagpur. You can start sharing your screen, Richa. And for giving the expert comments, I would like to invite Dr. Vidya Shankar sir, who is a senior oculoplasty surgeon from Mumbai, and Dr. Adit Gupta, who is also from Mumbai. Over to you, Richa, for presentation. Your slides are seen.
Okay. So I would be presenting a tale of teary floppiness. So before I start, I would just like to congratulate the entire MOS team for organizing this first ever midterm meeting. I have no financial disclosures. So this 48 years old, short-statured, obese gentleman presented with watering, foreign body sensation, redness off and on in both the eyes since 1 year. He was treated in the past year for allergic conjunctivitis multiple times. There was no history of systemic illness, trauma, or surgery in the past. On ocular examination, best corrected visual acuity was 6.6 and 6 in both the eyes. As this clinical image demonstrates, he had easily everting eyelids with more than 12 millimeters of vertical distraction. The lower eyelids had a delayed snapback test. Mild conjunctival congestion was seen in both the eyes with a clear cornea and no lag of thalamus. The rest of the anterior segment and fundus was within normal limits. The upper and lower puncta demonstrated stenosis in both the eyes, but it was amenable to cannulation by 26 gauge cannula, and irrigation was freely patent. Schirmer's demonstrated 20 millimeters of wetting at the end of 5 minutes. So with this examination and his short stature, his stubby neck and obesity, we asked him some retrospective questions. If he had any history of eversion of eyelids during sleep, that his son denied. There was no history of snoring, nighttime awakening, or daytime sleepiness. But he did have history of untreated depression with suicidal tendencies. So with this, we came to a diagnosis of both eyes floppy eyelid syndrome with punctal stenosis. So he was planned for an upper and lower eyelid pentagon excision with punctal dilation and mini monoca stent placement, right followed by the left eye. And he was advised psychiatric and ENT clinic consult simultaneously. So incision was taken at the medial 2/3 and lateral 1/3 junction. And finally, 11 millimeters of full thickness upper and lower eyelid was excised. Post-operatively, he was given a standard regimen that included steroid antibiotic drops 4 times in a day. And for 7 days, he was relatively asymptomatic. 3 weeks after the first surgery, he came with recurrent watering in the right eye with foreign body sensation. And he had developed a pyogenic granuloma in the site of the previous surgery. So it was planned to be excised as it was quite elevated and rubbing over the ocular surface. Post-operatively, he was started on tapering steroid drops and lubricating eye drops. Left eye surgery was deferred for now. 20 days after this surgery, there was no relief in symptoms. Right eyelids were well opposed, conjunctiva was healthy, cornea was clear, punctum was normal size, irrigation was freely patent, but there was a mild delay in fluorescein dye disappearance test. He was at this time advised orbicularis squeezing exercises and lubricant drops are to be continued. Again, 1 month after this, there was no relief in symptoms. His examination was status quo. And at this time, he was given the option of lacrimal gland needling, for which he was keen. So lacrimal gland needling was done under topical anesthesia after inserting the universal speculum. 5 needle entries were given in the palpebral lobe, avoiding any major vessels. Monthly sittings like this, 3 such sittings were done. And after all of this, that is 7 months after the first initial surgery, he reports marginal improvement in symptoms. Examination is status quo. He does present with mucoid discharge, but he wipes it most of the times that he comes to the clinic. And he was reinforced at this time to again visit the ENT and psychiatry clinics that he had not yet gone. So the challenge in this case was I'm starting out in my clinical practice, and after following all textbook advices of everything, getting a proper optimal surgical outcome, there was still no patient satisfaction. So thank you for your patient listening. And the questions to the panelists are what more can be done in this case or could have been done? And the second more important question, was anything needed to be done at all? Thank you.
Good case. Maybe expert panelists, if you want to comment. Adit, Vidyashankar sir.
Yeah, Richa, very well presented. It is actually commendable that you've got this up on this forum and you're highlighting fallacies that we have in our existing oculoplastic practice. So everyone usually tries to present their best cases, but you have been brave enough to present something which actually none of us know how to manage exactly. There's no fixed protocol for this. One thing which you correctly mentioned, what I do for these cases is I refer them to my closest competitor. That is the first thing that you will learn with experience. As you mentioned that you are starting out in your practice. So as years pass by, you will try not to do much for these cases. Just go step by step for symptomatic relief. Another thing, what I have noticed in these cases is that the watering is secondary to inflammation of the ocular surface because of lax eyelids and constant rubbing of the eyes, and also because of using handkerchiefs again and again. So the first thing which I advise these patients is to stop touching the eyes, and if they want to drain off the excess water, I just tell them to dab at the outer corner. Second, sometimes open cancel surgeries do help in cases of floppy eyelid syndromes. So open cancel surgeries, as in where you have to disinsert the common cancel tendon laterally and reinsert both the upper and lower cancel limbs of lower cancel tendon separately. So that is known to help in some of the patients, but there's no fixed answer to that. Third thing which can be done or which has been attempted is seeing if there is a strip of conjunctiva or conjunctivochalasis in these patients, and sometimes conjunctivoplasty can also add to it. So that all these patients, usually I approach them step by step and do not do all the things at once as you have done in your case, and just psychological support is more important, and treating the baseline pathology most of the times, which is obstructive sleep apnea. But overall, I think it was a very well documented case and really commendable job.
Thank you. Dr. Vidyashankar sir, please.
Yeah, very well presented, Dr. Richa. I would also go with Adit saying about the wiping of tears. Wiping of tears, we generally tend to wipe it down. So the lower lids tend to become a little more lax than what they are already. Second, probably instead of getting the same type of results in both the eyes, upper lids, as you have taken the wet, sometimes cosmetically, it might be better off to take a LTS, that would probably make the cosmetically good. And the reason that we know about the irritation and all of that is basically the lids is not being well opposed to the globe. So LTS probably will be able to, if you consider that the medial and the lateral canthus is a little forward in both the eyes, however much you tighten the lids, it will still not, the tears would not flow on the ocular surface. So the better option would be to disengage the canthus and take the lower lid up and posteriorly, upper lid down and posteriorly. This way the bucket handle movement of the lids would be a little better. So the tear, this, and you are correctly going that you are getting a psychological and other this also, because more and more surgeries done for this patient, they generally go into the cocoon and they would not want to visit any other doctor for the fear that it might fail. So you would need to treat on all aspects for this patient. Other than that,
another query. Okay, sir, go ahead, please.
Go ahead, ma'am.
I wanted to ask whether his whatever psychotic treatment, does it have to do anything with this?
He's not on treatment. Sorry.
So you said that he is taking some treatment?
No. He had depression and even suicidal tendency. We had advised him multiple times to visit a psychiatrist, but he still hadn't.
Because all of these medicines are much more dry than what it actually is.
Okay, good case, Richa. Congratulations, nice presentation. So we'll go to the next case, which is the last case of the plastic session, which is going to be presented by Dr. Nirav Raichura. Meanwhile, Dr. Nirav, you can start sharing your screen. He's an oculoplasty surgeon practicing in Mumbai, trained from Shankar Netralaya. And for discussion, we have our experts, Dr. Mangesh Dhobekar from Ganpati Netralaya Jalna and Dr. Neha Srirao from Pune. So this is basically a total SN gang, it seems. 3 of them are from SN trained. So yeah, over to you, Nirav, for the presentation. Your slide is seen.
A very good afternoon to everyone. Am I audible?
Yes, you are.
I thank the MOS Scientific Committee to give me the opportunity today. So I'll be presenting a case of recurrent orbital pleomorphic lipoma. So this 45-year-old gentleman presented to me with complaints of gradually increasing yellow-white mass arising from under the right upper lid since last 6 months. He had no other ocular complaints. Clinically, the mass appeared to be well-defined, yellow-white, non-tender, and in the epibulbar region of the upper and lateral part of the orbit. Magnetic resonance imaging of the orbit showed a fat intensity lesion in the superolateral right orbit involving the epibulbar space and was also seen infiltrating the right superior rectus muscle, which can be well seen here in this T1 weighted axial image. So we decided to take up the patient for surgical debulking. It was decided to do a debulking such that we remove as much mass as possible without damaging the superior rectus muscle. During the surgery, the mass was a very good plane of dissection was obtained all around, except at the insertion of the superior rectus muscle. The superior rectus insertion and the belly were left untouched. So this was the patient's picture at day 1 post-op, and this is the patient's picture at week 5 post-operative. Histopathologically, the lesion appeared to be predominantly showing adipose tissue with scant fibrous tissue, along with typical multinucleate giant cells with nuclei arranged in floret pattern, which was suggestive of a pleomorphic lipoma. So the patient did well for about over a year, after which he presented to me with a recurrence. About 6 months later, he presented a more aggressive looking yellow-red mass. By this time, he had developed right-sided hypotropia along with restriction of elevation and diplopia in primary gaze. So a resurgery was planned. A repeat magnetic resonance imaging showed a similar fat intensity lesion along with probably some amount of fibrous tissue. The second time, this time the surgery was a little more challenging. It was difficult to find the right surgical planes. We went on with gradual dissection, layer by layer, trying to protect the superior rectus muscle and exposing the muscle first before excising the mass. So here you can see that as I'm trying to expose the superior rectus muscle, the rectus muscle is seen to be engulfed within the mass. Here you can see some of the fibers of the superior rectus muscle, which are seen being engulfed into the mass. So a gradual dissection was done and a debulking was done. Histopathology was similar to the first time, and immunohistochemistry showed it to be CD34 positive and negative for MDM2 and CD68. These are the patient's pictures after the second surgery, 1 month post-op. The patient does not have diplopia now. He is orthotropic in the primary gaze, but the elevation is still restricted. So pleomorphic lipomas are rare orbital tumors. Only 8 reported cases are there in literature, with only 1 case with diplopia and involvement of the lateral rectus muscle. To conclude, benign lesions can be locally aggressive. Complete excision may not always be a feasible option. So the question here is, what next? We need to explore other modalities of treatment also. I am sure this patient might have a second recurrence. So what do we do next for this patient is my question to the experts. Thank you.
Great case, well managed surgically, and we hope for the best possible result and absence of any recurrence now after the second surgery. So over to the experts for their comments. Dr. Mangesh.
Yeah, am I audible?
Yes, you are.
First of all, I would like to congratulate Dr. Neerav for sharing such a rare and nice and interesting case, basically. I would like to have some comments upon this. I have never come across pleomorphic lipoma so far, because these are the so rare cases, and we routinely come across many fatty lesions like the prolapse orbital fat, because at the first presentation you showed one case that was suggestive of a simple prolapse orbital fat, but little it was superior. Most of the time it comes from the supratemporal orbit, and the color of the lesion is typical yellowish. We know that how it looks on the closer examination. And I think that the cases like this, that the pleomorphic lipoma or the liposarcoma for that matter, must be frequently not diagnosed at all, or might be very much misdiagnosed. And here again, it lies the importance of the histopathological examination of every tissue you remove out of the body. And second thing is that we, even in OPD, we come across the many lesions. The common one being the dermalipoma and the prolapse orbital fat, and we should not more emphasize the importance of the imaging in all such cases, because most of the times we feel that it is just a prolapse orbital fat and we go ahead with the excision. Because I had one similar case, the patient came with a lower lid prolapse orbital fat, but on the examination and the palpation, I found there is something nodular lesion, and just I ordered the imaging, and it was something atypical, and then I did the incision biopsy. It came out to be a non-Hodgkin's lymphoma. So it is the very important point of the we should have imaging in all such atypical cases. And as you have presented, that was what next can be done, because much I think has been done, and even the second surgery would have been a very challenging, because we know that whenever the post-operative cases, there are the much of fibrosis, and removing or the debulking is very, very difficult in all such cases. And pleomorphic adenoma, pleomorphic lipoma, basically, it is a very locally aggressive. And even in the literature, it has been stated that the wide local excision with the clear margins. But as you have stated, in the orbit, it may not be possible to have a clear margins. because even the fatty tissue and the residual might be there, and there are again, hopefully there might not be any recurrence, but we are whether we should give for the adjuvant treatments like the radiotherapy or the IMRT. I think we should explore all these options. And as you are rightly ruled out the liposarcoma component, because the liposarcoma MDMT is negative, and had it been a liposarcoma, then I think exentation would have been the way to go. But this is being the benign, we can have some locally or the globe salvaging treatment here, post adjuvant or the new adjuvant chemo radiotherapy, basically not the chemo one. Might be we need to explore. Thank you, Nirav.
Dr. Neha, please.
Excellent documentation and very well presented, Dr. Nirav. Pleomorphic lipoma, very, very rare entity. And I think one of the main factors causing the recurrence in your case would be the involvement of the muscle, because usually it's never intramuscular, it's always in subcutaneous tissue. I mean, one of my doubts, I mean, when you think and reflect, one of the points that I can make a comment on is considering the histopathology and the IHC was something, you know, on the lines of liposarcoma, like Dr. Mangesh mentioned. Probably we can think of radiotherapy in case there is a recurrence again, and you know, probably we can discuss it with the radiotherapist and see if instead of surgery going through surgery again, we can offer a radiotherapy to the patient.
Correct. That was one thought that came to my mind. But then there are certain reports in literature where not for the orbital lesions, but lipomas elsewhere, where radiation would cause a probably, you know, cause a conversion into a liposarcoma. So since we have here a case which is still not a sarcoma, you know, MDM2 negative, whether doing that, like we would be inducing some kind of a secondary change into the lipoma was my concern, you know, and that's why though I discussed with the patient about radiation, we did not go ahead with that.
Also, I think excision with clear margins would be the ideal scenario in the case, but because it is involving the superior rectus, you are not able to do that.
Correct, correct.
Nirav, what was the extent of the superior rectus involvement intraoperatively you saw?
Pardon me?
What was the extent of the superior rectus involvement intraoperatively in the second time?
So the extent, like I said, the insertion was completely engulfed. There were certain areas where I couldn't excise the mass, you know, I couldn't excise it completely because it was seen infiltrating all around. So it was quite extensive. To as much posterior as I could go, I could see the lesion everywhere was infiltrating into the muscle.
So even the taking out the superior rectus, even that may not be a viable option.
Correct, correct. Yeah, because here at the second time, the patient's chief complaint was diplopia, and I didn't want to damage the muscle and, you know, make that diplopia permanent. So
yeah, challenging cases really.
Okay. Dr. Watway, whether we should wind up the session now?
Yes, yes, sir. I would like to invite, I would like to ask for the concluding comments from our chairman and co-chairman, Deshpande sir and Pakhre sir, please.
Thank you to all the speakers, experts, panelists, and colleagues who have attended this session. And especially thanks goes to the presenters, the young presenters who has given the new access to the new knowledge of this. And the symposium of oculoplasty is really a fruitful thing for us, to all seniors and juniors. Thank you. I will hand over a little bit to the Dr. Pakhre also to give some comments. Okay.
Thank you, sir.
Yeah.
First of all, I congratulate Maharashtra Ophthalmic Society and Scientific Committee for organizing such a midterm conference, which this concept was not in our tenure. This facility was not there at the time of our tenure. So all the young these presenters and panelists have done their job nicely. I congratulate all of them. Thank you.
Thank you, everybody. And I conclude the session and hand over mic to the next session.
Thank you, sir. Thank you so
Thank you,
much.
sir. Thank you very much.
Thank you so much,
Thank
Dr.
you, sir.
Aditi and Dr. Zabar ma'am, for moderating and importantly also coordinating this amazing session. I think the oculoplasty was really interesting. I think each session of this meeting was equally interesting. And as Aditi said yesterday, I think probably one of the times when oculoplasty got the same hall as the cataract.
Yes.
We would like to give definitely more visibility to also oculoplasty in the annual conference as well. You guys are all doing amazing work. Thank you again. Thank you so much, Dr. A. Deshpande sir and Dr. Pakre sir for being the chairperson. And thank you to all the young presenters, young panelists, and the senior experts for your comments also. So now we go to the last sweet and very short part of this midterm conference, the MOS Midterm Young Turks. So the MOS Midterm Young Turks actually, or MOS Midterm, started as a small concept during the GBM that we had last year in Nasik, snowballed into small concept, and then it became bigger and bigger with Dr. Bide sir, his inputs, all the scientific committee, managing committee inputs, and we actually have this opportunity to have a full 1.5 day midterm conference of MOS in the form of MOS Midterm Young Turks. And this became a conference which was full-fledged with all subspecialties. We had included all 9 subspecialties, including an exciting young ophthalmologist national video festival, which was very well attended yesterday. Of course, the aim of this midterm was to give platform to our young colleagues, our young stars, to encourage them. And I'm happy to share that we had 2,050 registered delegates for this conference, which was actually quite a big number. And we had almost 200 faculty. The cherry on the cake was majority of these faculty members, which is 100% of the speakers and 50% of the experts were young ophthalmologists. Many of them got their first ever platform at the state conference level. And the theme of the conference, which was case-based discussions, also delivered to its potential. So therefore, it was full of learning for everybody. And we really thank all the senior chairpersons, moderators, experts for amazing learning. We thank all the scientific committee, managing committee members. Special mention about all the chief coordinators of each session who have done very meticulous work. I am personally very thankful to Dr. Santosh Bide sir as president for being a great guide and support. He believes in his team wholeheartedly always and has given us all the support. Also very, very thankful to Dr. Anaga and Dr. Vivek sir for their support as always. And special thanks to Aditi as secretary. I think she is ever so sincere, hardworking, and always ready to contribute with never say no attitude. Thanks to all the delegates who are actually the core of the meeting. And I would like to actually now invite Dr. Bide sir to share his thoughts as the president of our August MOS.
Good evening, Vardhaman. Thank you. First of all, this midterm Young Turks, all credit goes to Young Turks of my team. And first of all, my Young Turk, number one, Dr. Vardhaman Kankriya, who is the chairman scientific committee of Maharashtra Ophthalmological Society. He has proved himself the organizational capacity and the scientific capacity. So I'm sure that he will work as a member scientific committee also and as a chairman scientific committee also in future. So all the best to you, Vardhaman, and thank you once again. Dr. Aditi, who was always there, and she has helped us in. There were a lot of hiccups initially, but Aditi was always there helping all of us. My entire scientific team and managing committee team, all the coordinators of all the sessions. In fact, the concept of involving everyone, all the ophthalmologists from all across Maharashtra was our theme, and giving platform to the young, talented ophthalmologists who are upcoming ophthalmologists. They usually do not get podium presence in the actual annual conferences anywhere. So we thought that as an association, we should give them opportunity to showcase their talent and showcase their expertise to all of our fraternity. And I am happy that we could achieve that 100%. The video competition, 2-minute video competition by UC was the icing on the cake, and everybody enjoyed. And in fact, the innovation, the concept of innovative videos was very well appreciated. And I assure you that we are going to have a full session on ophthalmology innovations called as Innovation during our annual conference of Maharashtra Ophthalmological Society at Kolhapur in October 2023. So with this, I request everybody to register for our annual conference at Kolhapur. As you all know that Kolhapur is the tourist attraction also. We all know the Kolhapur's temple and all other things where we can visit. So please attend Moscon 2023 in large numbers, and do suggest us, give us suggestions so that we can improve, we can implement those new ideas during our annual conference also and during our monthly activities also. Your valuable suggestions and encouragements will definitely help us deliver better and better programs in the future. And thank you once again, all the audience, all the participants, all the coordinators, all the scientific managing committee members, all the mentors, all the advisors for guiding us and helping us to make this midterm MOS conference a huge success. Thank you.
Thank you so much, sir. Thank you very much. Any of the past presidents would like to comment in short? Then we will continue, please.
This is a nice session, that is I will say, and this should be continued every time, and more young people should be given the chance to speak, because that is the second row of our mass who is going to achieve the dais in future.
Yes, that is our future. Future generation should be given more through. And now
Young
we have
generation
created
is our future.
Yeah, we have created a template, and on the same templates, the future conference, midterm conferences can be done in future.
Absolutely, sir. Dr. Marathi, sir.
Hello, good evening all.
Yeah.
I think I've been enjoying this conference since yesterday. It is a wonderful conference, and the concept of midterm along with online platform, I think blessing in disguise in COVID era, what we learned and we gained this Zoom platform, which was that way not known to most of us, though it was existent. We have utilized that totally, and if it were been the physical conference, probably would have affected the main conference, and even the sponsorship, everything would have got affected. So we thought that it should be online, and I think that idea has worked. Other thing is we are given the chance to youngsters across the country. That is the first time podium presenters was the great idea by Dr. President Santosh Bhide, Vardhaman, and each member of Maharashtra Ophthalmological Society. And even in video competition of yesterday's session, that was the topmost session of our conference. Yesterday also I said, like the Cricket World Cup, main World Cup, and Under 18 World Cup. So this was like Under 18 World Cup, where all the youngsters got the opportunity. And in presence of seniors as moderators and panelists, their expert comments were there. But what I've seen that even youngsters are not behind. They are at par with seniors. I think when next generations they come with new ideas, new innovations, new studied material of each and every section, every aspect of ophthalmology. And by that, even we seniors also learn. And even technology driven thing, seniors like Dr. Deshpande sir, Dr. Pakre sir could join. And I think they are also interacting with the youngsters. This was the great successful conference, I must say, and the great milestone in the history of MOS. I must congratulate Scientific Committee and Maharashtra Ophthalmological Society for this particular success. And we are raising the bar every year, year by year. And this process must go on. I think Maharashtra is one of the biggest states in India. Not one of the biggest, it is the biggest state in India. And I think in ophthalmology also, we are in diversity. So we should take this ophthalmology beyond to Maharashtra, that is at national level and at international level. The scientific content of this particular conference was also of international repute, I must say. So kudos to Team MS. Wonderful work done by each and everyone. Congratulations to each and everyone. Thank you for the opportunity given to me and most of the participants, youngsters as well as seniors. Thank you. Thank you so much.
Thank you very much, sir. Dr. Agarwal, sir, who is our president-elect next year, would you like to, sir, say something?
Yes. Very good afternoon to each and everyone. Really, the very idea of this conference is giving platform to the newcomers or the novice surgeons that I like the most, and which has successfully done by Dr. Bhide, Dr. Vardhaman, and Aditi. They have taken a lot of efforts for last from the Saturday evening. I am watching all the videos and the sessions, and I found that the young generation have a lot of talent. They have showcased their talent in a very well manner, and it was very well discussed with the young experts as well as the senior experts. And there was no didactic lecture. That was also a big idea I found, and that is little bit boring in the conferences, didactic lectures. And these case presentation and discussion really give the take-home messages for our young as well as senior people who are working in the fields, and that will help in your day-to-day practice. So it's an amazing conference, and kudos to the MOS team, especially Dr. Santosh Bhide, Vardhaman, Aditi, and all the team members. Thank you very much for giving me the opportunity. Thank you.
Thank you, sir. Anybody else would like to share probably their experience, and then we will conclude. Dr. Bhide, sir, anything you would like to add?
As everyone has said, appreciation, we are grateful to you for appreciating, but there is a saying that compliments don't help in improving. So if you want to improve, do suggest us. Do not give any give us positive suggestions, so that we will keep on improving. And dear Santosh, you are the president, incoming president. So we have created this template for the midterm conference, and Vardhaman is going to continue as a chairman scientific committee next year also. So I am sure the next year also it will be a great midterm conference. We are really lucky to have the technology with us. Technology has really helped us, and I think Zoom platform is one of the technology which is something better out of COVID experience. Because of this, there is no geographical barrier. You can attend all the virtual conferences from anywhere in the world. In fact, I could attend this, though I was in US. I'm still in USA, and I am able to attend this conference.
Dr. Bhide, sir, has not slept
a physical interaction
for last 2 days because he reached US and then the conference started.
Yeah, so, but it was really nice.
And I've been attending from Gujarat.
Yes, sir. Yeah.
And the young generation is really talented. They are tech savvy. So we must tap their potential. We must make use of their technical expertise. And of course, they are updated in their knowledge also. So overall, it's going to be a great learning experience. So for every one of us. Absolutely. So with this, I would like to thank again our chairman scientific committee, Dr. Vardhaman, Dr. Aditi, Dr. Anagha, Dr. Vivek, Dr. Viral Shah, all the managing committee members, and scientific committee members for their full commitment. And I'm really blessed to have such a great team. Thank you once again.
Thank you, sir, for being a great team leader. And at the end, we would like to also thank Mr. Sunil, who has been the technical great support. He has given us a glitch-free conference. So thank you so much, Mr. Sunil, for being there. Yes. Thank you again. And we are also very thankful to Ento team for fully supporting this midterm event. They have always come forward whenever MOS required their help. Thank you to Mr. Masurkar, sir, and Nikhil for always being there as a strong support to MOS. Thank you.
Yes. Sunil and Entod are the two backbones, technical support. Without that, this would not have been possible, actually.
Great.
Thank you, Sunil.
Yes. So I think with this, we conclude officially the MOS midterm Young Turks. And we will see you again very soon with a lot of MOS activities which are happening on both ophthalmology and beyond ophthalmology front. Thank you.
Yeah. So we are going to have a photography contest. The theme will be wildlife animals. In fact, we are going to have a photography workshop by one of the famous photographer that will be on 10th of June in Pune. And we will definitely have similar photography workshops. Maybe we will try to have one in Solapur and one in Aurangabad. I'm not sure, it will depend on our sponsors, but on 10th of June, we are definitely going to have a photography workshop in Pune. So do participate in those photography activities as well. So,
Thank
and
you.
We are going to have a sports event on 10th and 11th of June in Pune.
Absolutely.
MOS sports event.
All right. Okay, sir. I think with that, then we will conclude. And Dr. Bide sir also should rest. And we will see him back with renewed vigor when he's back to India. Chala. Thank you. Thank you, everybody. Thank you. Thank you. Thank you, Aditi. Thank you.
Okay.